Chalo, let's begin. Not the sacred games, but the scared games, which we are really scared of. Neuro, right? So I am the Guruji for you for the next 3 days, but you need to give a lot of balidan for that work. Okay, a lot of topics which we'll be covering in next few days will be one stroke, second will be the myelopathy and the myo and the neuropathy. Okay, right? So let's begin and let's start it. Okay, first of all, something which we need to take out again is the JCB machine to dig out the topic of neuro or the CNS. It's a very important one. And what does the CNS stand for you? Central nervous system. As I told you in the very first class, okay, common, neuro, scare. So you see a neuro patient and you get scared of it, right? So don't worry, we are going to study it, right? Chaliye, let's start with the very first topic for the day, that is the cerebrovascular accident, being commonly abbreviated everywhere as the word CVA, also known to me as a term stroke. Okay, let's try to begin with this. Remember this, first foremost thing is the definition part of it, right? The definition part is crucially important at this juncture, because if you understand the definition, I think so we'll be able to understand the pathogenesis of the disease a lot. Now, how do you define a patient of CV or stroke? It is defined to me as abrupt onset neurological deficit, abrupt onset neurological deficit due to focal vascular cause. But the condition apply here is or infarction is demonstrated. I'll repeat my words again. First of all, remember this, CV or stroke is something is defined to me as abrupt onset neurological deficit due to a focal vascular cause, or infarction is demonstrated. This can be radiological, of course, by doing a neuroimaging, or can be pathological later on also. So remember this fact again, that this abrupt onset neurological deficit is for the more than 24 hours in duration. Okay, so the duration of the deficit should be more than 1 day or 24 hours. Then we try to classify it under the heading of stroke. Okay, because if you remember, there is a younger brother in the family also known to me as the transient ischemic attack. Transient ischemic attack being abbreviated to me as a term TIA, right? Same thing again, but the important factor is in this patient there is reversal of symptoms within 24 hours time. That's why the word transient has been coming for it. Okay, I can use the word complete reversal to explain it better. That means the patient has recovered completely from the deficit within 24 hours time is known as a TIA. But conditions apply again. No infarction on imaging. That's very important thing to put it as a case of transient ischemic attack, that there is no infarction seen in the patient on imaging. Okay, right. I know some people are always on the spot logging into the app, not 5 minutes prior. Then they realize their app is hanging because there's a lot of already apps there in your mobile phone. They all are fighting with each other. Right? I'm waiting for you, don't worry. Okay, let everyone join. Are you guys there with me? Or am I speaking to the room alone? Okay, repeat. Yeah, some people are not getting the live option. I know that. When you have so many apps in your mobile phone, no, of the same nature, they all start fighting with each other at the last minute. So my advice will be to log in at least 15 minutes prior and see it's really working or not. Okay. Yes. So I'll just repeat. Some people have joined late. Okay. Cerebrovascular accident or stroke is defined to me as abrupt onset neurological deficit due to a focal vascular cause, right? That is for a duration of more than 24 hours. That's very important. That your patient comes to you with hemiparesis, a speech language disorder that we studied in the season 1, that is aphasia. That is a neurological deficit. And there is a vessel of the brain supplying the blood, and that has got diseased in a point focal for a duration of more than 24 hours, right? So that's very important thing. Or infarction is demonstrated. Now the word infarction goes for ischemia infarction. That's again a part of definition now, because sometimes you find that the patient might have recovered but there is an infarct on an MRI. I'll always say this patient had a case of stroke, right? Same thing if it completely reverses in 24 hours time, that is known as the word transient ischemic attack or TIA. Okay, and most important thing, in a patient with TIA there is no infarction on imaging seen, right? Let me repeat it for the third time. I'm repeating it for the third time. Okay, stroke CVA, I'm just trying to define it. It is defined to me clinically as abrupt onset neurological deficit due to focal vascular cause whose duration is more than 24 hours, right? Very important. Or the infarction is demonstrated in the patient. That's very important again. Sometimes I've seen clinically patients who come to me with some deficit and they recover from it completely. But on the MRI or a CT, they come back to me with an infarct. I should not put them as TIA. I should define them as a case of stroke. Or infarction is demonstrated. That's again important thing. Transient ischemic attack, there is complete reversal of symptoms within 24 hours time, or there is no infarction seen on imaging. That's again very important thing. Okay, so let's move in from here now. Okay, we're taking a lot of time for this. First of all, important concept which we need to build up: why does a TIA happen and why does an infarct happen? You know, the cerebral blood flow, that you know for the brain, as of course, is different for different types of material inside. Like for example, I want to see the gray matter or the white matter. Okay, gray matter and the white matter. The gray matter, as you know, the cerebral blood flow is approximately to the amount of 75 ml per 100 gram of the brain tissue it is trying to perfuse per minute. That's very important thing, right? While the white matter is around 35 ml per 100 gram of the brain tissue that is trying to perfuse per minute. So who gets the larger amount of blood? It's of course the gray matter, and maybe the second one is the white matter. So we're talking about the cerebral blood flow pattern now. But important MCQ which keeps on coming is this: the average cerebral blood flow that you see, the average cerebral blood flow that you find is roughly 54 ml per 100 gram of the brain tissue per minute. So if we take the average part of it, it comes out to be somewhere 54 ml per 100 gram per minute. Now why this kind of thing and thinking process is really important? Because we know this, that if the cerebral blood flow is less than 20 ml per minute, now the cerebral blood flow has come down from the average of 54 and it has gone below 20, then in that situation in the brain we might see ischemia, correct? But we will not see infarction. There is ischemia without infarction if the cerebral blood flow is less than 20 ml per minute. Okay. But if the cerebral blood flow goes below 16 to 18 ml per minute for a duration of somewhere 1 hour, then in that case we find infarction. So first there is ischemia and then there is an infarction coming in the picture. Okay. Now if the cerebral blood flow reaches a magnitude of 0 ml per minute for a duration of somewhere 4 to 10 minutes, then we come across a catastrophic situation, that is the neuronal death. Okay. So we find few facts now with us that the cerebral blood flow pattern, okay, the cerebral blood flow pattern that you find is variable. Average cerebral blood flow is 54 ml per minute for 100 gram of the brain. If it goes less than 20 ml per minute, then we find ischemia without infarction. If it is 16 to 18 ml per minute for 1 hour time, you find infarction. If it is nil for 4 to 10 minutes, then you come across CVA or stroke is defined to me as the abrupt onset neurological deficit due to a focal vascular cause. Okay. And the most important thing is that it is for a duration of more than 24 hours or 1 day. That's very important thing for defining it. Right? Or infarction is demonstrated on the imaging that you have seen in the patient, right? Am I audible to all of you? Am I audible, visible? Hello, hello, hello. Am I audible and visible to all of you? Okay. There is a younger brother in the family of stroke that is known as the TIA or the transient ischemic attack, which is defined to me as a complete reversal of symptoms which has suffered in a patient with a neurological deficit within 24 hours, and no infarction on imaging is seen with the patient. Okay, that's again very important thing. Now the basics are back again. The pattern of the blood flow in the brain, the cerebral blood flow to the gray matter to the white matter, The gray matter, the cerebral blood flow is going to the magnitude of 75 ml per 100 gram of brain tissue per minute, and the white matter is around 35 ml per 100 gram of brain tissue per minute. Okay. Average cerebral blood flow, if I take in the brain, average is around 54 ml per 100 gram of the brain tissue per minute. Now, why we need to know these values? Because depending on the cerebral blood flow, we get ischemia and infarction. If the cerebral blood flow is less than 20 ml per minute, we find in the brain ischemia without infarction, right? If the cerebral blood flow is 16 to 18 ml per minute for an hour duration, then you find infarction. If the cerebral blood flow is 0 ml per minute for 4 to 10 minutes time, then you get a neuronal death. Now, this is something very, very important and crucial to understand, because sometimes we come across patients with a cardiac arrest. To revive the patient, you always have to do a chest compression first, because if you compress the chest, the heart will revive and also the brain will revive. Because if the brain doesn't get any kind of blood for at least 4 minutes time minimum, then the brain damage, or a patient might land up with a hypoxic encephalopathy or a vegetative state. Okay. Only one page to leave, not too many. Now remember this, if I want to see this as a try, don't write this thing. On the top is a topic that we discuss, neurology. To understand it better, there are two main parts of neurology. One is the neuroanatomy and the second wala is the neurophysiology, right? So if you understand the neuroanatomy, neurophysiology, obviously the neurology will be very, very easy to carry forward as a topic. So let's go into the basics of the brain. What I'll do here is, we'll try to see the brain and we'll like to see the neuroanatomy part. That means a particular area of the brain, what function is it really doing? And then looking into the neurophysiology part, right? What function it is doing? And if something is wrong in this area, the function is impaired, what kind of deficit in the patient that you see? So it's neuroanatomy, neurophysiology, and then find neurology in a form of a deficit. Okay. For this, what we'll do, we'll start with the anterior-most lobe of the brain, that is the frontal lobe or the frontal cortex. Okay, the frontal lobe or the frontal cortex. The frontal lobe has got one more very, very important area inside it, that is known to me as the primary motor area. Can you tell me the numerical number of this area? What is the numerical number of this area? Can someone of you type on this chat box and tell me what is the numerical number of this primary motor area in the frontal lobe? It's area number 4. Okay. Now, important thing is this, that what does it really do for me? Here we find the origin of the corticospinal tract. CS stands for the word corticospinal tract. Okay, the abbreviated name for corticospinal is CS. Corticospinal tract starts here. We have tried to discuss in the previous sessions also that the corticospinal tract is also known to me as what? The pyramidal tract. Okay. Now I'm sure that your physiology by Anupam ma'am and anatomy by Pawar sir has been also been done. Now can you tell me, does this pyramidal or the corticospinal comes from here only or somewhere else? Remember this. The contribution for the corticospinal tract is from the primary motor area, one area. Primary motor area contributes to the formation of the pyramidal tract. It starts from there. How many percentage? 31%. So 31% of fibers which are corticospinal or pyramidal originate from the primary motor area. Very important concept. Now another area which is the premotor area. and another one is the supplementary motor area. They contribute to nearly 29% of the pyramidal tract fibers. So it's not only, remember this, corticospinal tract not only originates from the frontal lobe primary motor area, it has also got the input from the premotor area and the supplementary motor area also. Now to your surprise, there is another area which is parietal. Okay, the parietal lobe, although a sensory lobe, but will contribute, okay, will contribute to the pyramidal tract also 40%. So why I'm giving this fact, because it's a very common misconception by any student that the motor cortex only is the only source of the pyramidal tract. No, there are other sources of the pyramidal tract also. This is all from Ganong, nothing new. You all should know this. Now, when I look into the primary motor area, I'm trying to discuss this. Okay, primary motor area. I'll take you in this area. The primary motor area, which is in the frontal lobe, the area number 4. Okay. Can someone of you tell me, it has got layers in it, na? Can you type in the chat box, how many layers are there in the primary motor area? How many layers are there in the primary motor area? How many layers are there in the primary motor area? Quick answers from your end. Please start from beginning as a comment. You think this is the beginning of the class, don't worry. Good, 6 layers are there. Good. There are around 6 layers in the primary motor cortex, the primary motor area. But this pyramidal tract comes from which layer? The pyramidal tract, tell me please, the pyramidal tract origin in the primary motor area comes from which of the following layer? Out of the 6, is it from all the 6? Fill in the blanks. The pyramidal tract originates from the primary motor area, agreed. Yes, the layer number 4. Layer number 4. Okay, this is a very important thing. Oh, sorry. Is it area number 4 or the layer number 4? Betts layer, which layer is it? Area 4 or 5? You marked me wrong. Fifth, my dear friend, the 5th layer. The 5th layer has got large cells of beds inside it. Area number 4 was a topographic or the nomenclature applied for the motor area, but the layer inside the brain was the 5th layer inside it. Okay, from which the large, write it down, inside that there are large pyramidal cells of beds present. There are large pyramidal cell of beds which are present there in the 5th layer of the primary motor area, which will give rise to this kind of a tract known as a corticospinal or the pyramidal tract, which is coming down. Okay, so bit of anatomy, a bit of physiology, right? Now let's try to look it in a view that I see as a cut section, coronal section. If I want to make a coronal section of the motor cortex, which part of the body is originating from which part of the motor cortex? Now let's look at this. The lower limb happens to occupy the medialmost part over here. The lower limb happens to occupy the medialmost part over here. Then we have the trunk coming in. Then we get the upper limb coming in. And suddenly we get a hand over there. And somewhere laterally, I'm going to get the face also. Okay. And then of course the tongue will come. Let me mark these areas. The lower limb, the trunk, the upper limb, the hand, the face, and maybe the tongue area, which is down below laterally. Okay, yeah, someone pointed out the right name for this. It looks like a ghost, which is hanging upside down to scare me. The name of a ghost is known as homunculus. So there is a homunculus which is there somewhere inside the motor cortex, and the pyramidal or the layer of bits is there somewhere where which the pyramidal of the corticospinal tract will originate. Okay. Now something which we can easily understand out of this diagram, the face and the hand have got a larger area of representation compared to rest of the body. Why? Because we do fine skill with our hand in the face. So write it down. Finer the skill that a particular part of the body is performing, larger is the area of representation in the brain. Larger is the area for representation in the brain. So finer the skill, larger is the area of representation in the motor cortex. Okay. Now, apart from this, there are other areas, and this part, very, very important. This part, which is the lower limb part, is a motor cortex for the lower limb, is near the center, is referred to me as a paracentral lobule. So this is something which is remaining near the center, is known as a paracentral, and it's a motor cortex for the lower limb fibers. Right. Now let's move into another area, which we know as the premotor area. So the word is not motor anymore, it's known as a premotor area for me. And the number for this area, can someone of you tell me in the chat box? Okay. What is the number for this area? Premotor area, someone of you knows it. It's area number 4. Oh, sorry, area number 6. Area number 6 is the premotor area. Okay. Now, it basically gives origin to the extrapyramidal tract. The pyramidal tract we have tried to understand through the corticospinal, while this one is the extrapyramidal tract which originates from the premotor area, area number 6. Now when I see the function of this area, very, very important thing, if I want to see the function of this area, one function it tries to serve every time is planning and execution of a particular movement. How are we going to do it? Correct. And also it's important for sequencing of a particular movement. In what sequence do I really do it? Okay. So there are two main things it tries to serve the premotor area, area number 6, through a tract which is not pyramidal but outside the pyramidal, known as the word extrapyramidal. Okay, let me check your long-term memory today with some priming, of course. Just imagine this. This is a pen in front of me. I start my hand from there, correct? When I reach the pen, I stop. I start my hand, and when I reach the pen, I stop. There are two pathways in the basal ganglia which are trying to work in this direction, to initiate a movement and to stop a movement. Can you tell me who initiates the movement? Who is someone in the pathway in the basal ganglia? We discussed in the Parkinsonism chapter. Some pathway, if you remember. Okay, some pathway na. There are two pathways in the basal ganglia regulated via dopamine. Yes. Which pathway am I talking about? Yes, very good. Your long-term memory is intact. Long-term because it has been many months. Okay, direct, indirect. Good. Now you know the basics. Direct, indirect pathway are going to initiate and stop the movement. Okay, so in a nutshell, if I want to tell you again, the direct pathway, as I told you earlier, was a stimulatory pathway. Yes, while on the other spectrum, the indirect pathway happened to be what? The inhibitory pathway. To start a movement direct, to stop it indirect. Okay. Now, something in the previous lectures which I did not touch upon at that time, I kept it reserved for today, was what are the sequence of the areas which are in a pathway. As the name suggests, it's a pathway. It has to travel from one point to the other point. And what are the chain of the or the areas coming together to form a direct and the indirect pathway. Okay. Let's try to write a mnemonic first, and then we'll be it's very easy to recall it, right? Write it the mnemonic first. If you can take a one page for this work, it will be excellent now. Okay, so just take a full one page for this, take full one page for this one, and then we'll try to write these pathways and try to recall them. Come straight, get into thalamus. Okay, so come straight, get into thalamus. Okay, that is a thing that we try to arrange the direct pathway into one. Now, why did I mark this as red? Because that alphabet C is a part of the mnemonic to remember cortex. Okay. Then in the sequence, we get S, straight. Then stands for the word striatum. Okay. Then we have the next structure, get into, G and I. G stands for globus, P stands for pallidus, okay, and I stands for interna, globus pallidus interna. And then finally, where do we reach? We reach our final station, that is the thalamus. Okay, so come straight, get into thalamus. Okay, remember this concept. The main action of the direct pathway, if you remember in the previous lectures of Parkinsonism, we have tried to discuss a bit of anatomy also, basal ganglia. If you remember the striatum, globus pallidus, all these were structures which were in the basal ganglia, and somewhere medially was the thalamus. Now, what does the thalamus finally do? It will send a signal back to the cortex to work. That means it's a stimulatory pathway. So whatever my brain decides to do, there has to be a signal from thalamus to work for it or not. Okay. You know what happens? Cortex stimulates the striatum. Okay. Cortex stimulates the striatum. Striatum works more. It will inhibit globus pallidus interna. Okay. And in turn, there is no inhibition on thalamus, and thalamus works more. I'll write it down like this. Just write this concept: striatum and globus pallidus. Whenever they give a signal outwards, they always give what? Inhibitory signal. Striatum and globus pallidus. Okay. Striatum and the globus pallidus. Okay. They always give out a signal which is known as the inhibitory signal. Right? So cortex stimulates the striatum, striatum works more. That means it will inhibit globus pallidus interna. That means globus pallidus interna will not work. That means it will not inhibit thalamus. In a sense, it will not inhibit thalamus. That means thalamus will fire more, and the signal back to the cortex goes up is stimulatory. Okay, so the direct pathway is known to me as a stimulatory pathway. Okay. Now let's look into another pathway, that is the indirect pathway. For this, the mnemonic first. come straight, get externa, and get into the thalamus. Okay, don't panic, people who have joined just now. I'm going to repeat for you guys, so at least let me go in the flow. People who are there with me, who are enjoying the songs also, so let them study and I'll start again. Let me complete this part at least. Come straight, get externa, and get into thalamus. That is an indirect pathway. Now look at the concept. From cortex C to thalamus, we went indirectly. On the way, we got externa with us. Okay. So the mnemonic stands like this. Come, C stands for the cortex. Okay. S wala stands for the word what? Striatum. Get externa. Get externa will stand for what? Globus pallidus externa. The word N stands for what? The subthalamic nucleus. If you remember these structures, okay. And get into stands for globus pallidus interna. And then finally we reach where? Thalamus. So people who are there with me, people who are guys who are there with me can answer my query. First of all, indirect pathway will be what? Inhibitory pathway. That means thalamus should inhibit what? The cortex. That is the main thing that I need to do, right? Okay, let me see this again. Cortex stimulates the striatum, right? Have patience, please. You're behaving like some school kids, you know. Striatum increases and works more. Striatum works more will inhibit the next structure, that is globus pallidus externa. That means it will work less. What work should it do? Globus pallidus should send a signal what? Inhibitory. That means it doesn't send any inhibitory signal, and now the signal which goes to the next structure is plus. Okay. Subthalamic nucleus works more. That stimulates what? Globus pallidus interna. That means globus pallidus interna works more, and what does it do? It will inhibit what? Thalamus. Thalamus will not work. Will there be any signal to the cortex stimulatory? No, it will all be going to be inhibitory. Okay, so time for the inpatient guys, people with a disorder known as irritable brain syndrome, irritable brain, not bowel, who keep on just typing on the keypad whatever comes to the mind, like the flatus in the stool, which a patient of IBS often passes. Okay, so my friends of the IBS series, irritable brain syndrome, okay, I'm on a topic known as I'm Vinod ke Papa. I'm your father, don't worry, spammers. Cerebrovascular accident or stroke. This is the fifth time I'm telling the definition. Oh my god, my neighbors also know it now. Abrupt onset neurological deficit due to focal vascular cause, that is known as CV or stroke. So people with IBS, okay, that is the definition. This is the first slide. And the onset of the deficit is abrupt, okay. and focal vascular cause due to a vessel problem, and the duration of this is more than 24 hours or 1 day. Very, very important. Or infarction is demonstrated. Now, I'll come to that concept again, that sometime I find in my clinics that a patient has recovered from everything, but the CT MRI shows an infarct. We always put it as a classified thing as a stroke patient, because there is a younger brother in his family known as transient ischemic attack. Transient ischemic attack is complete reversal of symptoms within 24 hours and no infarction on imaging. That's very, very important thing. One, the patient has recovered and doesn't have any infarction, and the recovery happens in 1 day time, okay, is known as transient ischemic attack. Cerebral blood flow, a basic concept again. Cerebral blood flow to the grey matter is around 75 ml per minute for 100 gram of brain. For the white matter is 35 ml for 100 gram of brain. Okay. Now the point here is, need not remember as grey and white matter differently, remember it as average. Now the most important thing, how to remember this, the average cerebral blood flow is 54 ml per 100 gram of brain tissue per minute. If the cerebral blood flow is less than 20, we find ischemia without infarction. Okay. If it is 16 to 18 ml per minute for an hour time, then you find what? We find infarction in the brain. If the blood flow to the brain is 0 ml per minute for 4 to 10 minutes, then you find neuronal death. So everything here has got a reason now. Clinically, when you come across a patient of cardiac arrest, what do? You start intubating the patient first. No. The first thing is the technique to save the patient is through the cabs, compression, airway, and then breathing. Compression of the chest will not only revive the heart, but it will also revive the brain. Because in any case, if the brain doesn't get any blood for 4 minutes time, the patient may turn out to be later brain dead, or maybe vegetative, or maybe hypoxic ischemic encephalopathy. Okay, this is from the start. So stop typing. Good. Neurology is something which cannot be understood without the pillars of neuroanatomy and neurophysiology. We are on neuroanatomy, which area of the brain, what function does it do, and is something wrong in that area, what can be the possible deficit. Okay, I'm on the frontal cortex or the frontal lobe. The primary motor area, area number 4, okay, from where the corticospinal tract or the pyramidal tract starts from. But the question of physiology is this: does the pyramidal corticospinal originates from there only? No, it originates from the primary motor area, 31% of the fibers. Premotor and supplementary motor area, 29% of the fibers, and to your surprise, even the parietal cortex, major chunk, 40%. So, moral of the story, does the pyramidal corticospinal only originates from the primary motor area? No. It originates from premotor, supplementary motor, and parietal. Okay. Primary motor area in the frontal lobe has got 6 layers. Some people told me correct. But the pyramidal tract originates from which layer? Someone told me area number 4 or the layer number 4. No, it's not layer number 4, it's layer number 5. Okay, because it has got large cells of beds over there from which the motor area or the pyramidal cells are sitting, which originates the pyramidal tract. Correct. Congrats, many students have finally logged in. Good. Now, how is the motor cortex looking inside the brain? If I take a section that is a coronal section, okay, the lower limb is the medialmost, the trunk, upper limb, hand, and the face, and the tongue. Now the lower limb part is the paracentral lobule, which is the motor cortex for the lower limb. Trunk, upper limb, hand, face, and the tongue. Why did I make the hand and the face a bigger one? Because finer the skill, larger the area of representation. That's very, very important. We do fine skill with the hand and the face, so larger the area of representation in that part. Now something I missed upon, if at all, in this motor cortex, there is a destructive lesion. Now the lesion is destructive, like infarct or bleed. What are we going to have? Yes, what are we going to have? Weakness in the patient known as paralysis. While on the other spectrum, if there is an irritative lesion in the brain, like a brain tumor or a cyst, what are we going to have? Seizure disorder. Seizure disorder, right? Let me ask you a question to check your long-term memory. Patient complains of Jacksonian march in the lower limb. Where is the lesion in the brain sitting in? Can you tell me? If you remember the Jacksonian march, which we have discussed in the very first class in month of April when the lockdown started, it starts distal, goes proximal, starts proximal, goes distal. Okay. It is always there in the paracentral lobule. Why? Because I'm talking about the lower limb. Any irritative lesion in the lower limb, okay, will cause seizure, can be cyst, brain tumor, anything. Okay, it's a very simple question. Premotor area, area number 6. It gives rise to another tract which is not the pyramidal, but it's known as the extrapyramidal tract outside it. The main function of it is planning and execution of movement. Whatever movement I'm trying to do, I plan and execute it from there. And also sequencing of movement is equally important at this point. Okay. Now think that you don't know, and I would suggest people who have just joined in to take a full one page and write this pathway, very important, direct indirect pathway. The direct pathway happens to be the stimulatory pathway from the background knowledge in the previous classes we have discussed. The indirect pathway is the inhibitory pathway now, right? The stimulatory pathway, the direct pathway, could easily be recalled through this old mnemonic: come straight, get into thalamus. The word C in the come here stands for the cortex. The S in the straight stands for the striatum. Get into, the 2G and the I, globus pallidus interna. And then the last part is the thalamus. The main thing that you need to know here is the direct pathway is stimulatory for the cortex. That means some signal from the thalamus will go to the cortex to stimulate it. The cortex stimulates the striatum. Striatum works more. Remember this before we proceed. The striatum and globus pallidus, whenever they release, they always release an inhibitory signal. Now can you guys tell me, what is a inhibitory neurotransmitter in the brain? Okay. What neurotransmitter is considered to be inhibitory in the brain? Is it glutamate or GABA? Any answers from your end? Is it glutamate or GABA? Some fugax is there, don't panic, it will come back. GABA, good. So maybe the striatum and the globus pallidus release a molecule GABA to inhibit the next structure. Okay. So cortex stimulates the striatum. Striatum will release maybe GABA, slow down the next structure, that is globus pallidus interna. Globus pallidus interna always release an inhibitory signal. That means it will should inhibit thalamus, but since it is inhibited, it will not inhibit thalamus, and the thalamus will fire more, and the cortex will always get a stimulatory signal from the thalamus. Come straight, get into thalamus, the direct pathway. The indirect pathway, the word indirect comes because of this reason: it is traveling through a different route. Indirectly it is going to the cortex, thalamus. Come straight, get externa, and get into thalamus. Okay. Cortex receives or sends the signal to striatum, globus pallidus and externa. The N stands for subthalamic nucleus. Someone was asking me what is STN? Arey Baba, it is subthalamic nucleus. Globus pallidus interna and thalamus. People I know, people have not attended my previous lectures. I'll just draw a rough diagram. If this is the cortex, correct? Basal ganglia, thalamus. Okay. What is this part? The lentiform nucleus. It has got an outer peripheral part that is known as what? Putamen. What is this? The middlemost part. Globus pallidus, externa, interna, two parts. There is something above the caudate nucleus. There is something below the subthalamic nucleus. Even down below, if you remember, yes, was the midbrain, substantia nigra, which gave me what? Dopamine. Between the two, now between the two areas, what is being sandwiched like this? We have discussed this n number of times in the previous classes. Internal capsule. Okay, so what is striatum? Can someone of you tell me what is striatum? Can someone of you tell me? There's some fugax, don't worry. What is striatum? Striatum is a combination of putamen with a caudate nucleus. Okay, so this is nothing but we already have done it. You have, I'm 100% sure Pawar sir has also taught this in anatomy. Nothing new, it's all basics. So cortex stimulates the striatum. Striatum works more, which inhibits globus pallidus externa, which doesn't inhibit subthalamic nucleus and it fires more. To stimulate globus pallidus interna, which works more and now it inhibits thalamus. So thalamus in a turn doesn't send any stimulatory signal to the cortex. So the indirect pathway is said to be inhibitory. Okay. Now the third area in the frontal lobe that we need to learn about is the supplementary motor area. The supplementary motor area. Few functions it tries to serve. One is planning and sequence of activity. Now what is the difference between the premotor and this? They also do the same thing, but this one is more or less based on memory, on the past experience. How do I do? Maybe a planning thing happens here based on memory. It is also equally important in the patient for assumption of a particular posture that we try to take, sit down or climbing up a stair or a ladder. It is being done here in the supplementary motor area. Supplementary motor area is also equally important for one thing, inhibition of reflexes which we are born with, right? Known as the primitive reflexes. Primitive reflexes. If you remember these reflexes that you might be born with, yes, the sucking reflex or the grasping reflex. But as a person grows up in life, we find this. As the person grows up in life, these reflexes disappear from the patient. Who makes them suppressed is a supplementary motor area to inhibit the primitive reflexes. That means in an elderly patient, you come across with stroke, and on neurological examination, you find the patient is having sucking and a grasping reflex. What does it mean? It means the lesion in the brain is in the supplementary motor area for us. Okay? So there is some fugax, don't worry, it will get corrected. Fourth area is the frontal eye field. Frontal eye field. FEF. Can you tell me what is the number of this area? Area number? Frontal eye field. Area number 8. Frontal eye field. Area number 8. Okay. Don't worry, don't panic. Going to come back. It is reversible, it is transient. This fugax. Okay. Just check the net once more. Give me a second. Am I audible, visible to all of you? Audible and visible to all of you? Okay. Everything is fine now. Good. Actually, sometimes on this Wi-Fi network, now my kids start watching YouTube, Netflix. I have to tell them not to do this. Okay. but they know the Wi-Fi password. They're very smart. That's why I know them as Binod, and I'm Vinod ke papa. Frontal eye field, frontal eye field. This is a topic that we have already discussed in the previous class, right? Please tell me if there is a lesion in the frontal eye field. If there is a lesion in the frontal eye field which is destructive, okay, or irritative, okay, eye deviates from the lesion, eye deviates from the lesion. Please tell me again. This we have discussed in the previous class. In the destructive lesion, please tell me, the eyeball will deviate where? Towards the lesion or away from the lesion? Eyeball will deviate towards the lesion or away from the lesion? Please tell me. If it is a destructive lesion, please tell me. Eyeball will deviate towards the lesion or away from the lesion? Yes, very good. Guys, remember it. Towards the lesion. Irritative lesion, please tell me. It deviates away from the lesion. Right? This all concept we know is been well carried forward in the previous classes. We have discussed it. Number 5 is the Broca's area. I've discussed this also in the previous classroom teaching. Broca's area. Broca's area is area number what? If you remember from physiology also, area number 44, 45. And the location of the Broca's area is where? It's somewhere in the inferior frontal gyrus. Inferior frontal gyrus, right? In the frontal lobe. And what was the main function? We have discussed this as a separate topic. Forming the words in the brain, word formation happens there. So all the words I'm talking through, word formation happens from there. 6th is a very important area that you all should have with yourself, is the prefrontal area. Prefrontal area. Why? Because this area is important for two things. Control of your emotions. One. Second thing, it is for equally important for retrieval of memory. I'll come to that separately. How does it function there? What function does it do? Retrieval of memory, especially the fact kind of a thing. Okay, just a example like this, like you go for the exam on the computer screen, because all the exams are now CBT type, and you find on the screen a question or from a topic which you have never read. Maybe your first question is from biochem, the second question is from microbiology, and the third question comes from community medicine. What kind of feeling do you have? Good feeling, bad feeling? Of course bad feeling. And you will go into a lot of stress. To control your stress, what will work? The prefrontal area. And now what will happen? Whatever you have read previously, you will not be able to recapitulate or recollect it, because retrieval of memory is not being done, because all the time the prefrontal area is to control your emotions. So to have a good emotional control, not incontinence, you should always try to practice some tests, maybe online, so that you are more acclimatized to that stress of examination. It's equally important. Okay. Now there are two things which the prefrontal area does for me. Now if there is a lesion in the prefrontal area, what can be the kind of a deficit that we find? Remember this, if a person feels sad, he's going to cry. But if he cries very loud, I think he's got a sort of a emotional incontinence. Maybe a person feels very happy and he starts laughing at everyone around him. and other person will think that he is making fun of me, again is a sign of a social incontinence or maybe emotional incontinence. In another word, I find if there is a lesion in the prefrontal area, the behavior will not be as per the surrounding. It will be an antisocial behavior. So remember this quick fact that the behavioral abnormalities often come across in a patient of stroke or any brain disorder when the lesion is frontal. Okay. Number 7, which I actually forgot to tell about, is a micturition area. I should have told it earlier, people are typing so much in the chat box, my half energy is going there only. Control or maybe of micturition. Control of micturition happens through the micturition area. Now, if you understand this, there is an area which we have described already in the motor cortex, that is a paracentral lobule, which was a motor cortex for the lower limb, but it is also a micturition area for me, and it is controlling my micturition. How? It tries to guide me for one thing, that where should I go and micturate. And look at this. When should I micturate? I will know. When the bladder is full, I feel the fullness of the bladder, I'll go and micturate. But the sense of where comes from where? The brain, frontal lobe, paracentral lobule, micturition area. So remember this, if there is a lesion in the micturition area in the brain, okay, if there is a lesion in the micturition area in the brain in the paracentral lobule, what will I do? I will not be able to hold the urine inside the bladder. That means my bladder will fill up. I feel like micturating. I'll have urge to micturate. But that social inhibition maybe, I can write the word as social inhibition on the bladder will be lost. So I'll micturate anywhere, anytime where I'm sitting at. So in another word, I will have urinary incontinence. So don't forget this point, that urinary incontinence is a feature of frontal lobe lesion, especially when the lesion is in the paracentral lobule. Okay, that's a very simple concept. Okay, infant bladder and all, yes, that's another name for it, because the bladder of the patient is like an infant. The infant has not reached the milestone of bladder training. They don't know where to micturate. So the word given to it apart from all these things is infant bladder. Okay, let me just summarize everything into a simple example which you'll be able to recollect in the exam also. Just imagine you go for a theory exam, and the theory exam is, as I told you earlier also, is a essay writing competition. So you just keep on filling pages, and you don't know anything in the exam. And there's always one fellow in your class who gets up after half an hour of the theory paper and asks for what? The extra sheet. And then there is a diagonally opposite guy or a girl especially who is writing with very good handwriting. First of all, good handwriting people should not become doctors. They're not eligible for that. Anyway, they're writing and you can see what's been written on the answer sheet. So obviously you not appreciate the handwriting. You will try to copy paste from there. So for example, someone is sitting diagonally opposite to me. I'll move my eyeball like this towards the left. If my eyeballs are moving towards the left like this, who is firing? The frontal eye field. Okay, it's sending a signal to the opposite eyeball, sixth cranial nerve, and through the medial longitudinal fascicle, medial rectus like this. You discussed in the previous lectures. So I keep on looking there. Okay, and I write in such a way that my eyeballs only move. I don't move there. So I have to assume a posture. As I told you, for assumption of a posture, who works? The supplementary motor area. So I assume a posture like this, and I start looking there and copy paste. When I'm writing with my hand, the brain cells which are firing to right are the cells of the pyramidal cells, the layer of bits that was layer number 5 in the motor cortex. So motor cortex, the supplementary motor area, and frontal eye field, all three are working for me. But I know my examiner, he is very cruel. He has got CCTV everywhere around his head, and he catches me. Now he catches me and asks me, "Yes, doctor, what are you doing?" Do I start crying? No. I said, "Nothing, sir, just writing, sir." So look at me. I was scared, but I tried to control my emotion of scariness by what? The prefrontal area. And now what? If I want to say, sir, all is well, everything is fine, which area of the brain is working? The Broca's area. Okay. So keep your frontal lobes good and alive if you want to stay healthy and peaceful in life. Okay. Now let's proceed and go into the parietal cortex or the parietal lobe. Okay. In the parietal lobe, okay, in the parietal cortex, we find a very important area which is known as the primary sensory area. Primary sensory area. Okay. The primary sensory area in the parietal cortex has got a number with it, that is area number 3, 1 and 2. I don't know why did they not write 1, 2, 3. There was some dyslexia at their end. They write 3, 1, 2. It's fine. No problem. Now, what is the main function of this area? You might have read and discussed this in your physio and anat lectures also. Localization of a particular stimulus. Whatever stimulus I get, I try to localize it in the primary sensory area in the parietal cortex. Okay. Now remember this, perception is different and localization is different. We'll try to understand this tomorrow again in the spinal cord sections, that whenever a mosquito bite happen on my feet, do I scratch my entire lower limb? No. I only scratch that part of the feet. Still, I cannot see the mosquito bite mark, neither can I see the mosquito waiting for me there. No. Still, I am so fine that I am able to localize that particular stimulus. But how does it happen? The nerve comes in, yes. For example, a mosquito bite, the sensory nerve will give me a signal. The signal will cross the midline in the spinal cord and will go up. The mosquito bite is never a pleasant thing, so it is always a pain and maybe a touch signal which I get. If you remember, the track which is traveling up with this signal is the spinothalamic track. So the pain touch, that is a crude touch maybe, and even the temperature together will travel up to the brain through the spinothalamic track. ST stands for spino, starts in the spinal cord and ends where? The thalamus. Correct? So thalamus is for me a sensory gateway. Now look at these words, gateway. It is passing through it. So the main function of thalamus is perception of any particular kind of sensation that I get. There are many nucleus in thalamus, we'll go to them individually also. But remember this, thalamus, the main function is perception. And then finally the signal will go to the brain cortex. For what? Particular kind of localization. Where did it happen? So mosquito bite on the feet, correct? I don't scratch the whole lower limb. I exactly scratch the part or the site of the mosquito bite. Okay. So remember this, if at all there is a lesion in the thalamus, the perception is lost and the patient will have loss on sensation known as anesthesia. So sensory loss or anesthesia as a complaint is something which we will find in a thalamic lesion. While if the lesion is in the cortex, do you find perception loss? No, if the thalamus is intact, you are able to perceive, but you are unable to localize it. Okay. So that's a very important thing to read and understand, is a primary sensory area. Area number 312 is for localization of a stimulus. Second area, remember this, is the sensory association area. Now we are moving forward from the primary to associative area. That is a sensory association area. The sensory association area is area number 5 and 7. Area number 5 and 7. Okay. The number is important now somewhere. Okay. It is for few things, need to remember this. It is important for perception of size and the shape of an object without seeing it. Very, very important, without seeing it. Okay, without seeing it. Okay, this whole concept is known as stereognosis. A genuine doubt for a first time. Won't touch pass through the posterior column tract? Yes. Fine touch will go through the posterior column. I'm talking about the crude touch. Okay. Stereognosis is very important. I'll tell you example, like you guys get up in morning nowadays somewhere. And how do you get up? That someone wakes you up? Now for me in the house, my wife throws water on me. This is how I wake up. Now what happens? You guys are sleeping at your home and a vibrator, mobile phone vibration comes, the alarm, right? And suddenly you move your hand around in the bed with closed eyes, and in your hand your textbook comes in. The moment you catch your textbook first thing in the morning, you're going to leave it behind. Oh my god. And then you pick up your mobile phone and put a snooze button and go back to sleep. This is stereognosis. Without seeing the object, on just touching it, you are able to appreciate the size and the shape and identify an object perfectly. That is stereognosis. Simple. Second function which the sensory association area will be doing is graphesthesia. Graphesthesia. Okay. Now graphesthesia is basically ability to identify tactile writing. That is writing with a tactile stimulus, like you write something on the patient's forearm skin, 0, 1, 2, 3. And in that case, the person will be able to know and judge what you have written, is known as graphesthesia. Okay. The third thing which this area is going to do is 2-point discrimination. So we apply calipers on the patient's skin, which are quite close by, and now what will happen? The patient will be able to judge, is it 1-point or 2-point, known as the 2-point discrimination. Okay, so 2-point discrimination happens through the sensory association in the parietal cortex. Okay, so please do remember this fact. These are the three things. Now why I'm telling all this story, because if they ask you A stereognosis, A graphesthesia, loss of 2-point discrimination is all happening due to lesion where in the brain? Parietal lobe. Which area? Is it primary sensory area? No, it is sensory association area. Okay. Now let's look at number 3. Is the taste area. Very important. Taste area. For identifying a particular taste, yes, we get a taste area in the parietal cortex, right? For example, you eat something nice, like I pour a black aerated cold drink in a glass and you drink it without seeing the bottle. You'll tell me it's Coke, Pepsi or Thumbs Up, because you have a recollection of the taste of Pepsi, Thumbs Up in the brain already. Like I'm very sure some people from Telangana and Andhra must be there, Hyderabad students, they must be knowing this. You eat biryani in Hyderabad, you can tell me on smells also, is it Bawarchi biryani or a paradise biryani? Okay, so this happens. Identification of taste is something in the parietal lobe, but how does it happen? Let's try to revisit basic anatomy again. If I see this as a tongue tissue, okay, and this one is the brain cortex. How is the taste signal going to the brain? Right? The anterior two-third of the tongue, if you remember this, the anterior two-third of the tongue has got a sensory supply from the facial nerve, 7th, right? While the posterior 1/3 of the tongue has got a sensory taste signal from where? the ninth cranial nerve, and down below the pharynx, the sensory supply is from where? The 10th. So we get this, the anterior 2/3 of the tongue. Keep on writing, please, on your notebook, not on the keypad. And the posterior 1/3 of the tongue. So we get a supply anterior 2/3, taste signal 7th, posterior 1/3 9th, and the pharynx is the 10th, right? Now all this is going to go to the brain. Why I'm trying to make a diagram like this, because signals are going to cross the midline, right? The signal from the 7th is going to come, okay. Signal from the 9th is going to come, signal from the 10th is going to come. I'll just label this as A, B and C. Now whenever you see a diagram like this, a nerve with a dot, the dot is something known as a ganglia, ganglia part, so or a ganglion part, A, B and C, right? A is a ganglion for the 7th cranial nerve, known as what? Geniculate ganglion. For the 9th cranial nerve, yes, it's above, superior ganglion. C, what? Inferior ganglion. So inferior ganglion, geniculate ganglion and the superior ganglion or ganglia are a part where all the nerve cell bodies will accumulate. For the 7th, it's geniculate, for the 9th, it's superior, and for the 10th, it's inferior. Okay. Everything is going to collect together. Can someone of you tell me what is this blue part I have tried to mark? Yes, good. NTS. NTS. Nucleus tractus solitarius. Excuse me for some spelling mistakes if I commit. Okay. Nucleus tractus solitarius, NTS. Right? Now everything will collect together. The taste signal. And will reach a part which is a sensory gateway, thalamus, through a track going up. Now, can you tell me which track is this? The taste signal goes to the brain through a bundle of fibers, white bundle fibers, after crossing the midline. As you can see, this one is the midline, the dotted line. What is this? Some lemniscus, where your vibration as well as the proprioception goes up. Yes. The medial lemniscus. The medial lemniscus fiber are going to carry up the signal of taste now also. Nucleus tractus solitarius will send it to the medial lemniscal fiber, and then it will reach the thalamus, and then finally it will reach the cortex. Somewhere we find the taste area, okay? Somewhere we find the taste area is in the inferior part of post central gyrus. So there is a post central gyrus, the inferior part of it will have a taste area sitting there for recognition of a particular taste, right? Okay. So this is not medicine. This is all, I think so, it's more of anatomy. Okay. Now number 4. Something which we find is optic radiation traveling through it. I'm not going into detail because I'm sure Opthal sir and ma'am, both of them has taught you about this. If there is a damage in the parietal lobe, which segment of the eye field will be affected? Mark it. Let's try to read Opthal also. I'm not going into details why. Tell me which segment will be affected if there is a damage in optic radiation in the parietal lobe. A, B, C or D? B and D. Inferior. D. D. Okay, if this is maybe one side, other side. Now you tell me. Okay, I'll leave this now. I'll cross check because I'm getting different answers from what I know. Okay, so we'll leave it here. I'll come back to you when after a break. I'll cross check from the anatomy faculty again. What is the best and the correct answer? Okay, right. Number 5. I'll cross check from anatomy faculty and get back to you. Angular gyrus, because everyone is giving me different answer. I'm not sure what has been taught. Okay, right. Angular gyrus, angular gyrus. Angular gyrus, remember this, stores images associated with number 1 reading, calculation and naming fingers. So the angular gyrus, as you know, it basically stores images associated with reading, calculation or naming fingers. Okay, few things which it tries to do. Let me take you into this basic concept. How do you read? You read an alphabet written in front of you. For example, I show you this. You read this as M, but I show you this. You will always read this as W. There is always going to be a different image of M and W in the brain for you. So how did you get this image of M in the brain? Because when you were kids somewhere, we were reading words by seeing it, and at the same time the teacher pronounced the alphabet M. So the word of M came in the brain with the image of M in the brain like this. So all of them together collected at a point known as the angular gyrus. So angular gyrus is associated with reading. So whatever the image of a particular word is there in your brain, you are able to store somewhere in the angular gyrus. And next time you see that word, if I try to tell you that particular word, you're able to write that correct word in front of me because the angular gyrus gives you that image. Second is calculation. Calculation is again something important. Simple arithmetic calculations you can do, even the complex wala you can do. Naming a finger, if you see this as a thumb, index finger, middle finger, ring finger, little finger. So naming the fingers is also done through this part of the brain, angular gyrus. Now remember this old concept which I could learn somewhere, that the lesions of angular gyrus could be acquired like degenerative or can be developmental also. So if the lesion of the angular gyrus is developmental, what is going to happen in the patient? The very first thing that they might commit as a problem is right to left confusion. So if there is a door in the room on my right, I'll go towards the right and open the door and come out of it, the room. But this time I go towards the left. But you prompt me, sir, the door is on your right. Why are you moving towards the left? I say, no, Baba, the door is on my left today. So there is something as a direction orientation problem, in a sense that whatever is there in front of me is projected like a mirror image, just the mirror image of it. Okay, so this is something important, mirror image. Now what happens when in the developmental pathology, for example the anglo-garris, there is right to left confusion and teacher teaches the child the alphabet B. So she shows the alphabet B written on the board and pronounces the word B. But the child stores the word B in the brain for the word, but the image of B goes like this, just the opposite. On the other end, she writes the alphabet M. He stores the alphabet M in the brain like this. Maybe I can just give you an example. Bombay. It's a very old example, Bombay. We all read this as a word Bombay because the B-O-M-A-M-Y looks like this. But whenever I tell this patient to write the word Bombay, the person will write the word Bombay like this. In this patient, the B and the Y are just the opposite, but the O, M and A are also opposite, but they look the same. For the very reason that whenever they learnt a word, they learnt a word in an opposite mirror image. So next time when they recall a particular word, they're going to recall it as a different image like this. Okay. So this is how the problem comes in. So there are two sets of problem. Remember this. First of all, as you can see in this, the child, due to right to left confusion as a mirror image problem, has learned the things incorrectly. The learning is at fault. That is known as the term dyslexia. Remember this. The word lexia goes for the word learning. Because of this, the problem in the patient comes later on in reading a particular word. That is known as the word dysgraphia. The word graphia goes for reading as well as it can go for writing also, no problem. So there is a defect or dysfunction in reading and writing, dysgraphia. Apart from this, calculation was something which has been done with the anglo-garris. So these patients cannot do simple arithmetic calculation, acalculia. Neither the patient can name the finger which has been showed to him. They cannot identify the finger. That is known as a term finger agnosia. Okay. The word agnosia is a term which is applied for disorder in which we cannot identify. We cannot identify the finger which has been shown to me. That is known as the word finger agnosia. So these are few things that come together as a syndrome. Okay, don't tell me the movie name. I'm not playing dumb charades with you guys. It's known as the Gerstmann syndrome. Gerstmann syndrome. So Gerstmann syndrome is a term which is applied for constellation of all these symptoms together, and the lesion, write it down. The lesion is where? Angular gyrus. Okay, the lesion is in the angular gyrus. Gerstmann syndrome like story. Okay, now remember this. There are two angular gyrus, left and the right angular gyrus. The left angular gyrus, remember this, will create a problem known as the Gerstmann syndrome. Gerstmann syndrome. Okay. Right. What will happen when the right angular gyrus is affected? Please tell me. Hanji, people from the dumb charade group, some dumbs are there with me today. Okay, so players of dumb charades, please tell me what will happen if there is a lesion in the right angular gyrus. At least one symptom you tell me, I will be more than happy with you guys. That means you are studying. Oh, complete silence. 2 minutes of silence. Normal. Yeah, shabash. Neglect. Okay. Non-dominant lobe. Oh my god. Neglect. How many pages till now? Wow. I'm getting answers from your end. this happens. Some people have not taken this lockdown seriously. You know what they thought was, this is a holiday for me. Arey Baba, this was the right time for you to study. It's so peaceful. No one is going to throw you out of the house. Even your parents are happy to keep you inside the house this time. If you tell them that I want to go to work, they say, nahi beta, काम nahi at this moment. Good. Some people are coming to me with apraxia as an answer. I'm very sure Dr. Sachin in psychiatry also discusses this topic. Let me write this down. What are the symptoms if there is a lesion in the right angular gyrus? Anosognosia. Anosognosia, in which the patient denies any kind of a deficit. For example, these patients, you tell them that you're having this and this problem, they will deny it. No, I'm totally normal. You have a problem with you. Okay, so they denied this deficit. This is known as anosognosia. Second, they've got apraxia. Apraxia, I'll discuss it separately at the end. It is a very another topic to read separately. Two kinds of apraxia: dressing and constructional apraxia. Okay. So remember, in a layman term, apraxia cannot do an activity. A praxic patient doesn't have any weakness, he doesn't have any paralysis kind of a thing, but he cannot do any kind of an activity which has been told to him. For example, dressing. For example, wearing clothes. For example, like, I'm wearing a pant. I hold the pant and I put the right leg into the right leg of the pant, my left leg into the left. Suddenly I lose the orientation of it. I'll put both my legs into same side, or I'll not be able to align my body to the alignment of the cloth. So the alignment thing is totally lost in them, especially by wearing clothes. Construction is a very famous thing. Cannot copy geometric patterns. Can you tell me which disorder? Now this is something from gastro. Which disorder? Okay, I'm priming you today. Which disorder? Yeah, some yes, good. This is intelligent brain syndrome. Okay, not irritable. It's intelligent brain syndrome, IBS. Yes, hepatic incaf. They have got constructional apraxia. Apart from this, these patients have got geographic agnosia. Geographic agnosia. Okay. Geographic agnosia means basically for the patient outlook, yeah, cannot find the bed in the ward. So patient is in the ward, admitted, and he cannot find his bed. Now there are beds available. It's not a COVID ward. It's not a COVID ICU. Beds are available, but he cannot find the bed. It very commonly happens when you attend a viva, and your examiner has already he has taken your viva. You get up and your viva is over, and then you really forget where is the exit door. You often suffer with this after viva. Yes, post-ictal geographic agnosia. Okay, right. Now let's move into another important lobe, that's the temporal lobe. Temporal lobe. Okay. Remember this temporal lobe, another very, very important one, has got an area inside it known as the primary auditory area. Primary auditory area. Okay. This is supposed to do the process of hearing for me. I'm sure in anatomy as well as in ENT, sir, both the sirs have taught you about this temporal lobe primary auditory area. Okay. So there is a very, very, very important diagram of the auditory circuit, which I'll try to redraw with you guys. so that this topic fits into your brain forever. Okay. Now, just before I forget the number of the area number 41 and 42. Okay, area number 41 and 42. Okay, is the temporal auditory area, and I request you again, take full 1 page for this work. Take full 1 page for this diagram, because some diagrams are really very important. In all the exam, everywhere we're getting a question on them. So my advice will be to take full 1 page for it. Hemispatial neglect, I know this. I'll come to that separately. Okay, when I go to Alzheimer's, I'll talk about that topic separately, because the hemispatial neglect drama, is left or right hemisphere, and it might be different for every patient. So I'll come to that later on. Okay, chalo, for this what we'll do, we'll start from below. We'll leave some space above. Leave some space, maybe if you're writing on this rule kind of a page, 10 lines you can leave. Okay, now we'll draw like this. We'll draw the section of medulla first. So this is a section or a transverse section of medulla I'm trying to make. Okay, why I'm trying to make a section of medulla, because the 8th cranial nerve will come with a signal. The vestibulocochlear nerve will come with a signal there. Where? In a ganglion outside and a ganglion inside. Okay. This one is outside ganglion, known as the spiral ganglion or ganglia, while this one is the dorsal cochlear nucleus. So there's a dorsal cochlear nucleus. Every cranial nerve, remember this important thing. Every cranial nerve has got a nucleus in the brainstem, except for the first two, 1 and 2 cranial nerve, because they don't have any nucleus. So we'll go back to the brainstem again tomorrow when we discuss it. But the 8th cranial nerve has got a nucleus on the brainstem at the pontomedullary junction, but I'll put it into medulla first. Okay, and then just above it will be the next structure, which is the pons. Okay, pons. Now this signal from the dorsal cochlear nucleus, right, will go to pons, right, and in pons it will try to cross the midline also. In pons it will try to cross the midline like this and end into another nucleus right over here, right. Now this part of pons, where I see in a cut section, in a transverse view, it looks like a shape of a trapezium. Yes, this crossing over of the auditory fibers in pons in a cut section gives me an appearance of a geographic appearance of a trapezium. Yes, can you name me this body where the pons is having this crossing over of the fibers? Is known as the trapezoid body. Trapezoid body, correct? Now there is a nucleus in pons again, where this signal which has come from the opposite side has been there in pons. Okay, the name of this nucleus is what? The name of this nucleus is superior olivary nucleus. Superior olivary nucleus. Now look at this. There is a cochlear nucleus in medulla, and then there is a olivary nucleus in pons. Correct. Good. Just above pons we get our great structure. The midbrain. MB stands for the midbrain. Okay. Now this very signal will now go to the midbrain, and the dorsal part of it, which is the tectum, again there will be someone receiving it. This is an old thing and an old concept which anatomy sir teaches also very well, that there are colliculus in the midbrain, superior and the inferior. Superior is for the eye, inferior is for the ear. Eye is above, ear is below, it's easy to remember it. So there is a nucleus or a cochlea or a colliculus where the things are going to come, known as the inferior colliculus in the midbrain. Okay. Now we have to go to another structure. Yes, which is a sensory gateway. What is the sensory gateway? That is my thalamus. Fine. Now thalamus has got nucleus for every cranial nerve. Not cranial nerve in the sense there are various parts of the nucleus for every cranial nerve, but for the eighth nerve, remember this, there is a body there. The body in thalamus which receives the auditory input has got a name as the medial geniculate body, MGB, medial geniculate body, and then the final signal will reach the cortex like this, right? So what we could understand through this, in the trapezoid body, the auditory fibers have tried to cross the midline, but conditions apply. Some fibers will go uncrossed also to the cortex. Now same thing will be followed on this end also, and some of the fibers will go uncrossed now to the brain, but majority of them cross over to midline. So I'll repeat, there is a dorsal cochlear nucleus in medulla which receives the input from the eighth nerve, which will reach the pons, cross the midline in the trapezoid body, relate to the superior olivary nucleus, then project in the midbrain, inferior colliculus, thalamus, medial geniculate body, and finally the cortex. Some fibers will not cross the midline. Okay, why this is very important? Because if there is a lesion in the cortex, will the patient develop deafness? Tell me. If there is a lesion in the cortex, temporal lobe, the auditory area, will my patient develop deafness or not? Yes or no is a simple question. Yes or no? No, possibly, because if you are not getting the signal from this end, no problem. You can divert the signal to the opposite cortex and the sound impulse will be very well heard. Okay, so deafness as a concept here is rare to be seen, not so common. Now, if at all deafness happens, rare to rare it happens, what kind of deafness should I name it as? Should I name it as sensorineural, or should I name it as conductive deafness? Please tell me. If at all rare, I agree. If at all it happens, what kind of deafness should I name it as? Sensorineural or cortical? Conductive, sorry. Aha. I wanted to hear sensorineural from your end. Excellent. Great, guys. Excellent. Very good. Cortical deafness. You have never heard this term because it is rare. Haha. So rare things you don't know, it's good. But you should know an entity known as cortical deafness is also there, but it's rare. That's why you don't know it. It's not your fault. Right? Okay. Now the second area. Second area you already know is the Wernicke's area. Wernicke's area number what? Area number 39 and 40 is a number given for it. If you remember from the previous classes, we have discussed this. This all is located in the superior temporal gyrus, and the main function of it is to understand what has been told to me. We have discussed this in aphasia chapter also, comprehension. Okay. Number three, olfactory area, smell, olfactory area. Olfactory area is located in the temporal lobe. Taste area, parietal, olfactory area, temporal. Okay, number four. Oh my god. Optic radiation. I'm getting into problem today. I don't know. I'll just cross check with the opthal teacher once. Okay. A, B, C, D. Now, if we have a consensus on this one, it's fine. Where is the visual loss, in which quadrant do you find if the lesion is temporal and it involves the optic radiation? Any answers from your end? Okay, pie in the sky. B. I don't know. I'll just cross check it again because this is what I learned. In my days. Okay, it's B. I'll just again cross check and get back to you. If there's something difference in opinion, we'll sort it out. Number 5 is another very important area known as the memory area. Another very important area is the memory area. Okay. Now, for this, I'll take you into the basics of memory and the memory recall that we know. Okay, I'm getting this side. Fine. Remember this. Some basic memory concepts should be very clear to you because this has been recently asked in AIMS. In most of the exam, we get a question on this. Memory is actually being divided into two halves. That's known to me as a declarative memory. Okay. And the second wala is the non-declarative memory. So there are two types of memory that you find is declarative and non-declarative memory. Okay. The declarative memory, as the name suggests, we are trying to declare something. No, whenever I am trying to declare something, I need to be aware of that thing. So the declarative memory, remember this, requires awareness, and non-declarative, like, does not require awareness, does not involve awareness. Okay, so there are two types of memory, declarative and non-declarative. Okay, now remember this, the declarative is something which is also known as the explicit memory, and the non-declarative, okay, is also known to me as the implicit memory. Okay, now this declarative or the explicit memory is in two types. One is the semantic, other one is episodic. Right? Remember this. The semantic is for facts. Episodic is for particular events. Right? Now, For example, the semantic for facts, it is stored in the temporal lobe, the anterior and the lateral temporal lobe. And also one lobe which I have just now discussed, the prefrontal area. I was just trying to tell you this retrieval of memory. Whatever I'm teaching you in the class, you are able to recall that fact in the exam. That will require the prefrontal area. Correct? But which class you have to recall this fact from? That will be an event for you. My class or some other class teacher class. That will be for episodic events. Where is it stored? This one is stored in the hippocampus. Remember this? Hippocampus is a part of the temporal lobe which is much medially. Okay? But I can write the medial temporal lobe separate again. And also a part which is a broader area known as the neocortex. Right? So this is something which is very important, very frequently asked nowadays. Okay? People don't want boxes. I remember you boxes. Non-declarative memory. Okay? Non-declarative memory. Oh, sorry. And the area. There is a memory which is known as a procedural memory. Procedural memory. A particular procedure like driving, cycling, you already know it. It can be a skill which you already know, or a habit that you have already acquired. Okay. Which area of the brain stores it? A lot of three structures, One is the striatum part. Okay. Second wala is the cerebellum part. And then the neocortex. Neocortex. That is a procedural memory. Another one is priming and perceptual memory. Priming is very important. This is something through clues. I can write via clues. If you arrive at a particular answer, that will be a priming or a perceptual memory. Okay. Like I remember I went for the Viva and the examiner asked me a very genuine doubt. Which of the following anti-epileptic drug will cause seizure? I said, sir, it's an anti-epileptic. Why should it cause seizure? But I was very smart. I had the power of maybe circumlocution. And I tried to explain, sir, so there are various anti-epileptic drugs. There are various kinds of seizure disorder. Sir said, okay, keep quiet. Tell me what are the drugs which are contraindicated in patients of JME? Please tell me the answer. What are the drugs, anti-epileptic, which are contraindicated in patients of juvenile myoclonic epilepsy? Tell me the answer. Yes, one of them is the problem drug phenytoin. It will exacerbate the myoclonus. We have discussed this in the first or the second class. Okay. So I have tried to prime you. I have given you a clue that there are two anti-epileptics which can cause seizure. In a sense, they can exacerbate myoclonus in a patient of JME. Simple. That is priming perceptual via clues. For this, what part of the brain activates is neocortex. Okay. Right. Then there is another memory that is known as the associative learning. Associative learning. Okay, associative learning. That is known as a classical conditioning. Right? Classical conditioning means like Pavlov doggy of Pavlov, if you remember. Yes. Like for a lunch break, it's a very common experience. You are feeling hungry or not. You look at the watch and you say, oh my god, the class is still beyond 1 p.m. I have to take the lunch break. Even I am feeling hungry or not. Because you're a doggy of Pavlov. Over the time, it's not the hunger pang which has tried to condition you to that reflex of eating food. It's a clock which has come in front of you. And some people I know in the class are sitting just with a clock. Okay, classical conditioning, associative learning. That is amygdala and the cerebellum part. They work for that. Non-associative learning. So my doggies of Pavlov, how are you? How's the Josh? Break. I was wondering what has happened. Where is my tukde tukde gang? Break gang, tukde tukde in Hindi. I am Arnab Goswami. I will fight with you. Tukde tukde gang. Habituation. Habituation and sensitization. Arey, when you are getting so many jokes, why are you worried about the break? Yeah? You are at home, bindas, eat, drink. Okay, sit down there only. Non-associative learning. Okay, non-associative learning. Okay, habituation and sensitization. That is through the reflex pathway. Okay. Okay, so this is the basics of memory, memory, which is non-declarative of various types and declarative. You can just try to connect with this uh, uh, topic somewhere in physiology as well, because this is something very important. Okay, now I'll go back to another basic of medicine, which we should know, that the memory is not only as declarative and non-declarative, it is in another two types. There is a working memory, that is an immediate memory. Okay, and then there is another memory which is the short-term memory. Right, now I'll just check your memory on this. Please tell me, which layer of the motor cortex are the bed cells located in? Which layer of the motor cortex are the large bed cell for the pyramidal tract located in? Which layer? 1, 2, 3, 4, 5, 6. There were 6 layers if you remember. Out of which 6 layers is it really located in? Yeah, layer number 5. So this is something which even I, with you, of course, you are the leader for me, we wrote it wrong in the first go. Fourth we wrote because it was area number 4, I remember 4. No, it's fifth, something which I recollect just now, immediate memory. Then we have a short-term memory. Okay. Uh, which country did the COVID virus originate in? If at all it originated, yes. COVID virus originated in which country? China. That's why it is known as China originated virus in December 2019. Okay, that's my abbreviation, not the yes, COVID-19. So that is something of the short-term memory. Okay. Now remember this immediate and short-term memory is located in the temporal lobe. Fine. And then this whole drama will be converted into a long-term memory in the part of the brain which I know as the hippocampus. Hippocampus. And then finally, Then finally, the long-term memory will sit down in a part of the brain that is known as a neocortex. So a very simple and a straightforward physiology question that we found. Which part of the brain do you consider as the gateway of memory? Gateway of memory. Area where it is passing through. Like the gateway of sensory input was thalamus, the gateway of memory is nothing but my hippocampus. Correct? Now remember this way. Loss of memory or amnesia can happen in two formats. Like a patient has met, for example, with a head injury. I'm just giving you an example, head injury. Okay. And now the patient forgets what has happened to him in the past. That is known as loss of past memory, known as the retrograde amnesia. Loss of memory. I'll talk about Pape's circuit also, but I think so that will be better if we discuss it under Korsakoff psychosis and all. It will have a better connection there. Okay, we'll keep it for that topic. Okay. Now, anterograde amnesia, like you read something and after 5 minutes or 10 minutes, I ask you a question based on that topic and you are not able to recollect that. Maybe you are not attentive, one reason. And second reason, of course, you are sitting with your own distraction, mobile phone. Anterograde amnesia, the thing that happens after any chronic insult or an acute insult in the patient's brain, and the patient cannot register any fact, any detail after that injury part, is known as anterograde. Anything of the past he has forgotten is the retrograde. Just a general example, patient comes to me with head injury. He might be unconscious initially and became conscious, and I ask him, what is your name? He doesn't remember that. Where are you coming from? He doesn't remember that. That is retrograde. But this patient can recall everything. Yes. And suddenly when his relative comes and asks him, it's a very common experience, that the relative comes and asks him, how are you? He said, I am fine. But since morning, no doctor has come to check me up. Then the relative says, just 5 minutes back, a doctor was talking to you for such a long time. No doctor came and checked me up. That's why every patient after hospital admission, I've especially seen in the COVID ward, all of them suffer with this amnesia, anterograde amnesia, very common disorder. Now, remember this, anterograde amnesia, the lesion that you find here is in the temporal lobe. Temporal lobe. The temporal lobe of the brain is a storehouse of the working in a short-term memory, and my patient will not be able to recall anything based on it. That is anterograde. Now I'll ask you a question from the very first class that we have covered this topic, seizure disorder. Seizure disorder. Please tell me. Seizure disorder, what kind of memory loss do you find? We have discussed it in the seizure chapter also. If you remember, I have talked about it. Like a patient of seizure at home, what happened with him during the episode, he could not recollect that to me. While on the other hand, he could recollect who is he, where is he living, where is he coming from, everything. So that episode of amnesia in the patient of seizure is what? Anterograde. After the onset of seizure, yes, anterograde amnesia. But we've talked about this in the previous lectures in aphasia also, that God is great, Okay. Remember this, the lesion in the brain can either be in the left or the right. Okay, the left hemisphere if you remember, and the right hemisphere if you remember. We have talked about this in the previous aphasic lecture also. The left hemisphere was a dominant hemisphere where the Wernicke's and the Broca's area was sitting for me, and the right wala was a non-dominant hemisphere. So there are two things that you should know. The amnesia in the patient is not only retrograde and anterograde, it can be in two other formats. For example, the amnesia can be a visual amnesia. Okay. Or the amnesia can be an auditory amnesia. Okay. Remember this, the visual amnesia commonly occurs when the lesion is right non-dominant lobe lesion, Auditory amnesia often occurs when the lesion is left dominant kind of a lesion. I'll talk to this in a very simple example format that will be very easy to understand it also. For example, uh, you see me today and again tomorrow you see me on the screen. And next day tomorrow when you see on the screen, you will type on the keyboard which teacher, who is he? I am seeing him for the first time. You are suffering with visual amnesia, that you don't recollect my face tomorrow. On the other end, you don't see the screen, you just listen to my voice. Because I've seen some students on just putting their mobile phone in a corner of the house and I am speaking, they're not seeing me. They know, they already know everything. Okay, so they listen to my voice and they don't recognize me. That is auditory amnesia. It's very simple. Now, the visual amnesia has got a problem. I remember this concept. I've talked about this earlier in the classes also, that I was traveling in metro once in Delhi when metro used to run before lockdown, and two of the damn students saw me. They looked at me and smiled at me. I also smiled at them. And then we showed each other the pathognomic V sign of dams, victory sign, pathognomic. And then they also showed me this. Then one of the students asked me, you were also in dams? I got a shock. I said, yes, I was also in dams. Then he asked me another genuine doubt, which batch? Then I had to do priming. Then I gave them a clue. If you remember ethosuximide, yes, I am Vinod ke papa and ethosuximide ke dada. Okay, then those idiots understood that I am not their batchmate, I am their teacher. So the basic problem my students often face is this: inability to recognize faces which you have already seen. Okay, see, a film star suddenly you see on the road, you will able to recognize, but a teacher you find on the road and go on, isko dekha hai kahin, somewhere I've seen him. Oh, he was in dams. Oh, this is my teacher. No, this is known as prosopagnosia. So this is a term which is applied for inability to recognize faces, prosopagnosia. What kind of amnesia is it? Visual. The lesion is more likely in the right non-dominant hemisphere of the brain. Okay. Now, somewhere you remember this, that this visual amnesia, or visual amnesia in which the person cannot recollect a thing on seeing it, is not generic. Like for example, he will see a car and will tell it's a car, but which brand is it, which car is it Maruti or Mercedes or Audi? He doesn't know. Okay, see, I also see Mercedes, Audi, I don't know because I don't have them. Okay, that's a different story, but this patient will be able to recognize, like face for a face, able to recognize face for a face. Like I'll show someone's face to him and he will tell, yeah, this is face, but whose face is this? He doesn't know that. Now I'll tell you another example. In my residency days, I got a patient in my hospital, an old man who suffered with a stroke. And then when the relatives brought him to the hospital, they had a single line complaint about him. Said since morning, our uncle is not able to recognize all of us. None of us he can recognize. And now I asked them, then why did your uncle come with you then? He said he is able to recognize her on voice. So this is something important now. Able to recognize for a face, but whose face is it? He is not able to recognize, but with auditory clues, write it down, with auditory clues, recognition is possible. So with the auditory clues, the patient can easily recognize. Okay, right. Hmm. If guys you have attended my season 1, you must be knowing me very well that I am not fond of topics. I am more fond of MCQs. Neuro as a topic is incomplete. If you don't solve any MCQ. Okay? Chal. Let's start with it. You'll get these questions. I'll try to put it on Facebook by the end of the day. Don't worry. Okay? Or maybe uh, I'll just put up a PDF and your franchisee will give it to you. Okay? But that sometimes depends on your relation with the franchisee. I've seen it. So I'll put it on the Facebook. That's fine. Question number 1. We'll take a break after this. So Tukde gang students, keep quiet. Okay. 26-year-old male, known case of rheumatic heart disease with atrial fibrillation, presents with acute onset weakness of left side of the body, both upper limb and lower limb, which has recovered in 20 hours. Please read this question carefully. CT scan brain showed ischemic changes in the right internal capsule. Let me define stroke again for the 10th time today. Even the walls of this room know the definition of stroke. It is defined as neurological deficit due to focal vascular cause or radiological, yes, evidence of infarction. Condition apply. This thing should be there for more than 24 hours for anyone. Or radiological evidence of infarction. Got my point? So don't mark it in a hurry. This is TIA. This is a very simple question. No. This is embolic stroke. Why is it not a case of thrombotic? I'll come to that later on because we'll discuss embolic separately. Because atrial fibrillation as an arrhythmia gives rise to embolic stroke more frequently. Okay, so we'll come to that concept. Why is it not thrombotic? Why is it embolic? Transient ischemic attack. No, why not transient ischemic attack? Because there is radiological evidence of infarction, irrespective of duration of the episode of weakness. Ischemic changes in the right internal capsule. Okay, so don't mark it as TI in a hurry. It's embolic, simple. Question number 2, simple, easy question. Which of the following has a maximum area of representation in the cerebral motor cortex? Shoulder joint, elbow joint, wrist joint, or the first metacarpophalangeal joint? First metacarpophalangeal joint. Just a fact. Okay? Just a fact. You know, whenever I discuss this question, everyone takes home the message that the first metacarpophalangeal joint is the having the maximum area. No. This is for the MCQ the correct answer. But can you tell me the largest area of representation motor is for which group of muscles? Which group of muscles are having the largest area of representation that is motor? Can you tell me? This is given in Genong very well. Any answers? Not the hand, not the vocal, larynx, vocal cord are the same thing. Okay, you are speaking with your tongue, larynx, both, pharynx, yes. Muscles of vocalization, remember this. They actually occupy the largest area, not the tongue. They put everything into a single apparatus, the vocal apparatus. It is not only tongue, it is pharynx, larynx, everything. Okay. Now, which area? Someone wrote lips has got the largest motor area. No, it's not the lips. It's not Imran Hashmi. Sensory, yeah. The largest sensory area, that is for the lips, not the largest motor area. Okay. So remember these two facts of physiology being commonly asked nowadays. Some people are seeing the emoji and then wondering where is the joke. You have to be attentive for that. Uh, Patient suffers left hemiparesis due to ischemic stroke with destruction of area number 8. Area number 8 was what? Frontal eye field. And my patient had left hemiparesis. Left-sided body was weak, correct? That means the lesion is what? In the right cortex. And is very well said ischemic stroke due to destruction. So it is a destructive lesion in the right cortex of the patient causing left hemiparesis for the patient. Where are the eyeballs going to deviate? Very simple. If the frontal eye field on the right side suffers an injury which is destructive, the eyeballs are going to deviate towards the lesion. Simple. B. So we don't look here and there. The answer is B. Simple. Okay. Arrange the following structure in a sequential order of flow from origin in the direct pathway. Direct pathway was easy, no? Come straight, get into thalamus. So that is easy now. What comes first? Cortex. What comes after that? Striatum. What comes after that? The globus pallidus. And what comes after that? 4. Okay, let me arrange it in a different way. 4. Okay, 1, right, 2, right, and the last 3. So which is the correct answer? The answer is B. See, there's a trick in solving such questions. These are very common questions in Ames pattern. If you know the first and the last, you can hit the bullseye. Okay, but the only thing that you need to know what are the other two between the two. Okay. Right. This is something from anatomy. I've not gone into sections by making them. You already know a lot of it. Damage in the area marked in the image would result in which of the following deficit in the patient? Please tell me. This what marked gray is what? The frontal lobe. And it's head part of it. Yes. The prefrontal area. Prefrontal area. And the prefrontal area being damaged, what are we going to see? Personality changes, antisocial behavior. Okay, just have a clear idea on all these areas. There was an inferior frontal gyrus. Which area was sitting there? The number was 44, 45. What was that area? The Broca's area. Okay, the inferior frontal gyrus. Then there is this wala. This one is a primary motor area, number 4. In front of it, what happened? In front of it, what did we have? Was area number 6, the premotor area. In front of that, what did we have? The area number 8, the frontal eye field. Okay, I've just drawn actually Broca's here. No, it should be slightly above. It's fine. Okay, so that's the recap of the areas that you find in the frontal lobe. Okay. Deficit in the following sensory modality being tested occurs due to lesion in which of the following area of the brain? This female is trying to touch an object like a comb, and now she'll be asked which object have you touched, and she has to just point out what object is it. Okay, it's a comb. So you can touch a comb without seeing the comb and you can tell me what it is stereognosis, and stereognosis requires which area? Sensory association area, parietal lobe. Simple. Okay. Hmm. Damage in this part of the brain would result in which of the following deficit? Now we have gone into the parietal lobe. Okay. So if this was the sulcus, the central one, in front of it was the area number 4, in front of it was area number 6, even anterior to that was area number 8 for frontal eye field, and now the inferior frontal gyrus had the area number 44 and 45. Okay, I'll just number it there, 44 and 45. This is for the Broca's area, right? Correct. Now 3, 1 and 2 is the primary sensory area for localization. Behind this is area number 5 and 7. That was my sensory association area. Sensory association area. Okay. Here is area number 39 and 40. What is that? For understanding, did you understand? Wernicke's area. And the occipital lobe is quite simple. Area number 17, the visual cortex. Okay. So this is a very simple one. This is the sensory association area we have tried to mark. And what is the deficit there? Astereognosis. Right? So it's not a very tough job. Go back and read this diagram again in your anatomy books, better given there. I've tried to connect it with medicine. A patient with Alzheimer's disease cannot dress up on his own, cannot find the bed in the ward, neither can copy geometric patterns. Patient denies that he is suffering from any problem. Alzheimer is a disease which involves degeneration or atrophy. Now, which part of the brain is likely to get involved? It's a very simple answer. There should not be any left to right confusion for you. You are not Ishan Avasti, I know that. You are intelligent, brainy students, IBS. Yes, cingulate gyrus or babre. Angular gyrus on the right side. Cheek, no problem. Lesion in angular gyrus with intact Broca's and Wernicke's leads to what? This is possibly the simplest question. Broca's and Wernicke's we have discussed in the previous classes. The Wernicke's was for comprehension. The Broca's was for speech output. Both of them are required for a common thing. What? Repetition. But what is the angular gyrus now going to do? It is going to read the word which is written in front of me, understanding the written text. Correct? The A is the correct answer. You can rule out every option and get to the best answer. Okay. Now another question, arrange the structure correctly in the ascending order of transmission of auditory impulse for hearing. Who comes first? The cochlear ganglion comes first. That's number 4. After that, what comes in? The trapezoid body. After that, what comes in? The inferior colliculus. And the last one in the race will be the medial geniculate body. The cochlear ganglion is somewhere outside as a ganglion, outside even medulla. Okay? Yes, 4, 2, 3, 1. This has been repeated in names in all the exam last year, I remember. This came in your AIMS question bank this time. A very simple question. A physiology Viva examiner asked to a student who recorded the first EEG. The student responded, I don't know. But the examiner did not say come after 6 months. That's an addition from my end. The examiner felt bad because he was also a student once like him, Saas bhi kabhi bahu thi. And the examiner felt bad, oh my god, and decides to give him a hint. The name rhymes with what you get from Haldiram of America, McDonald. And then the intelligent, brainy student, the IBS student came with the right answer. Sir, hamburger. Okay, what is this known as? It's known as priming. Okay, because a recall which I could get initially, someone has written non-declarative also in the option, but I went to every student, kept on asking them. Then it's very difficult to answer it. Okay, so if you put an option like non-declarative memory over there, then it's very difficult to answer it. Like question comes in exam like the COVID virus started in China or Wuhan. So is it priming or a country? So it's very difficult. So anyway, this was the correct recall and the easy answer is priming, no doubt on this. Okay, right-sided temporoparietal lobe injury, right-sided brain injury. Okay, leads to all except. Oh, sorry, right-sided. No, I read it wrong. Right-handed. Right-handed. Right-handed person temporoparietal lobe injury. Okay, right-handed person has got the speech area where 90%, if you remember, Wernicke's aphasia can occur. Acalculia angula garis can occur. That superior contractic anopsia was temporal lobe. Okay, can occur. Where are we sitting? What is not seen? Urinary incontinence. Okay, urinary incontinence is occurring when the lesion is which lobe? Not temporoparietal but frontal lobe. Chalo. Now, before we try to proceed into the chapter of stroke, we would like to first classify stroke uh, and see what are the things, how do we classify them clinically, everything. For this, remember this, cerebrovascular accident or stroke, of course, as a vascular event that you know, okay, is of two types. Either the vessel in the brain which is supplying the blood has been blocked, or the vessel that is running with the blood has got ruptured. So maybe clinically when I see the patient or radiologically, there are two subsets of patients that we find. One is the ischemic stroke. Okay. Second wala is the hemorrhagic stroke. Ischemic stroke, as you see, there is less amount of blood due to some thrombus sitting inside the vessel, and the hemorrhagic, the blood leaks out from the vessel. Okay. Now the ischemic stroke is of two types, that is embolic or thrombotic. As the word embolic goes, it is an embolus from somewhere else, right? Thrombotic is a thrombus formed in situ within the vessel. We find clinically that around 85% of patients with stroke are ischemic and 15% of patients of stroke are hemorrhagic. And when we look at the embolic are the major amount in ischemic, that is 75%, and 25% are thrombotic. So overall, when I look at the type of strokes, okay, it is something, the embolic stroke, which is found to be most frequent and most common, right? Uh, Before we move into the ischemic stroke, let's try to read from the basic what is the blood supply of the brain and which part of the brain is supplied by which artery. For this, we'll make three kinds of diagram in a view. Okay, so we'll make a section, not a section, but we are trying to see the brain. Okay, this one is the lateral view of the brain. This one is the medial view of the brain. So we are looking at the cortex. The viewpoint is lateral or the medial. In the lateral view, one thing which we find correctly, the blood supply is like this. The anterior cerebral artery or the ACA happens to supply this part complete as a strip. Okay, so I can do one thing. I can go with the shading on this. this one. So this blue shaded part of the brain is the supply from the artery anterior sublateral. So let's look into the lateral view. It is supplying a strip in the superior part and thus tries to touch the occipital lobe, the anterior sublateral, while in the medial part it supplies a larger area like this. The second one is the MCA. So now the second artery, which is having a larger chunk in the lateral view, is the MCA. So this one is the middle sublateral. Okay. So what are we left with? One more artery. Yes, that is a posterior sublateral. That will supply the posterior part like this. So this is where you see the lateral and the medial aspect of the cortex. What all area could it be supplying? So one thing is very clear, the occipital lobe, if you look at, will go to the PCA. Major part in the lateral view, as you can see, is going to the MCA. In the medial view goes to the ACA, and a thin strip like this, actually it's not that big, it's thin, in the lateral view goes for the ACA. Okay, but another viewpoint is the inferior view. If I look at the brain from below, how is the blood being supplied to the brain? Okay, so this is the optic chiasma or the pituitary gland over here. Okay, now this part, I'll follow the same coloring scheme. This one, okay, stands for the ACA. So one thing is very clear, the medial most part, even if I look at the brain inferiorly, is supplied by the ACA. And then lateral to that, comes in your middle sublateral, and the posterior one, like over here, has to be the posterior sublateral or the PCA, right? So this is how the blood supply of the brain looks like. So if you remember this diagram, you'll able to understand one major concept, that we find somewhere the medial most part of the frontal lobe, if I look at below, is supplied by an artery known as the ACA or the anterior sublateral. Okay, rest of the motor cortex, if I look at, is always being supplied by another major artery, that is the MCA. So let me project everything into a different view to understand it better. Like if I want to make the homunculus again, I would see like this: the lower limb, the paracentral lobule, the trunk, arm, forearm, and big hand somewhere, and the face. So one thing is clear, that one artery which supplies the paracentral lobule is the ACA. The rest of the motor cortex is being supplied by another artery known as the MCA. Right? Okay. I'd like you to take one full page for this one. Take one full page for this diagram, because we're going to project the diagram below. So it's going to start above and come down along the tracks. Okay. I'll go into detailed clinical view of ACA and MCA and PCA, how do they differ from each other. But before this, the track should be very clear in your mind. So my humble request to take one full page for this work. The paracentral lobule is by the ACA and rest of the motor cortex is by the MCA. What is important in the motor cortex? As you all guys told me, the bed cells, which are sitting somewhere in the layer 5 of the frontal lobe, from where the origin of the track occurs. And the track was nothing but the track which is coming down like this is what? The corticospinal or the pyramidal track. Can you tell me these radiations, which are coming down, the motor cortex, the radiations which are coming down in the motor cortex, what are these radiations known as? Are they known as the motor radiations, pyramidal radiations, or some viral radiations? What are these radiations known as? Corona radiata. Okay. So somewhere the radiations which are coming down like this, okay, are looking to me in a inverted shape like this. This is the pyramidal track, like an inverted pyramidal. Okay. Now we are looking at the brain in a coronal view, like this. We are cutting the sections coronal, and then we'll go down transverse sections and see this. Everything will converge over a point here. As you remember, yes, this structure is a very important structure where everything will come. Yes, the internal capsule. If you remember the basic anatomy again, the internal capsule has got three parts of it: the anterior limb, okay, the posterior limb, and there is a bend between the two is known as a genu. So what we find somewhere as a representation topographic, just a second, a topographic representation that we found in the cortex is somewhat different in the internal capsule. Now what do you find here is that the face comes and occupies an area in the internal capsule that is near the genu part, okay, and the upper limb and the lower limb comfortably sit in the posterior limb of the internal capsule. Now don't forget this line. Posterior limb of internal capsule is supplied by an artery known as the middle cerebral artery. Okay. Now the middle cerebral artery, if it gets a lesion in the internal capsule, the posterior limb, the lesion is going to be anatomically as well as radiologically a very small lesion. It is just going to be a lacunar infarct. I'll discuss that topic separately again. So these infarcts which are so small, they are known as lacunar. As the word lacunar comes from a Greek word that means lake, lacunae. So there's a big sea and a small collection of water, lake. Same, there are big infarcts and there are small infarcts which look like a lake, lacunar infarcts. Okay, so you can write the word as the lacunar infarction. If there is a lacunar infarct in this internal capsule posterior limb, it is going to be a small lesion. But the problem is the deficit which the patient is going to face is going to be big. It is going to be a large deficit because every corticospinal fiber which is convergent has been cut off now. Okay. So what do you find clinically in the patient? Clinically, when I see the patient, one side of the body is weak, hemiparesis, right? But it is known to me as a term dense hemiparesis. Why the word dense is applied? Because fibers are together and they are more dense in this part where the lesion occurred. So the term is not just the weakness on one side as a vague term hemiparesis, it is applied as a term dense hemiparesis. Only the fibers which are motor are involved in them. So we know it as the pure motor hemiparesis. So we got terms with it. Internal capsule, okay. Right, should not be the convexity medial side. You are right. I'm just drawn a mirror image. I'm very sorry. Okay. You can just draw the convexity on the medial side. I'm very sorry for that. Okay, some silly mistakes. Right. Pure motor hemiparesis, dense hemiparesis. Now, something very important now is this. If I take this as a midline, if they take it as a midline, just below the internal capsule and the basal ganglia comes an area which is the brainstem. Let us rewind the brainstem again. That is made up of the upper part which is known as the midbrain. Okay, and then below the midbrain is your pons. Below the pons is what? Medulla, right? Why I'm trying to put down this whole now look at the orientation, please. We were somewhere in the cortex above. We started with bed cells, came down with the tract corticospinal pyramidal. What was above was more of a coronal view. Now when I come down to the level of internal capsule, I'm trying to make a transverse view so that I'm able to see in the horizontal plane what is happening with the tracts. Now as I come down into the brainstem, the midbrain, pons and medulla, again I'm taking a transverse section, okay, in a horizontal plane, right? Now when the corticospinal tract comes down in the midbrain, remember this, it occupies the interior part of the midbrain. Something from the previous lectures we have attended with me, and anatomy also sir tells you that this deeply pigmented part of the midbrain which synthesizes dopamine was substantia nigra. But there are fibers which are coming down through it from the brain cerebrum. So this area is known as what? The crus cerebri. Finally it comes down to the pons and it reaches the medulla. Why I'm trying to project the diagram downward like this, because something very important and never to forget. We try to move down and medially. So the orientation in a three-dimensional plane is not vertical only, it's slightly medial, because at the lower part of medulla, when the projections known as pyramid come in the interior part of it, you know this whole drama will cross the midline and come down like this, where another area below, which is nothing but a relay center for any sensory and a motor thing, that is known as the spinal cord. Right? Somewhere I rewind again. There are some discrepancy in percentages, that's fine. 85% of fibers, majority, are going to cross the midline in the lower part of medulla to come down in the spinal cord. Now please follow the diagram very well. This is very important. Medulla it crosses, it comes down in the spinal cord, but now if you can look in the diagram please again, in medulla it was medial, but when I come down in the spinal cord it comes down lateral. That's why every time when you hear the term corticospinal, they always apply a term over it as a lateral corticospinal, because it is coming down in the lateral column. And then finally it ends at a gate. Yes, to come out as a nerve for a perfect muscle. Now this gate where it ends is a cell which is present in the anterior part of the gray matter. That's why the name is the anterior horn cell, being abbreviated to me as a term AHC. Finally it will come down as a nerve, out as a nerve, sorry, towards a muscle. Now you must be knowing this fact from physiology that around 15% of the fibers are not going to cross the midline. Okay? Now they are going to come down in the spinal cord and at a particular segment, and through interneurons, connecting the two sides of the spinal cord, they are going to cross. So look at this now. The part which doesn't cross, I can write the word as uncrossed corticospinal tract, is going to come down, and it is not known as medial corticospinal, it is known as anterior corticospinal. It's not too much in amount, it's just the 15%. Okay, some authors do write it as medial, but in most of the books I have found the word anterior along with it. Okay. Now what is the major difference? Something from physio, ma'am keeps on repeating this old concept. The lateral corticospinal tract is for which group of muscles? The distal muscles. Don't forget this term. And the anterior uncrossed wala is for what? The proximal muscles. Now that's an easy clinical difference. Like if I ask you the muscles of the hand, okay, they are away from the axis, that is distal. But the muscles of the trunk or the shoulder or the neck part are the proximal muscles. So the control from the brain happens like this. But ultimately, both of them are going to supply the muscles of the opposite side. When the signal originates from the left brain, the right side of the body moves. When the signal originates from the right brain, the left side of the body moves. Now this is something you already know. Most of you know this diagram very well. But what is the medicine part here now? Look at this. If there is a lesion in medulla, pons, midbrain, internal capsule or the cortex, you understand this, the weakness is going to be on which side? Contralateral opposite side, correct? But if at all the lesion is below the crossover of medulla, that means in the spinal cord, the weakness is going to be on which side? The same side. So remember this concept. Write it down. This should be very, very clear in your minds. Any lesion, okay, above decussation. Now I'm using the word decussation for the easy reference because upper medulla. Now I'm using the word decussation because the upper part of medulla, the fibers haven't decussated now. They have not crossed the midline. Weakness is going to be on which side? Contralateral side. Opposite. CL stands for contralateral. But any lesion which is involving, oh, spelling mistakes. Any lesion below medulla or below decussation, the weakness is going to be on the ipsilateral side. Okay. So that's a very old and easy concept to always carry forward before we go into the drama of stroke or myelopathy anywhere. Okay. Right. Now look at this diagram again. Something we'll utilize in the brainstem syndromes also. The corticospinal, whenever was moving down in the brainstem, it was always in the direction downwards and medial. That means any lesion in the lateral pons, any lesion in the lateral medulla or maybe lateral midbrain is not going to involve the corticospinal tract. Okay, simple. But most important thing you should know, what kind of weakness do you see in the patient? Paralysis. Remember this, paralysis is of two types, UMN and LMN paralysis. A bit of it we have already tried to touch upon in the previous classes. Okay. Tone increases in UMN, tone decreases in LMN. I hope you remember this. UMN, the tone increases, spasticity. I hope you remember this. When the stiffness keeps on increasing and the last part it suddenly gives away, clasp knife rigidity is spasticity. Element, yes, we have discussed this also previously, is showing what? Flaccidity. The tone is decreased. Another quick fact, deep tendon reflexes, which you commonly do with a knee hammer. Strike the tendon insertion deeply with a knee hammer, DTR. The deep tendon reflexes are found to be brisk in UMN and are commonly found to be dull and absent in LMN. That means hyperreflexia is something found in UMN, hyporeflexia is found in LMN. And I hope you remember the plantar also that you commonly do in your ward, the plantar response. The plantar response in UMN is what? Extensor. Extensor. It's also known to me as the Babinski sign positive. Right? So how do you do a plantar? If you imagine this as a sole of the patient's feet, okay, you take the knee hammer, start it from the middle end, strike it on the sole of the patient's feet. Start it from the lateral side, reach the ball of the big toe. If all the toes are coming down, that means flexion is occurring. It is a flexor plantar. If toes are going up and there is extension of the small toes, this is known as an extensor plantar. I hope you know the basics. The normal plantar is flexor and the abnormal plantar is always extensor. And an extensor plantar response is always known as the Babinski sign positive. Nomenclature, very important. Because I remember in my MBBS, I presented a case of stroke and I told the examiner, sir, the Babinski is extensor. Examiner looked at me and said, come after 6 months. I thought the examiner was having Wernicke's aphasia. He could not understand what I was telling him. But that very day, I was having conduction and Broca's aphasia. I was not answering him correctly. Okay. On the other spectrum, element, yes. In the element, what do you find is wasting and atrophy. Remember this fact that the nerve doesn't stimulate the muscle to contract. It also sends some trophic factors to grow all the time. Now when the nerve is cut off from the muscle, yes, we find that the trophic factors don't reach there and the muscle starts atrophy and wasting. There's another term known as fasciculation seen in element paralysis. The word fasciculation means a twitch. The word twitch basically stands for a visible or a palpable movement of the muscle. So the patient tells me in his own vernacular language maybe that his hand muscles or the forearm muscles, for example, he cannot see them. There is skin and the bone. The muscle is not there at all. But suddenly below the skin, he can see some movement. He can feel some movement like some worms are crawling below his skin. These are not the worms. This is nothing but your fasciculation phenomena. Okay. Remember this. Fasciculation phenomena is something very commonly come across in element when the lesion is at the level of the anterior horn cell. Now look at the term anterior horn cell. Okay. This though I forgot, you guys tell me what is UMN and what is LMN. I hope you know this from physio and anatomy so well that anything, remember this, anything which is standing, I'll make a diagram here, that will be better. Like I'll make a small diagram. This is the cortex coming down the corticospinal, crossing the midline, okay, stopping at a gate anterior horn cell to become a nerve for a muscle. Remember this, as the anatomy nomenclature goes correctly at this point, anything above the anterior horn cell is anatomically and clinically defined as the upper motor neuron, UMN, while anything in the anterior horn cell and the nerve is defined as the lower motor neuron or the element. So what do we catch from here? That means to cause a human paralysis, the lesion has to be in the corticospinal tract. But on the other spectrum, if I want to call a lesion to be element, where it could be? It can either be in the anterior horn cell or the motor nerve. So make this concept very clear before we move ahead anywhere, that whenever the lesion is corticospinal, the paralysis in the patient is UMN. Whenever the lesion is anterior horn cell or the motor nerve, the paralysis will always be typically LMN. Okay, right. Explain the Babinski sign again. Okay, I'll play a video with me, if I'm having it. Follow this video once. I'm trying to strike the sole of the patient's feet from the heel on the lateral surface or the lateral margin of the foot. I find like this. I find actually nothing. It was a very thick-skinned sole. That's why I could not elicit anything. But I'll play a plantar which is more flexor now. Yeah, this one is a flexor plantar. Now follow this. When I try to rotate on the patient's sole of the feet, okay, like this, the big toe comes down and the small toe try to come down. That is known to me as a plantar, which is flexor. Now how does an extensor plantar look to me? Okay, extensor. Okay. Follow this. Fine. When I try to strike the sole of the patient's feet, the big toe goes up and the small toe fan out. Yes. Okay. So this is something which is known to me as a plantar, which is extensor. Now the plantar which is extensor is written by a nomenclature, Babinski sign positive. Okay. Do we hold the foot? Why do we hold the foot? Okay, you can, it's all up to you. I was holding the patient's foot because the patient got very apprehensive. Okay, maybe I was trying to touch his feet and say, please cooperate with me. Okay, because I had a patient in my hospital, every student used to go and see him, neuro case, and every student used to catch his foot and strike the knee hammer, the blunt end, or maybe the key, and try to check the plantar. The patient thought that every time anyone comes does this only, and one holiday in the hospital no one was there to look after him. I was seeing that he was checking his own plantar. Possibly he was thinking that this is part of my some therapy they are trying to give me. Okay, right. So this is the basic UMN element. You should know this fact. Now one thing is clear, like if there is an infarct in anterior cerebral artery, if the infarct is in the anterior cerebral artery, okay, if you remember the basics of circle of Willis, we'll draw it again. But if you remember the anterior circulation, yes, I'm just drawing the circle of Willis anterior view, anterior circulation of it. The ICA, the internal carotid, bifurcates at the base of the brain into ACA, the anterior cerebral artery. Oh, drawn the direction just opposite. And this wala is the middle cerebral artery, or the MCA. Correct. See, The plantar flexor extensor depends, like if there is a lesion in corticospinal tract on one side, only that side is going to happen to have the plantar extensor. The normal side will always have it as a flexor plantar. Okay. Paraparesis, I'll talk to it separately in myelopathy tomorrow. Okay. Now the ACA is going to connect with each other like this with the help of a communicating artery, which is known as the anterior communicating artery. So there are going to be two kinds of lesions. Either the ACA gets blocked here or the ACA gets blocked here, right? Now just imagine this. This part and this part is different. This part is before the communication and this wala is after the communication. So I can name this as pre and post. Communal. Okay, so it's pre and post communal in a sense that it is something before and after the communication. But how are they going to be different? Like if there is an infarct, okay, which is pre communal, another AC infarct which is post communal, right? Please tell me, pre-communal infarct, will it have any neurological deficit or no? Please answer me, yes or no. It's a simple question from my end. Will neurological deficit occur in such patients or no? If it is before the communication, please answer me, yes or no, Y or N, simple. No deficit, my dear friend. Why? Because if this side is getting blocked, the other side is going to reperfuse it. Okay, I say a patient has got a lower limb weakness and he recovers after maybe 1 hour or 2 hours. What is that known as? Transient ischemic attack or TIA. So if at all something happens, it is going to be a very transient phenomena. But the post-communal, yes. What is going to happen? Lower limb weakness. Now my question will be contralateral or ipsilateral? Please answer me. Contralateral lower limb weakness or ipsilateral lower limb weakness? Contralateral weakness. Because if the cortical lesion happens on the left side, right side is gone. Happens on the right side, the left side is gone. So it has to be a post-communal kind of a ACA infarct. What have I written? I'm eating words today. Infarct in ACA, not in fact. Okay, simple. But there's another entity in which you find in the patient unpaired ACA infarct is there. Now, what do you mean by the word unpaired? This and this are paired to each other, but this ACA and this ACA are not paired with each other. In the sense, the communicating artery which should be there between the two is now missing. Okay. And you find this ACA infarct on this side and this side, both side. Look at this, unpaired ACA infarct in the sense communication is not there and infarct is on both the sides. Please tell me what can be the deficit now. Calculate it. Lower limb are going to be weak, one. Second, yes, one more thing. Bilateral lower limb weakness because both the side the ACA is gone. One more thing, urinary incontinence. If you remember, the paracentral lobule is something which is supplying the bladder in a sense, telling me where to mixture it. Now, I'm using the word unpaired in two sense. First of all, the infarct is in both the arteries, one. and there is no communication between the two. So bilateral lower limb weakness, we'll discuss that topic tomorrow in myelopathy, paraparesis. Now don't forget this, that the prefrontal area is also being supplied. The prefrontal area is also being supplied by the ACA or the anterior cerebral artery, right? Now, if there is a prefrontal area involvement, what are we going to see? The antisocial behavior. Because the anterior cerebral artery doesn't only supply the paracentral lobule, it also supplies the prefrontal area. That means a patient of stroke has come to me with a behavioral abnormality. So we find this problem with them. Okay, if it is bilateral post-communal, yes, it can happen again. Same way, always bilateral, most of the time, bilateral. Now going to the middle cerebral artery, MC infarcts. Below the urinary lower limb weakness, I've written urinary incontinence because the paracentral lobule, yes, was also responsible as a micturition area to guide me where should I micturate. Okay, fine. See, difference between post-communal unpaired and paired is this. In post-communal, which is paired, you find contralateral lower limb weakness because this side is having a normal supply. There is no problem with it. While if it is unpaired or it is post-communal on both the sides, then both the lower limb are going to be weak, paraplegia. Okay. Yeah, why no incontinence in post-communal? See, what I could understand that in the bladder circuit also, if one side is not working, the other side is working, they're going to compensate for it. Okay, so there's not much of a problem in it. Above the antisocial behavior, I've written urinary incontinence because of the lesion in the paracentral lobule. See, post-communal, why no urinary incontinence? Usually because if one side is not working, the other side tries to compensate and make the things happen. Okay. No neurological deficit in pre-communal because if this side is getting blocked, the other side will send the blood and reperfuse it. There's no problem. So if at all something happens, it will recover fast. Okay. Okay, if there is an infarct in anterior communicating artery, I don't think so. There should not be any problem then. Things should work on their own like this. What is difference between paralysis and paresis? Good question. Good question. I've discussed this previously with you guys also once that what happens is that the paresis is somewhere defined with power in a limb 1 by 5 to 4 by 5. Okay, while paralysis, or rather I can put the word as plegia, is applied to no movement at all. That means the power in the limb is 0 by 5. Okay. In post-communal, we don't find any antisocial behavior or even your urinary incontinence. So the salient features of ACA infarct will occur when unpaired ACA infarct occurs. Okay. Okay. Now let's go to the MC infarct. MC is very simple. We know that the middle cerebral artery is like this running. but it is dividing into two divisions. Okay. Now the division which goes above is the superior division. The division that comes down is the inferior division. Okay. Now what do we do here is that if we create a lesion in the MCA, okay, at this point, that means the entire territory of MCA is involved now. If at all there is a lesion in the entire territory of MCA, what can be the neurological deficit? Okay. Remember this. In these patients, when the entire territory is involved, what do we find? Hemiparesis. Paraparesis, paraplegia goes with ACA, most likely post-communal, not post-communal in the sense, but unpaired ACA, bilateral infarcts. Okay. Second thing which we find in these patients is aphasia. Can you guide me which aphasia would be seen in MCA infarct which involves the entire territory like this? Wernicke's, Broca's, or global? Can you guys tell me please? If MCA infarct occurs and it involves the entire territory, obviously my dear friend, it is going to be a global aphasia. Global, everything is gone. While if the superior division is involved, you find hemiparesis, right? Because the superior division basically supplies the motor cortex, most of it. Okay. This hemiparesis or hemiplegia is contralateral because the lesion is sitting above the medulla. That's correct. But very important thing, what aphasia do you find in them? Broca's aphasia. Broca's aphasia. Okay. But in inferior division of MCA, remember this, hemiparesis is not seen. Hemiparesis is not seen in inferior division of MCA getting involved. Please remember this fact. It is a superior division which supplies the motor cortex majorly, not the inferior division. But what are we going to see in such patients? One thing you know is Wernicke's aphasia, because Wernicke's area, we have discussed it earlier, is supplied by the inferior division. Okay. Second thing, Wernicke's aphasia will occur if there is a left-sided lesion. I repeat, because the Wernicke's and Broca's are sitting in the left hemisphere. Okay. But what about the right-sided lesion? What about the right-sided lesion? For them, aphasia will not be a problem. They will have a different problem in constructing out thing. What? Constructional apraxia. Constructional apraxia. So I'll just summarize. I've tried to not take you into a hi-fi drama on this topic, but just try to focus on this part. If MCA infarct involves the entire territory, okay, hemiparesis will occur in the patient. One side of the body will obviously be weak because the motor cortex, the major part, goes with it. And aphasia is going to be global. Why? Because superior division supplies Broca's, inferior division supplies Wernicke's, and both of them are gone. But remember, conditions apply. The lesion has to be on which side of the brain? Left hemisphere. Then only, because the dominant hemisphere will cause aphasic problems. Superior division of MCA, if it is involved, not the entire territory, we find contralateral hemiparesis. Is it left or right? Whatever side. And Broca's aphasia if there is a left-sided lesion. If the inferior division occurs to be involved, then when we don't find hemiparesis, we find Wernicke's if it is a left-sided lesion, while if it is a right-sided lesion, we find a construction apraxia. Okay. If the superior division is involved on the right side, then only hemiparesis will be the clinical feature, nothing to do with aphasia. See, most of the questions are hovering around these small concepts. They give you like this: a patient has come to you with hemiparesis with Broca's aphasia. Now, which artery is involved, which territory is involved? It is MCA superior division. Okay. Entire territory may it is going to be a contralateral. Remember, my dear friend, any lesion above medulla, contralateral weakness. Yeah, inferior MCA supplies the angular gyrus. There are many more symptoms than this. Actually, I'm not trying to complicate it. I want to keep it as simple as this. Bilateral MCA occlusion. Then God is uh, the only thing that can save the patient. Okay, it's going to be a quadriplegic patient maybe. See, contralateral concept is very simple. Any lesion which is somewhere above medulla, the weakness is going to come on the opposite side. Okay. Now, very important, another thing which has been recently asked. There are some named MCA syndromes. MCA in fact sometimes have a named thing also with them. Okay. Brachial syndrome. Brachial syndrome. As the word brachial goes, it is with a particular limb, okay, especially the upper limb. In brachial syndrome, only in the patient, hand, arm, and maybe the face is weak. So a brachial syndrome is an MCA syndrome in which the upper limb and the face is the only affected part of the body, not the lower limb. Okay. There's another named syndrome with MCA that is known as the frontal opercular syndrome. Frontal opercular syndrome. In such patients, patients will have Broca's aphasia with or without the arm weakness. So just know the names of these syndromes. Frontal operculum syndrome. A Broca's aphasia patient with or without arm weakness is known as frontal opercular syndrome. When only arm weakness or the upper limb and the face weakness is known as a brachial syndrome. Okay. See, remember this two cortex. I'll make it simple, yeah. Guys are so worried. What will happen, sir? Dekho. These are the two cortex. Okay. Let me label this, for example, the left and the right cortex. Both of them are getting a supply from artery on either side, that is your middle cerebral artery or MCA. MCA is dividing itself into two divisions, superior division and the inferior division. Now, if at all there is infarct in MCA, the entire territory on either side. Okay, I'll just keep it on one side to avoid any confusion any further. Okay. If there is MCA infarct in this part, entire territory in the sense like this, from where it is originating, obviously the weakness is going to be what? Contralateral. If it is a left-sided lesion, what are we going to have? Aphasia. Correct? What type of aphasia? Wernicke's and Broca's combined. Global aphasia. So let me mark this as 1. So the lesion in MCA, the entire territory is going to present like this. Okay. Second and the third. Second, what are we going to find? Opposite half of the body is weak, contralateral weakness. With what aphasia? Broca's aphasia. Inferior division, what do we see? Do we see weakness? No. We find what? If it is a left-sided lesion, we find Wernicke's aphasia. If it is a right-sided lesion, you find what? Constructional apraxia. So try to focus like this. It's very simple. Okay. Right, any doubts on this? Okay. Now let's try to look at another artery, which is the posterior cerebral artery. This was a question this year in NEET PG AIMS. Everywhere we found a question based on it. Okay. So there is a Binod in the chat box who is asking me one question again and again. When will endo start? Endocrine will start when neurology will finish. Simple answer. Okay. Ayo, shouldn't the lesions be ipsilateral because the fibers haven't crossed? Oh my god. I think so. We are not on the same page. I repeat again. If the corticospinal tract hasn't crossed, you have a lesion, the weakness is going to be contralateral because this half supplies the opposite side. Okay. Now the most important, posterior cerebral artery. Posterior cerebral artery. Posterior cerebral or the PC artery want to make a diagram of it. It will be better to explain it. So I want to cut the brain in a transverse section and see it. Now the structure which are supplied by the PCA, posterior cerebral artery, are very atypical. They are the medial and the posterior part. Okay. One part, if you try to look here, somewhere if I remember the brainstem, the basal ganglia, the medial most part was made up of what? Thalamus. So thalamus has got two nucleus, the medial nucleus and the lateral nucleus. Remember this. In PCA, the medial nucleus of thalamus is involved, okay, as well as the lateral nucleus of thalamus is involved. If at all the medial nucleus of thalamus is involved, I'm not going into why it all happens, just remember this. In the patient there is hypersomnolence. That means increased sleep. The medial part is also important to control the behavior. There is also behavioral abnormalities present in the patient. Okay. Lateral nucleus of thalamus, will be touching upon the lateral nucleus very often in spinal cord tomorrow. We'll have hemisensory loss in the patient. We're going to have the hemisensory loss in the patient. Right. Then the medial part of the temporal lobe is involved. Okay. The medial part of the temporal lobe is hippocampus, which is nothing but your gateway of memory. So what do you find here in these patients? A typical memory loss is seen, right? Then there is a connection between the two cortex all the time, not the hippocampus, the two cortex. Can you define me what is this connection known as? Can some of student can tell me what is this connection known as? Hey Baba, you're taking so much long time. My God. Splenium, splenium priming of splenium part of corpus callosum. Now please tell me from your long-term memory, if the splenium part of corpus callosum occur, what will happen to the patient? I'll do some priming on this. A particular type of a speech abnormality will happen in such patients, known as aphasia. Splenium part of corpus callosum. I'll give you another hint. What is this? What is this written? This is another priming I'm trying to do. Conduction aphasia, my dear friends, is due to arcuate fibers. What is this I have written? One class I wrote this, some people started doing this. Sir, tic tac toe, I win, sir, you lose. I say, yaar, this is some Chinese word I have written. Do you know Chinese? No. You're blind to Chinese word. That is known as pure word blindness. Correct? We have discussed it previously. And don't forget, the calcarine area of the occipital lobe is also supplied by the PCA. The calcarine area. Okay. Right? That is known as heminopsia. Patient will have heminopsia. Right. There are some syndromes attached with PCA. We'll write them down and try to recollect them also in a different way. It's very important. Okay. Yeah, alexia is another term. Good. You called me this alexia as a term. Good. Right. So this came in, I think so, NEET PG this year, PCA territory. What is the problem? But remember my words, examiner is not going to repeat the question. He is going to repeat the topic. So we need to go beyond this topic and try to learn more about PCA, what all else can happen to such patients. There are some syndromes with PCA also. Okay, write them down. This I found this in PGI as well as Nimhan's question bank. Thalamic Geraint Roussy syndrome. Thalamic Geraint Roussy syndrome. Okay, in these patients, what do you find is contralateral hemisensory loss. Like the lateral nucleus was lost, right? Same problem. But remember this, in these patients, this sensory loss is followed by agonizing, burning pain. So in the part of the body where the sensory loss happened, post recovery maybe, the patient will have a continuous burning pain, This is known as a thalamic Guerin-Roussy syndrome. Okay, nice name, French name. Another name syndrome, don't forget, is known as the Anton syndrome. This is another very commonly asked question, Anton syndrome. Okay, if someone of you know it, it's a very common question in which the patient is having cortical blindness. That means it's a lesion in PCA territory, but patient is first unaware of it, okay, and often denies it also. It's known as the Anton syndrome. Hemianopsia is something which is applied for a term in which the complete visual loss is not seen. It's a partial loss. Okay. Can you tell me, if a patient is unaware of his problem and on top of it denies it, what is it known as? Any clinical name for this kind of a symptom? Yes, anosognosia. We just now talked about this, na? Anosognosia. Okay. Right. There's another term we should know about, which has been recently asked, is a balance syndrome. This is very, very commonly asked nowadays. I've seen nowadays they're not interested in asking your brainstem. Brainstem, they know lateral medial, lateral medullary, late medial. They keep on asking about these cortical syndromes now. Balance syndrome. Write it down. In balance syndrome, there is a severe spatial disorientation due to bilateral dorsal parietal involvement. The first important point. On both the side, the parietal lobe in the dorsal part is getting involved now. Now, what is the clinical relevance of this concept? The clinical relevance is that it occurs in a watershed infarct between B oblique W stands for between MCA and PCA. I'm sure in radiology sir must have talked about this word watershed between the two arterial supply like this. Okay. Now what are the symptoms? This has been asked. In balance syndrome, what are the symptoms with the patient? First of all, the patient has got oculomotor apraxia. I'll explain apraxia in Alzheimer, that will be better to understand there. But the word apraxia means a deficit without any pyramidal, extrapyramidal, cerebellar or any sensory problem. That means the patient doesn't have any weakness as such but cannot do an act, that is apraxia. Now, as the word oculomotor comes, that means the third cranial nerve, something to do with the eyeball and its movement. So in these patients of oculomotor apraxia, the deficit in orderly visual motor scanning of the environment. So this patient cannot do an orderly visual motor scanning of the environment. Okay, it's MC, right? These patients also suffer with another problem known as the optic ataxia. Which means in the patient accurate manual reaching towards the visual target is absent. Okay, I'll just keep on writing for now. I'll explain it in a perfect example. And third part, which makes this particular part very, very important to understand, is this symptom: simultaneosia. Watershed infarct means an infarct which happens at the junction of the two arterial supply, like where the PCA met the MC at that part. Okay. Simultaneosia means ability to integrate information from the center of the gaze with peripheral information. I'll give you an example. Like I'll show a patient a lot of trees. I'm just trying to draw some trees over there. So I'll show a picture to the patient, like there are a lot of trees over there. So what is this? He will look at this and tell me these are trees. This is a tree. But I'll ask him, so many trees are there together. What is it known as? Forest. So my patient will look at one tree and just tell me it's a tree, but cannot integrate it with the rest of the things in the environment. He cannot tell me it's a forest. He just looks at it and tells me it's a tree. I'll give another example. Maybe a lamp. I'll show him a lamp, study lamp maybe. Okay. Now I'll ask this patient, what is it? Patient will leave the top part and look down. And this part he will look at and answer me, this is an ashtray. So I take my lamp away, otherwise he is going to burn it. So he is unable to integrate things together. He looks at the lamp, cannot name it as a lamp, okay, but looks at the base of it and tells me this is an ashtray. So this is inability, maybe a kind of a thing, to integrate the rest of the thing with the center. Yeah, the bullseye, or maybe Arjun, and you all should have this only. You should not worry. Like so many students are there giving exam with you. Don't see them. See at your laksh. That's more than sufficient. Okay. Now, how do you check for this simultaneosia? Remember this test. There's a test being done in these patients. Okay. Okay. If I put the word A over there, A simultaneosia, it will be what? Inability. Okay. Simultaneously, I'm not able to see it. A simultaneosia, then we'll put the word as inability. Okay. There's a test known for it, done in psychiatric clinics very often. That is bilateral letter cancellation test. Sorry, modified letter cancellation test. Okay. I'll write words like this in front of the patient. Like this. And ask him what are these words. You know what he'll do? And I tell him to pick out A's in this. He will pick out this A, this A, this A, and this A correctly. But when I look and ask him what is this, he's unable to tell me that. Why? Because visual scanning for reading this word A requires the movement of the eyeball, which he cannot do so well. He's got oculomotor ataxia. Secondly, he is unable to reach the target so perfectly, and he is unable to integrate with the words around him and what is it. So a lot of visual scanning is required for this patient to read this big A. He's unable to do, but the small A's which are fitting like this, like this, like this, like this, like this, he can easily tell me. This is known as a modified letter cancellation test for them. Okay. Patient has got asimultaneosia, that means inability to do all these things. This is known as a balance syndrome, has been asked recently. All these are components of balance syndrome. Okay, right. Any doubts till now? I'm very sure you will be having a lot of doubts because these are two topics which I have taught maybe for the first time for many of the batches. Okay, any doubts? Okay, okay. Samantognosia is something which is a normal thing. Asamantognosia means inability to do it. Okay. This is a test known as a modified letter cancellation test. I'll write it down. Patient can read small a's but cannot read large a's. Okay. Optic ataxia means a deficit in orderly visual scanning of the environment. What's around me, I have to see. I have to reach a particular target. Like for example, I'll tell him to see what is here. First of all, if there are a lot of things, maybe a river, mountain around it, he's unable to reach this target. There is a tree in front of you, can you see it? First of all, he cannot do an orderly visual scanning. Secondly, can he reach the target? No. On top of it, if at all he sees, he tells me it's a tree, he cannot catch it as a forest. So all of them happen to be together. So modified letter cancellation test is a test in which the patient has been written a lot of words in front of him. The small alphabet words are read very well with him, but the large ones are often missed by him because it requires a lot of visual scanning around it. Okay, right. Purpose of the test is to find it out. Asamotagnosia can be found out through this test. Oculomotor apraxia cannot move the eyeball so well, and optic ataxia means cannot reach that particular target. Infarct, causes are infarct. Okay. Large are missed because the patient cannot do complete scanning around it. It requires a lot of scanning. He cannot move the eyeball. He cannot reach the target in such a big word. Okay. He has to trace everything like this. Okay, fine. He cannot do this. Now, let's try to see another small concept, that is the lacunar stroke. As I was talking about, the word lacunar derived from a Greek word lacune, which means a lake. So there are infarcts in the brain at various points. Most of them are subcortical, which results in small infarcts, lacunar infarct. I'll repeat this topic once more. I don't know. Balance syndrome is a severe spatial disorientation. Around the space around him, he is not able to see things, which involves the parietal lesion on both the side due to watershed infarct between MCA and PCA. First of all, in the patient, there is oculomotor apraxia. He cannot do an orderly visuomotor scanning of the environment. Secondly, if I tell him, tell me where is a lamp in this room, he cannot reach the target. On top of it, if he reaches there, he just looks at the base and tells me it's an ashtray. He has inability to integrate information from the center of the gaze with more peripheral information. This can also be found through this modified letter cancellation test, in which we write a lot of alphabets. He reads the small alphabets, but the bigger alphabets, which require a lot of scanning around it, he cannot read them so well. So he cancels the word. Okay. Lacunar stroke, very important topic again. Remember this fact. In lacunar stroke, the infarct size The infarct size is somewhere in the range of 3 mm to 2 centimeters. So it's a very small kind of an infarct, not more than 2 any time. Okay. It accounts for nearly 20% of the stroke patients. So any stroke patient comes to me, 20% of them we find in the clinic to be having lacunar infarcts. Okay. Major risk factors for this problem. Write it down. The major risk factors for lacunar infarct are hypertension and age, not diabetes. Age of the patient and hypertension are the two major risk factors for this problem. Okay. Another clinical point which has been asked multiple times, it involves the small penetrating arteries. Now the word penetrating artery means it tries to supply the lower part of the brain. Okay. By two events. One is atherothrombotic disease of the vessel. One problem. Second one is lipohyalinosis of the artery. This has been asked multiple times in the previous question bank, that lacunar infarcts involves which artery, small penetrating artery, and what can be the reason for the involvement. One is atherothrombosis and second is lipohyalinosis. Okay. Now remember this, they are very often preceded by an episode of a transient ischemic attack. Okay. Most of the patients of lacunar infarcts we found, they very commonly are having a preceding TIA episode with them. Okay. Clinical types, you can write like this, is something very commonly asked nowadays. Clinical types of lacunar infarcts and where is the lesion in the brain in such patients. Okay. Pure motor hemiparesis is one type of it. Can you tell me where is the lesion for this? We have already covered this topic. Yes, it is there in the posterior limb of the internal capsule, right? Second, yeah, the word dense hemiparesis applied for it. If it is a pure sensory kind of a lacunar infarct, that means only sensory symptoms are seen, then in that case ventral thalamus is involved. Thalamus sensory gateway, in the ventral part most of the sensory nucleus are sitting. Okay. Note this term ataxic hemiparesis. This is another term you should be aware of it, that the weakness is there in the patient but ataxia is more than the weakness in such patients. So the word is ataxic hemiparesis, in whom ataxia is more than the weakness found in the patient. Now you might think just now, okay fine, then sir it will be a lesion that is possibly cerebellar, because cerebellum is a balancing organ. But why will a cerebellar infarct cause weakness? So it is not in the cerebellum. Please remember, there are some descending tracts and ascending tracts which are also important for maintaining our balance. Okay, they are involved in such patients. So remember this, just a location in such patient is ventral pons. Ventral pons. Okay. Fourth, dysarthria difficulty in articulation. Another term applied for them is clumsy hand syndrome. Can you correctly tell me if there is dysarthria and the lesion is not in the cortex and it is a lacunar infarct involving the subcortical zone? Don't tell me the answer is medulla. I'll not keep it there. Where else can be the lesion be? If the patient is having dysarthria as a symptom with hand weakness also along with it, can you tell me? Patient is having dysarthria. We have discussed this topic in the last previous class also in aphasia. Dysarthria, difficulty in articulation. Yes, corticobulbar, good. But where is the lesion likely to be? Basal ganglion, internal capsule, correct. Which part? Posterior limb, anterior limb, genu part. If you remember, we have drawn the diagram. Face, upper limb, lower limb. Yes, face, tongue, corticobulbar fibers are passing through it. So which part? The genu part. The genu of what? The internal capsule. If at all it is involved, the patient will have difficulty in articulation. Yes, with some weakness in the hand muscles, clumsy hand syndrome. So don't forget, this topic is very important. Commonly asked in the exam, depending on the type of the neurological deficit, in a lacunar infarct, where is the lesion likely to be sitting? Okay. Now let's look into another concept. What is the etiology of acute ischemic stroke? Okay, one reason, it can come from the heart, go to the brain, which you know as a word cardioembolic stroke. Starts from the heart, goes to the brain directly, cardioembolic, right? Now, most common cause, if I look at the word cardioembolic, it's going to be what? It is going to be an arrhythmia of the heart in which the atrial appendage often dilates, known as what? The atrial fibrillation, being abbreviated as a term AF. Overall, when I look at embolic strokes, yes, then in that case we find that even the embolic stroke, when we see, it's more often occurring due to atrial fibrillation. Another add-on drama on this is that it is most of the time found to be non-rheumatic in etiology. So it is a non-rheumatic kind of AF that you find. Okay. Apart from this, cardioembolic can happen due to any other reason. For example, MVP or the mitral valve prolapse. Another reason for that. But remember this, mitral valve prolapse causing it is extremely rare. Okay, unless prolapse is found to be severe in the patient, unless the prolapse is found to be severe in the patient. Okay, then cardioembolic can also happen due to a patent foramen ovale. I'm not going into this topic because it's somewhere that dealt in pediatric cardiology. That is a patent foramen ovale, and through the venous route like DVT, it transverses and goes to the brain. It is known cause. Okay. Non-rheumatic means atrial fibrillation can be a case of cardiomyopathy. That is not a rheumatic etiology. Can be carotid atherosclerosis, another reason, or carotid dissection. Okay, so carotid atherosclerosis or carotid dissection is another cause for this kind of a disease. Okay, so these are few causes. Apart from it, most important to remember any time is atrial fibrillation, that is the non-rheumatic AF as a leading cause for it. Okay. Now, less common causes if I want to look at in a group, second group can be the less common causes. I'm not going to detail of every cause, but a few important ones you should always remember. One is this, a topic that we have covered in the previous class also in headache, giant cell arteritis. Giant cell arteritis. If you remember, giant cell arteritis involves two arterial circulation, the external carotid or the internal carotid. Okay. Remember this, the external carotid artery is more affected than the internal carotid artery. So as a cause of ischemic stroke, giant cell arteritis is always seen as a rare event. Okay. Another cause that you all should know about, this is another commonly asked topic in AIMS, PGI, every exam, is your Moya disease. Moya disease. Okay, write it down. It's very important. Moya disease basically involves the distal internal carotid artery and the stem of the MCA and the ACA. Okay. Remember this, in this disease, yeah, smoke of puff, I know this, dhua everywhere. Write this point. It is a sort of an occlusive disorder in which rich collaterals develop around the occluded vessel. Rich collateral develops around the occluded vessel, which give rise to a puff of smoke appearance. Another very important point in these patients is this: vascular inflammation is typically absent in them. There is no vascular inflammation seen in the vessel. Okay. So this is something about the Moya disease, and don't forget the word puff of smoke. Okay. Then another term that you all should know is this: posterior reversible encephalopathy. Posterior reversible encephalopathy syndrome. Press is another topic which keeps on coming. Like Moya, they just keep on asking about puff of smoke. And another one that they are very much interested nowadays, I have seen this, is press. What is press? Remember this. It occurs secondary to hyperperfusion. Secondary to hyperperfusion in increased BP exceeding cerebral autoregulation. So what happens in such patient whenever the BP rises, BP rises, and now what happens, suddenly there is a autoregulatory phenomena in the brain to protect it. That means a vessel should not rupture or there should not be any leakage from the vessel as such. But in these patients, that thing is lost totally. So what do we find in these patients? Obviously, if there is some leakage, we find cerebral edema in them. One. But remember this, the cerebral edema most of the time in the Press syndrome is found to be in the area occipital lobe. Okay. Secondly, in these patients there is reversible cerebral infarction found. In these patients there is reversible cerebral infarction found. So cerebral infarcts happen and they revert. Okay. So if at all they complain of what? One, headache, and the second one is decrease in vision. Why decrease in vision? Because the cerebral edema typically affects the occipital lobe. Yes. What kind of patients are more often predisposed to it? Maybe this Press syndrome is often associated with which group of patients? It is commonly seen in patients who come to me with head injury, one disorder, seizure disorder, most important, females, eclampsia, PIH. If the patient is having or taking any kind of a sympathomimetic drug, even it was found in patients of migraine, severe migraine. So it is posterior reversible encephalopathy syndrome in which the posterior circulation there is some leakage of fluid from the diseased vessel causing cerebral edema. There is some cerebral infarction which corrects on its own, and it is all due to very high pressure, blood pressure, which is beyond the cerebral autoregulatory regulation, and it is commonly seen in these group of patients. Okay. See, why is there an infarction in these patients? In the sense that there is some hyperviscous, no, but there is some deficient flow in the vessel for some time. Because of this, infarction happens and then there is reversibility. But suddenly when the pressure rises, it is beyond this brain autoregulatory phenomena to control it, and that results in a lot of cerebral edema. Okay. Now, am I audible? Audible to all of you? Okay. Another very important, commonly asked topic, is this. Yeah, you can call it as a sort of a hyperperfusion injury for some time. Okay. See, what happens is the flow or the pressure rises, but the flow doesn't rise that much. So there is some kind of a hyperperfusion for some time, and then it all reverses. Okay. Cerebral, write it down, another small topic. See, all these topics have been asked and I cannot really help you much, but they have been asked, and most of them are theory based topic, not practical. Even I have not seen so many patients related to them. Okay. Write it down. Cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. A very long name, Ranchor Das Shamakdas Chachar. Short and sweet, we'll write it as Rancho Cadacil. Okay, it's a very, very commonly asked topic again. This CADSL as a disease is associated with small vessel strokes. Okay. Secondly, in these patients there is a autosomal dominant inheritance which often comes through a gene known as the Notch3 gene. Don't forget the name of the gene, Notch3 gene. Okay. In these patients, there is found to be progressive dementia also as a complaint. And 40% of them come to me with an episode of classical migraine. So anyone from the Tukde Tukde gang who is trying to break the class can define what is a classical migraine. Is it a migraine with aura or without aura? It is a migraine with aura, classical migraine. Migraine without aura, we have discussed this, is known as a unclassical. No, it's known as common migraine. That's more common. Okay, thank God you know it. So these are two topics which have been asked recently in bits and bytes, one liner kind of a thing. Just read them once. But something which has been asked, this NEET, this AIMS is about TIA. Write it down. Transient ischemic attack, if you remember. Yes, we have discussed this. Improves in how much time? Less than equal to 24 hours. But a word from Harrison again, most of the patients with TIA, most of them improve within how much time? 1 hour time. So please remember two facts. Most of them TIA patients improve within 1 hour time. Okay. Now remember this. Risk of stroke post TIA is nearly 10 to 15% in the first 3 months. So you need to be careful on such patient to put them on some kind of an antiplatelet so that they don't have a stroke. And it is highest in the first 2 days. In the first 48 hours of TIA, the highest chances of stroke happen with them. Now, to know a patient of TIA will have a stroke or not, this is a very commonly asked question this time. Which scoring scale is being used? ABCD2 score. ABCD2 score. Now, what is this word A? Stands for age. The B stands for the blood pressure. C stands for the clinical symptoms. D stands for what? Duration. And the last D stands for what? The deadly D, diabetes. So there are two D's at the end. That's why the word ABCD2 comes in for them. Now, why the scoring scale was important? Because on these parameters, if they are there in a patient, I can easily tell them that they are going to have a stroke very soon. So be careful. Okay. Now, what are the cutoffs which have been asked recently? Age. Age of the patient is above 60 years. So the score that they get for it is 1. Okay. The blood pressure. For systolic BP is 140 and the diastolic BP is 90. So if the blood pressure is above 140 by 90, he gets another score 1. Clinical symptom. Yes. Clinical symptoms. In the patient, only weakness. Okay. weakness, sorry, weakness present, aphasia present. I like this: weakness with aphasia, aphasia without weakness. So if the weakness is present, of course, with aphasia, you get a bigger score 2. If only aphasia is present without weakness, you get a lesser score, that's 1. Duration. Duration is more than 60 minutes, or the duration is 10 to 59 minutes. So who gets a bigger score? Anyone with a duration more than 60 minutes gets a score of 2. 10 to 59 minutes gets a score of 1. And diabetes wala will get a score of 1. So depending on all these things, we try to score the patient. You need not remember the scoring, that how many percentage with each score, but just remember the cutoff ranges here: the blood pressure above 140/90, the age above 60, the duration above 60, below 60, weakness with aphasia, aphasia only without weakness. Okay, this has been asked in all the exam this time, ABCD2 score. Okay, now how do we go in for treatment in patients of acute ischemic stroke? So when I come across a patient of acute ischemic stroke, I have to offer him a treatment. How do I go about treating such patients? Number 1 is thrombolysis. As the word suggests, it is breaking the thrombus in the vessel. It's simple. So we try to break the thrombus inside the vessel, okay, by giving a drug, thrombolytic agent. Don't worry, we'll take a break after the treatment part. It not take too long for you guys. Don't panic. No one dies of hunger in our country, at least. Okay, see, sit in the class, you are safe. Go outside to eat, you will get corona or COVID. So this is a better place for you. So have patience for a few more minutes. I'll give you a break. Even I am feeling hungry. Okay. Thrombolysis. Thrombolysis is done by the drug recombinant tissue plasminogen activator. I know you guys are feeling slightly more saturated because I'm not cracking jokes on the topics which for the last 1 hour, because these topics are very dry topics. There are no jokes on it. Jokes will come, don't worry. You feel more interested then. The recombinant TPA, the dose you should remember is 0.9 mg per kg of body weight. Okay. And most important, the route of administration has to be the intravenous route. Don't forget, the drug which has to go to the patient through the route IV has to go 10% as bolus, and rest of them has to go as an infusion over a span or a duration of 1 hour. So in any form, we have to give it and finish the drug within an hour duration. Now, most important, what are the indication and what are the contraindication for this drug to be used? Okay. When we look into the indication part, first of all, remember this: the onset of stroke should be less than equal to 4.5 hours. I expected this year something to change on this, but because of the COVID epidemic, the things are still the same at less than equal to 4.5 hours for the IV thrombolysis. The word onset means when the stroke started and till the time he came to me. If the patient came to me within 4.5 hours, okay, of onset, yes, that is known as a term for it's an indication for TIA. Okay. Second thing, in the CT scan that you have done initially, there should be no hemorrhage. It should be an ischemic stroke. We know it through a CT scan maybe when we don't find a bleed. Okay, right. Third most important, maybe not most important, but as a part of indication, the age of the patient should be above 18 years. Okay, age of the patient should be above 18. That means most of the patients of stroke that you find are elderly already. So most of them are eligible for it. Okay, so these are the three things looking in a patient to thrombolize or not for indication part. Now, more important and commonly asked is the contraindication part. In the contraindication, don't forget, in the patient, if the sustained blood pressure is there above 185 by 110 in spite of antihypertensive therapy. Okay, that means I have given an antihypertensive, in spite of that the BP is above this threshold, then in that case you don't thrombolize. That means the cutoff which I can take now, is less than 185 by 110 in a hypertensive patient with an ischemic stroke. Okay, fine. Second, maybe a contraindication you can think about is a bleeding diastasis, which can be in any format, like patients of chronic liver disease have got high prothrombin, patients already have got some disease in which the platelet count is low. Okay, they say any kind of a recent myocardial infarction, MI, or an intracerebral hemorrhage has occurred with the patient. Oh, sorry, not ICH, head injury. Some fugax. All is well, all is well, all is well. Don't worry. If there has been an episode of recent head injury or an intracerebral hemorrhage, it's better not to thrombolize such patients because there can be a higher chance of bleed at that spot which has already occurred and heal maybe. And don't forget this one. A patient has undergone a major surgery 14 days prior. That is 2 weeks prior to this, the episode of stroke, he has undergone a major surgery. Maybe the internal sutures haven't healed so well, maybe. So if you try to thrombolize such patient, he might bleed from the suture line. Okay. Major GI bleed 21 days prior. Okay. So because the GI bleed leave out an ulcer there, and the ulcers somewhere we find heal in 3 weeks or 21 days time. And if I thrombolize that patient before the healing process, he's going to bleed like hell from there. So that is again a contraindication. And somewhere I could read in the book, although they've removed it, rapidly improving symptoms. Can you guide me why I don't take rapidly improving symptom as an indication, rather I put it as a contraindication? Can you guide me on this? What is happening with the patient? Yes, it's a case of a transient ischemic attack who is recovering on its own. Leave it. He is not going to find an infarct in the brain. Okay, so it is going to improve on its own. Don't worry. I still remember, in my emergency room, a patient came and the power in the limb on hemiparesis side was 0 by 5. Okay, and I had sent the patient for an MRI, and MRI reported a diffusion weighted image of MRI, that you must be knowing the word DW, diffusion weighted. Some ischemia is seen in the MCA territory. Okay, now since the patient came so early, within 1 or 2 hours of onset, within 1 hour of onset he came to me, and when he returned from the MRI, I found the patient's power of the limb was 5 by 5. First of all, I was very shocked to see such a patient. I thought by doing an MRI, we have done a study to improve the limb power. Okay. So on the other hand, I thought maybe the radiologist which is sitting in the AC room in the radio lab, maybe they have given the report of some other patient. So I called them up and asked them ki maybe you have given me some other report of some other patient. The radiologist on the other end said, no sir, this is the report of this patient only. I said, no, this is not the report of this patient. How can you write ischemia in a patient with 5/5 power? The radiologist told me, sir, please read our last line. It writes like this, please correlate clinically. So that's a very important line. Please correlate clinically. Okay. Now, some precautions, some precautions that we have to take while thrombolizing such patients. What to do? We'll take a break and then start from there maybe. Acha, one bad news and one good news. What do you want from me? First the good news or the bad news? I'll give you the good news first. The lunch break is there for you. Okay. You want to take it for 40 minutes? I have no problem in it. But the bad news, let me break the bad news also. Our speed is really very, very slow today. So class will be till yes 9 p.m. Sorry for inconvenience. We have to complete a lot of big topics in neuro also. To start with endocrine tomorrow. Okay, so bad news, class is till 9 p.m. and the good news, you're getting a lunch break just now for 30 to 40 minutes. Come back fast then. Okay. And the possible treatment that we can offer them. Okay. Voice not coming? Voice, is it okay? Is it okay? Is it okay? Increase the, now I think so there should not be any problem with the volume. Right. We know that there is a treatment for patients of stroke which is done with the help of recombinant tissue plasminogen activator, right, which is given through the route intravenous. 10% of it goes to the patient bolus, rest 90% of it given slowly as an infusion over 1 hour time. Okay, and the indication we have already tried to discuss upon. The onset of the stroke should be less than 4.5 hours to me. There should not be any hemorrhage and the age of the patient should be above 18. Another very important concept is that sustained blood pressure above 185/110 in spite of an antihypertensive therapy is a contraindication. Now to understand this, we need to go like if the blood pressure is above 120/80 normotensive phase, but it is below 185/110, can we thrombolize the patient? Yes. Now we should know that when to control the blood pressure in a patient with acute ischemic stroke. So in a patient with acute ischemic stroke, don't ever think that high BP means very bad thing for him. Okay. Now first important thing is that the blood pressure of the patient should be above 220 by 120 millimeters of mercury, then we go in for chasing the blood pressure of the patient. If the patient is suffering with a disorder known as the malignant hypertension, in which you find hypertension with an end organ damage with the patient, okay, or if the patient's blood pressure is above 185 by 110, and this very patient happens to be a candidate for thrombolysis, okay, that is, we try to give a recombinant TPA therapy, and if the BP is above 185 by 110, then in that case we try to decrease the BP. Another important person whom we'd like to chase the BP fast is this. If the patient is having concomitant uh, pulmonary edema or myocardial infarction, look at this now. Pulmonary edema with a high BP can never settle until you chase the BP and bring it down. And in acute MI patient, you find that the high BP can cause a lot of arrhythmias also independently. So it's always better to bring down the blood pressure in such patients. So a safe zone maybe for thrombolysis is below 185 by 110, and don't worry, high BP is not that dangerous for even an acute ischemic patient. Okay. Now, important thing, while thrombolizing, while we are doing a thrombolysis therapy, okay, precautions to be taken. Now, when we are doing a thrombolysis therapy, precautions to be taken in a patient, okay, for this, first of all, very important thing, there should be two peripheral lines in the patient that we need to put, okay. The peripheral line means the intravenous line, IV lines. As far as possible, in this patient whom you are thrombolizing, avoid central or an arterial line. Central or arterial line. Okay. Most important, no other antithrombic agent or antithrombotic agent for next 24 hours at least. Okay. For next 24 hours, no aspirin, no other clopidogrel or any kind of an antiplatelet or anticoagulant agent for next 24 hours. Very important. Also in these patients, avoid urethral catheterization, because sometimes we happen to see a patient being thrombolized and the urinary catheter was there, and suddenly what happened was that there was a small trauma at the catheter site and the patient had a very bad or a torrential hematuria. So it's always better to avoid such thing. Okay. Yes, the blood pressure above 185 by 110 is a contraindication for thrombolysis in spite of therapy. That means if a patient comes to me with a BP of 220 by 120 and acute ischemic stroke or AIS, I'll use antihypertensive therapy and bring down the blood pressure till 185 by 110. And if the patient is an eligible candidate for thrombolysis, I can give recombinant TPA. There is no problem through the route IV. Okay. Why no central line? Because central line you need to puncture through the skin. Again, if you thrombolize the patient, they can just ooze from that puncture site. So it's better to avoid a central line or a CVP line through a big venous access. Okay. Now, can we use intra-arterial? There are some studies done on this also. Intra-arterial recombinant TPA therapy. that is through the angiographic route, maybe I put it into the artery. Yes, but the problem is it is not FDA approved. It is not FDA approved. Okay, it's not yet approved for arterial thrombolysis. But remember another very important point out here, that for intra-arterial thrombolysis with the same drug recombinant TPA, the window period is not less than equal to 4.5 hours. The window period is taken as 6 hours. So intra-arterial recombinant TPA, although not FDA approved, but now this time for them the window period, the time to use the drug is not less than 4.5 hours. It is almost less than 6 hours. So we have taken the window period to a larger limit for them. Okay. But to my own experience, I've seen many patients of ischemic stroke. I found that many of them could not come really well on time. So if they cannot come on time, what can I do for the patient? Okay. For them, we can offer them another treatment apart from recombinant TPA, that is giving them aspirin. That is of course an antiplatelet drug. Okay. Why avoid urethral catheterization? Because it increases the risk of hematuria. Okay, right? Aspirin is a very cheap medicine, and it's a very readily available drug, antiplatelet. Yes, they found that if used within 48 hours of onset, if you use aspirin in such patient, it might decrease the reoccurrence risk, and to some extent, not totally, mortality also. So the chances of having another stroke will obviously come down if you use aspirin within 48 hours of onset, and it will also bring down mortality in some patients. Okay. Number 3 is using an anticoagulant, right? Now the anticoagulation therapy, if ever you come across in your ward, you give to the patient an injectable low molecular weight subcutaneously given heparin, followed by a oral warfarin. So this is how we try to give this kind of therapy to a patient. But remember this, anticoagulant is a double-edged sword. Why? Because it will basically dissolve a clot which is there somewhere in the brain vessel, but the problem is it often increases the risk of hemorrhage. Now this hemorrhage is not only the brain hemorrhage. This can happen anywhere. It can happen in the GI tract causing hematemesis, or can happen in the lungs, hemoptysis, gum bleeding, anything. So we should be very careful in using these drugs. Anticoagulant, remember this, there are only few indications to use it. First indication is the atrial fibrillation. A patient of AF comes to me, okay? A patient of AF comes to me and I want to use an atrial anticoagulant for that patient. But my sense tells me that, yeah, it can increase the risk of hemorrhage. So how should I guide myself in a patient, for example, a non-rheumatic AF? Now I'm using the word non-rheumatic again because I'm already written this down and you already know this, that the non-rheumatic AF is the most common cause of the embolic stroke. Okay. Now non-rheumatic AF, to give or not to give, is based on a scoring scale, CHAD-2 score. CHAD-2 score. If someone of you knows this score, it's very good. Something in cardiology you often discuss about. Should I anticoagulate a patient of a non-rheumatic AF is dependent on this. It's actually CHAD 2 score. Okay. Now C here stands for the CHF, congestive heart failure, CHF. The H here stands for the hypertension. Okay. The A, as usual, like in the ABCD 2, stands for the age, and the D stands for the deadly disease, diabetes. And what is the 2 stands for? I'll come to it later. Like if at all in a patient with non-rheumatic AF, CHF or congestive heart failure is present, then he gets a score of +1. If hypertension is present, then this patient gets a score again of +1. Age. If the age is above, not 60, 75, then in that case he gets a score of +1. If diabetes is present, then again the patient gets a score of +1. Now the 2 comes here because of the +2 score. +2 score comes if the patient has previously suffered with what? A warning sign for a stroke known as the TIA. So the +2 goes for the 2 here, and rest of the things you already know. Chat 2 score. Now what is the relevance of this scoring system? They say in the chat 2 score, the score is 0, 1 or 2. Okay, 0. If the score is 0, don't worry, give only the patient one drug, aspirin. Okay, score 1 is a dicey one. You can give aspirin oblique anticoagulant, which is injectable followed by oral therapy. And if the score is 2, then in that case you only give an anticoagulant. So ABCD2 score, yes, the age cutoff in years is 75, not 60, 75. What is the full form of TIA? Oh my god, Tamaji Satakli. TIA full form. Okay, chat 2 score, right? CHF, hypertension, age, diabetes, TIA. So depending on this, you can easily decide upon any patient, should they require this or not. Okay. Apart from this, remember another indication, like a patient of stroke comes to me and in the background, the patient is having a prosthetic valve. Okay, prosthetic valve is an artificial valve that we have replaced in the patient due to any rheumatic heart disease or something like this. Okay, prosthetic valve. Okay, so don't forget, these are few integrated things. Even in CVS teaches this very well, chat 2 score and all. It holds relevance to give anticoagulant or not, because giving an anticoagulant any time will increase the risk of hemorrhage anywhere. Okay, now please do remember this. There are some things apart from pharmacological therapy, that is neuroprotection, right? There are certain drugs with us, okay, which can basically block the release of any kind of an excitatory neurotransmitter like glutamine and all. Okay. Another one is that, one thing problem with the drugs is that it has got less benefit. The benefit is not that good enough that we found in recent trials. Another neuroprotective thing that has been tried but again not very helpful was hypothermia. Somewhere they found that hypothermia could help the brain in a sense that it can be neuroprotective. Okay. Okay, explain the score 0. Score 0 means CHF is not there, hypertension is not there, age is less than 75, there is no previous episode of TI and no DM. So nothing is score 0. Then in that case, you give only aspirin. Hypothermia. The problem is hypothermia happen to increase the risk of pneumonia in the patient. Correct. Another important thing recently asked one of the exam, what is the treatment in format of journal care being given to the patient? Journal care. Okay. Journal care can be in form of a therapy which is known as constrained. Just correct the spelling. Constrained movement therapy. What is the meaning of this constrained movement therapy? Write it down. In constrained movement therapy in the patient, we immobilize the normal side of the patient. Wherever the weakness was there, opposite to that, the normal side, we try to immobilize that. And in that case, we try to recruit the abnormal neuronal pathway. So don't think the brain cells are always dead. They will recover. Only the positive feedback has to come. So we try to immobilize in the patient in a sense that we immobilize the normal side and encourage the patient to use the abnormal side and try to recruit the abnormal neuronal pathway. And there has been a study that they found it tries to improve the weakness in the patient. It helps me to improve the weakness in the patient. That is known as a constrained movement therapy. Okay. Right. I hope you remember this gates and all that I'd shown you in the previous classes. If you remember this gate, yes. What gate am I showing you? Right. This is nothing but you known as the what? This is known as the circumduction gate. And if you remember in the circumduction gate, I'm trying to hold my body on the normal side. Now this time in the constrained movement therapy, I try to immobilize my normal side. I tell the patient not to move it and on the abnormal side. Okay, circumduction gate, simple. Let's quickly just go back to that topic and try to fatafat revise some gates that we know. Yeah, that's a pill rolling tremor and nothing but your fascinating gait of Parkinson. Easy, not a problem. Yeah, that's nothing but your waddling gait. Yeah, that is an economic warrior gate. I call them as economic warrior because they are contributing a lot to the society nowadays, helping us to good amount of tax. Yes, that's the broad-based gate or seen in cerebellar lesions. Okay, we know them. Rest of the gates and all I'll show you in specific disorders. Okay. Let's take out some MCQs and try to solve them. Let's try to take out some MCQs and try to solve them. Okay. Question number 13. A unilateral anterior one-sided anterior cerebral artery occlusion, the patient has the following feature: paraplegia, gait apraxia, socially uninhibited bladder, or the patient remains asymptomatic. Any ideas on this question? Patient remains asymptomatic. See, in any question, don't try to search pre and post communal in this. Okay? So remember, in such question, you should take it as pre-communal only until unless they mention it post-communal. So most of the patients are asymptomatic. Yeah, this is something which I actually missed out. You are invited in a bank to deliver a talk to its employees on warning symptoms of stroke. To make your talk simple, you use a FAST acronym to explain the common physical symptoms of stroke. Which of the following is not a part of the acronym FAST? Tell me fast. This is community medicine. Okay. F stands for what? The facial weakness. A stands for what? The arm weakness. S stands for what? The speech difficulty, speech abnormality, and T stands for what? Time. So whenever you explain a layman, try to explain them through this fast mnemonic that you get a facial weakness, arm weakness, speech abnormality, and you should always come to me in time, otherwise I will not be able to thrombolize you. Simple. So Caesar is not the part of the fast acronym. The S stands not for Caesar but the speech abnormality. Okay, I found this question under community medicine. I don't know why, what is question doing there. Okay. 15. 45-year-old male presents with left arm clumsiness. Physical examination reveals a motor weakness with increased tone of the left arm. Tone has increased. With the passive extension of the left arm, there is initial resistance and then there is sudden release with maximum extension is reached. Oh my god, what am I talking about? Clasp knife rigidity or the spasticity. Patient is having weakness, right? Pathology within which of the following brain structure is most likely to be responsible for this disorder? Okay, let us first mark what are these areas. A, B, C, D and E, what are they? A is what? This is a part which is somewhere internal at the base of the brain, basal ganglia. Okay, what is C and what is D? And what is E? And what is B? B stands for the internal capsule. A goes with the thalamus. C stands for the globus pallidus externa. Sorry. The C stands for the putamen. D stands for globus pallidus externa, globus pallidus interna. Now I am going to see a motor weakness, typical motor weakness. The lesion has to be where? The internal capsule at this point, where the motor fibers are coming down. Because surrounding every point is a sort of a extra pyramidal tract. Okay. See, putamen hemorrhage, will come to that, will cause hemiparesis when the bleed actually goes and dissects the internal capsule fibers. But now if I want to mark one structure out of them which is able to cause alone hemiparesis or this kind of a problem, that is internal capsule. Now internal capsule, if at all involved due to some infarction, we have discussed this concept, is known as what? Dense hemiparesis. I think so this question should be very clear and easy. This is I picked out from the anatomy question bank. Okay. Sorry. Right. Baba, I'm telling you now, the bleed is here, putamen. It will go immediately crush the fibers. But this time, they have not given any history of an intracerebral bleed. They have just given a very silent picture like this. I'll come to that. In patients of a bleed, you will always have a high BP. drowsiness, headache, nothing like this is given in the patient. Okay, so if you want to mark B or C, please keep B in such a question as a better answer. Okay. Okay. 65-year-old gentleman walks into a casualty with a circumduction gait. His right-handed, he's right-handed and is unable to move the left side of the body. You find the blood pressure should be 190 by 90, high BP, and left upper motor neuron facial palsy. Okay. The following examination, he has homonymous hemianopia, and what is your diagnosis on this patient? Tell me. He is unable to move the left side of the body. He has got a left UMN facial palsy with hemianopia. First of all, if it was a lesion somewhere seen at the level of what? Internal capsule. Okay. Patient won't be having a facial palsy typically like this. And what is this hemianopia doing in his story? Because internal capsule lesion, I agree, will cause hemiparesis everything. But somewhere we find in such patients that there is only hemiparesis and nothing beyond that. Okay. So it's not a very correct answer. Tell me please, what is the best answer you will mark? First of all, the weakness is on the left side of the body. So the lesion has to be in the right cortex. If it is hemiparesis, it has to be an MCA, thrombotic. Is it incomplete hemiparesis or a complete hemiparesis? Yes, you should know this term as complete hemiparesis. Some of the authors have used this term complete hemiparesis. They say weakness which comes with a facial nerve palsy is considered to me as a complete hemiparesis. Okay, so remember this, don't mark it as incomplete, mark it as complete, right? So weakness with 7 nerve palsy is defined as a word complete for me, and it has to be a right cortical lesion because in this patient there is a UMN facial nerve palsy. What is UMN facial? We'll learn it in our myelopathy classes tomorrow, right? Okay. 75-year-old male presents with hemisensory loss, memory impairment, visual loss. As his relatives tell me, he is suffering from some behavioral alteration also. The lesion in which of the following artery is responsible for this neurological deficit? Please tell me. It's a very simple question, no problem. This is nothing but your PCA territory if you remember. Yes? Easy answer, nothing new in it. It's a very simple question. See, in incomplete hemiparesis, we don't find the facial weakness. Incomplete weakness with facial nerve palsy occurs, like in this case. Which of the following is a type of a lacunar stroke syndrome? Which of the following is a type of a lacunar stroke syndrome? Ataxic hemiparesis, pure sensory, pure motor hemiplegia. All of the above, all of them. Very simple answer. Right. A 60-year-old male with a history of a native the word means original. Whenever the word mention the word native, please do remember this. It means original. In this very question, what they want to highlight that it is not a prosthetic wall disease. So please remember the examiner wants to tell me it is not a prosthetic wall disease. It is a native aortic wall disease. Patient presents with left hemiparesis 1 week back which has tried to improve itself. Now you attend patients of stroke in hospital. For example, the weakness or the power in the limb when he came was 1 by 5. After a week of therapy or physiotherapy or pharmacological, it became 4 by 5. If it was 4 by 5 and it became 1 by 5, what is the relevance of it? First of all, let me clear this concept. What is the meaning of this 1 by 5, 2 by 5, 3 by 5, 4 by 5 and 5 by 5? Basic first. I hope you remember the power of a particular limb and the grading of it is done like this: 0, 1, 2, 3, 4 and 5. The grade 0 basically means no movement at all seen in the limb. The grade 1 means there's some movement seen which is likely to be flickering only. Grade 2, yes, in the patient the movement is seen, right, with gravity eliminated. Grade 3 means the movement happen in the limb against gravity. Grade 4 means movement happens not only against gravity but against what? Resistance. And grade 5 means what? A normal power. Okay. So this is the grade of power in a particular limb. And remember this, there is a scale for it. Just remember the name of the scale. The abbreviated name is MRC scale. There is an MRC scale to which the grading of a power in a weak limb is always been done. See, this is something I've been talking about. If the grade is 0 by 5, no movement, it is a term applied in clinical setting as what? Plegia. Like hemiplegia, paraplegia means no movement. While if the grade is 1 by 5 to 4 by 5, if the grade is 1 by 5 to 4 by 5, it is applied as a term what? Paresis, like hemiparesis or paraparesis. Okay, let me ask you a very simple doubt. There is a patient with me who is lying in the bed. Okay, the lower limb of the patient, okay, this is the bed. The patient can just move it left and right. The movement is just in the lower limb, left and right, parallel to the bed. Okay, but there is no movement on raising the leg. That means the patient, I can just write like this, can move the limb parallel to the bed but cannot raise it above the bed. Please tell me the grade. Quick answers? Good. The power is 2 by 5 in such case. Why? This kind of a movement parallel to the bed means that we have eliminated gravity in the patient. If we could have moved it above the bed, we could have made it as 3 by 5. Okay, so that's a very simple bedside clinical concept. Never forget it. Where was I? I was on this concept. That means if the 1 by 5 became 4 by 5, that means this patient started improving. 4 by 5 became 1 by 5. That means this wala patient started deteriorating. So we find like this, a stroke that improves, remember this, or maybe maximum at the onset, is always seen as an embolic stroke. While a stroke which deteriorates with time or increase of weakness is seen is known as the thrombotic stroke. Remember this. Embolic, thrombotic, there is a clinical difference which I can understand through this. Weakness improves in embolic, weakness deteriorates in thrombotic. T for tragedy and T for thrombotic. Okay. Now what do I have in this case? Weakness happened a week back which is improving. So he qualifies for which stroke? Embolic. ECG is normal now. The patient doesn't have any AF. What should I do with him? Best treatment 1 week after the onset now. Should I give him a recombinant TPA? No, he's out of syllabus. He's out of window period for this drug. Heparin and warfarin would have gone into the patient if there was some prosthetic valve or some evidence of AF on ECG. But in this case, only aspirin is sufficient. Okay. Another great question is this. 65-year-old male with no past history of diabetes and hypertension awakens at 8 a.m. in the morning and finds he cannot move his right upper limb and lower limb. That means the patient has got weakness on one side of the body. That means it is known as a neurological deficit. right? 9 a.m. the patient is brought into the nearest hospital and his MRI shows an MCA territory infarct. Okay, so he had got facility and money both. He was able to reach the hospital well on time and we got an MRI done for him. ECG is normal for the patient. That means there is no atrial fibrillation in the background. Hemodynamically, the patient is stable. That means the blood pressure is also normal. Now, what is the treatment best given to this patient? Tell me, please. Neurological deficit happened at 8 a.m. Good. And we found an infarct at 9 a.m. Excellent. Without AF, without diabetes, without hypertension, age above 18. With no evidence of hemorrhage on the CT. Okay, most of you have started typing the answer is A because they think that the patient has come 1 hour within 1 hour of onset. They think like this. Okay. Let me tell you this old fact, it's like a drishyam. Scenes are deceptive. If you've seen that movie of Ajay Devgan, Drishyam, the tagline was the scenes are deceptive. There's always an illusion and a delusion in a thought process. So Drishyam over here is this, that remember this, the onset of stroke, for example, of a ischemic stroke comes like this. In a patient who awakens with a neurological deficit, the onset of stroke is considered like this. When the patient went off to sleep. Got my point? That means the onset is not when he wakes up. Like in this case, 8 a.m. he got up and he found the first thing was a neurological deficit. The onset is not when he wakes up. The onset is when he went off to sleep. They thought in most of the cases like this, and they found it correct, that the onset of stroke happened during the sleeping hours. Since the patient was sleeping, he could not realize it and no one saw him sleeping, so no one found it. So please remember, technically he is out of window period. So where do we stand? Aspirin. Okay. Right. Now, 76-year-old male with a left-sided weakness of the body which recovered completely within 18 hours. Now, important thing, 18 hours. On examination, his pulse is irregular. That's enough an evidence of atrial fibrillation to call about. His blood pressure is 150 by 80. That's not very high. Patient is a known case of hypertension with diabetes. And 2D echo shows non-rheumatic heart disease. That means no evidence of a rheumatic heart disease. So it's a non-rheumatic AF. His age is 76. So why I'm writing 1 plus 1 plus? Yeah, what score? Chad 2 score. Right? Congestive heart failure is not there. Hypertension plus 1. Age above this plus 1 plus 1. Now the score goes to 3. Score goes to what? 3. Score goes to what? 3. Right? Now please tell me. Most of you are marking this, aspirin with warfarin. No, Baba. Only one. Oral anticoagulant, warfarin. Only one. Don't give 2 drugs together. It's not going to benefit. Aspirin only will go for a score of 0 maybe. Like in this case, if I go back and see this wala patient, anyway, it's not a case of AF, so leave it. So aspirin will go for a score of 0 maybe. Aspirin or anticoagulant for a score of 2, but score of 3 like this, warfarin. Okay, yeah. TIA has happened. Sorry. The score becomes what? Plus 2. 3 plus 2, 5. I was wrong in this, sorry. Yeah, the score has become 5 now. Because this is a case of TIA, no? Recovered completely within 18 hours. TIA. So the score is 5. Right. You are attentive at least. So this is a very clear question of chat 2 score. Remember it. Which of the following is not correct for a patient undergoing thrombolysis for an acute ischemic stroke? Yeah, the score is 5 for this question. Okay. Which of the following is not correct for a patient undergoing thrombolysis for acute ischemic stroke? Avoid putting an arterial or a central line. Yes. Avoid urethral catheterization. Yes. In case of a deteriorating neurological status, start cryoprecipitate and advise re-imaging. Yes. Why? You are thrombolizing the patient. It's a good drug. It will break the thrombus and may cause a leak. So it might transform itself into a hemorrhagic stroke. So what do I do in such cases? Give a cryoprecipitate which contains clotting factors. Do a re-imaging to find a hemorrhagic stroke. Simple. But do I give aspirin after completion of thrombolysis? I already told you this. No antithrombotic agent, no antithrombotic agent for at least 24 hours duration. Okay? So it's a very simple question. But when it comes in the exam, you're just blank. What did they ask? 45-year-old hyper. This question 23, is a very common question we found somewhere in Ames paper. Keeps on changing the age and the duration of the disease. Rest everything remains the same. 45-year-old hypertensive male presents with weakness over the left upper and lower limb, hemiparesis, for the last 2 hours. Okay, the CT scan brain is normal. Blood pressure is 160 by 90. Which of the following is the next best step in management? Very typical Ames kind of a question. Manage hypertension first. True or false? False. Why? We manage the blood pressure of the patient with acute ischemic stroke. Now, you might ask me, sir, why do you call it as ischemic? Arey Baba, we have not done the MRI, we have done a CT. CT scan will rule out what? Hemorrhagic stroke. First. So this is not a case of hemorrhagic stroke. His age is above 18 years. His blood pressure is below 185 by 110. And he is not rapidly improving. Let me take you there also. For the past 2 hours, I take him to be static. What do I do? Manage his hypertension? No, there's no point. Give him aspirin and reassess? No, I'll just waste time in doing all this. Give mannitol to decrease raised ICT. He doesn't seem to have a raised ICT phenomena either clinically. So what do I do? Yes, give a recombinant TPA and review the patient's past. After reviewing the patient past history, by past history, history of major surgery within 14 days, GI bleed within 3 weeks, past history of head injury, hemorrhagic stroke, and all that. So this is a very commonly repeated question. Okay. Restraint therapy in stroke is best related to. Restraint therapy in stroke is best related to. Tell me please. Recruiting the unused neuronal pathways. By immobilizing the normal side, we encourage the patient to use the abnormal side. And in turn, we try to recruit the unused neural pathways in the brain, which are not that damaged. Okay. There's another good question. Which of the following symptom in a patient of stroke is found to be beneficial for the patient? Fever, dysphagia, blindness, spasticity. Let me do a priming on this question. I have already discussed this question when we were seeing the gates in Parkinsonism chapter, it's trying to show you gates, and I have discussed this topic there. What is good for a patient of stroke? I'll do another priming for you. In a sense that it is helpful for maybe maintaining the balance. Good, you people know it. Spasticity. Why I'm talking about spasticity? Let me take you back again to powered by chai. Yeah. See, if the right side is weak, I'm holding on the left side and rotating it. The moment I keep it down, it's weak. It would have fallen down. But the weak side is going to hold the limb because of spasticity in order to maintain the balance. Okay, we've discussed it earlier also. In order to maintain the balance, spasticity is good. It can hold the limb on the floor when I keep it down, although weak, but the muscles over there are spastic. Okay, we can hold it. So the chai wala is back. Okay. Moya Moya disease. Moya Moya disease results from progressive stenosis and occlusion of which artery? Vertebral basilar or distal internal carotid? Distal internal carotid artery, distal part of it. Okay. Which of the following is false about the CADSL disease? There is a small vessel stroke and a progressive dementia. Yes. You read something in radio also that it causes symmetrical white matter changes on MRI. Yes. It can happen in the fourth and the fifth decade. That also correct. But is it autosomal recessive? Autosomal dominant. Which gene? The Notch 3 gene. So remember all these topics like press, CADSL, Moya Moya. Don't go into why. Just remember them. They are theoretical topics. Okay, hardly I have seen any patient related to it. Which of the following is not a part of the ABCD 2 score should be system for TIA patient? Age above 60, blood pressure above 140/90, clinical symptom with or without weakness, aphasia, diabetes, duration. Male or female doesn't matter for it. Okay. Press cerebral edema. In press, cerebral edema is seen in which of the following lobe of the brain? Occipital lobe. Okay. Chalo, let's move into another topic, that is hemorrhagic stroke. Don't worry, you'll all of you will get all these questions on Facebook at least by today. Okay, I'll provide you. Don't worry. I'll put a post on the Facebook with a meme, of course, and you'll get all these questions over there. You can just share with each other and all this. Okay, they're simple ones. Just a second. Now let's move into another zone, that is the hemorrhagic stroke. First of all, how do we classify the hemorrhagic stroke? Classification is very simple and very clear. Yeah, the chat 2 S2 VS SC score is slightly different from this. I've not gone into details of it. All the MCQs on Neuro, at least you can just solve it into this chat 2 score. It's more than sufficient. Okay. There's a bleed which happens inside the brain parenchyma. Anatomically, this bleed is known as the intracerebral bleed or the intracerebral hemorrhage. Intracerebral bleed or the intracerebral hemorrhage, being abbreviated to me as the word ICH. One bleed which happens between the brain and the skull. Okay. is extracerebral bleed or the extraparenchymal hemorrhage. So we come across two kinds of bleed, inside the brain and outside the brain. Outside the brain is the ECH, inside the brain is the ICH. Now, if you remember the basic anatomy again, the brain, between the brain and the skull, okay, there are three layers of meninges which happen to cover the brain like a pad, okay, pia mater, arachnoid matter, and the dura mater, okay. If there's a hemorrhage which happens between arachnoid matter, pia mater, that's known as the subarachnoid hemorrhage. Between dura mater, arachnoid matter, that is known as the subdural hemorrhage. Between the skull and the dura mater is known as the extradural hemorrhage. Okay. So that's the three types of extracerebral hemorrhage that you find: SCH, SDH, and the EDH. Between the ECH and the ICH, don't forget the most common type of the hemorrhagic stroke that we find is the ICH. Between the ICH and the ECH, ICH is more common. Okay, if you remember, we have just in the beginning, in the middle part, we have tried to see that around 15% of all the strokes that you find, 15% of them are hemorrhagic stroke. Now, if I try to just divide it, 10% happens to be the ICH and 5% happen to be the ECH. Okay. Now, don't forget this, that the most common cause of ICH, is high blood pressure or hypertension. Okay, most common cause of ICH is hypertension. And what are the possible sites of hypertensive intracerebral bleed that we find? Number one is the basal ganglia. A part of it, which is known as the putamen, happens to be the most common site of the hypertensive intracerebral bleed that we find. Right? Now, what can be the neurological deficit in some patient? In such patients, it is obviously going to be hemiparesis. There is a weakness seen on one side of the body, hemiparesis. Okay, why? Why, you already know somewhere? Yes. If I want to take a transverse section of basal ganglia and try to make it again, this one happens to be the thalamus part. This one is the lentiform nucleus. The outer part, the peripheral, happens to be the putamen. The middle part of it happens to be the globus pallidus. And above here it was the caudate nucleus. Right? Between the two, with the convexity medial this time, yes, is my internal capsule. If there was a bleed in putamen, it is going to go medially and touch the fibers in the posterior limb of internal capsule, and henceforth the patient is going to have hemiparesis. One thing is very, very clear in such patients: it's always a contralateral hemiparesis. Why? Because the lesion is above medulla. Any lesion above decussation in medulla, the weakness is always going to be on the opposite side of the body. That is contralateral hemiparesis. That is easy and well explained. The second is the thalamic bleed. Now, thalamus has been a sensory gateway all the life. So one thing as a symptom which I can mark as exclusive for these patients is usually a hemisensory loss. See, although hemiparesis can also occur in them, but I'm not trying to mix the two things. I'm just telling you the salient and the maybe something very peculiar for them, especially the thalamic bleed is a hemisensory loss. Number 3 is a structure which is known as pons. Right? Pontine bleed is the worst maybe because it causes a lot of catastrophic problems like increase in heart rate, tachycardia, increase in respiratory rate, tachypnea, increase in temperature, hyperthermia, increase in sweating, hyperhidrosis. But most important above all, yes, when I see the eyeballs and especially the pupil size is very, very small in them, like a tip of a pin. So that's why it looks like a tip of a pin, known as the term pinpoint pupils. If you read any time in any question pinpoint pupils, don't forget two more differential diagnoses of these patients. Organophosphorus poisoning, okay, OP poisoning, and morphine poisoning. These are two more differential diagnoses whenever you come across with a patient of a pinpoint pupil. Apart from this, don't forget the corticospinal tract is involved on both the sides. If you remember in a transverse section, I was trying to recreate this. The corticospinal tract was running in pons near the midline. So if at all there is a bleed, look at this please. The bleed is going to expand like this. And now the corticospinal tract of both the sides are gone. Left and right both. See, one side maybe corticospinal goes, we term the problem or the deficit as hemiparesis because only one side of the body is weak. Here both the sides are weak. That means all four limbs are weak, which we can refer as a term quadriparesis. And there is a rigidity seen in this patient. Remember this old concept. It's very, very, very useful. If you see this as a cortex, below this was the internal capsule. Around it was the basal ganglia and its structure. Below that is the brainstem, midbrain, pons, medulla, and finally we have the transmitter zone that is known as your spinal cord. So all these are the part of central nervous system. Remember this, whenever the lesion is in the midbrain or above the midbrain, whenever the lesion involves the corticospinal tract at the level of midbrain or above the midbrain, we get a rigidity phenomena in the patient that you learn in physiology also as what? Decorticate rigidity. I've shown you this in the very first class. Decorticate, what happens? Upper limb and the lower limb. The upper limb goes what? Flexed. And the lower limb goes how? Extended. So there is an extension in the lower limb and flexion of the upper limb that is known as a decorticate rigidity found in these patients. Okay. But if at all the lesion is below the midbrain, maybe in the upper pons, anywhere here, in such patients the rigidity that you come across is not decorticate. It is known by the name decerebrate rigidity. There is no O in this, there is no flexion in this. So when I see this patient, his upper limb and his lower limb, correct? Both of them happen to be extended. Don't forget this basic rule. Any lesion involving the tract descending corticospinal below midbrain will result in a decerebrate rigidity. Above midbrain or maybe a section at the midbrain will cause a decorticate rigidity. Decorticate has got a O, there is a flexion in the upper limb, while decerebrate is all the time E and E, extended. Okay. So please tell me, in a pontine bleed, what are we going to see? Decorticate or decerebrate? It is decerebrate rigidity. Apart from this, extensor plantar will be found in the patient. Yes, on one side or both the sides. As you can see in this diagram, corticospinal of both the sides are affected. So you find it to be bilateral extensor plantar. Right? With the decerebrate rigidity, Quadriparesis with a pinpoint pupil is nothing but your pontine bleed in the background of tachycardia, tachypnea, hyperthermia, and increased sweating, hyperhidrosis. See, there are a lot of things given in the book on these topics, like this happened, that happens. Need not go, just remember the salient points, because we need to diagnose in a particular MCQ what is the problem given in this case, what is the localization in that patient. Then we have the cerebellum with us. Cerebellum is an organ which is supposed to maintain my balance, and a cerebellar bleed will cause what? Ataxia and a vertigo. Okay, so this is something which we find in a cerebellar bleed. So that's about the hypertensive bleed. Quadriplegia again, simple. Dekho, corticospinal of both the sides are affected. See, the bleed occurs in ponds like over here in some artery, and the blood decussates left and right and involves a corticospinal tract of both the sides, resulting in upper limb, lower limb, all four limbs weak. We'll discuss this concept again tomorrow, like this, There are three kinds of patients that we see in neurological practice. In a patient, only one limb is weak, is mono. Mono means one. If one side of the body is weak, that is half, hemi. If all four limbs are weak, that is quadri. Okay. If only the lower limb are weak, that is what? Para. So there are terms like this: paraparesis, both lower limb are weak. Only one limb is weak, monoparesis. One side of the body is weak, hemiparesis. All four limbs are weak, quadriparesis. Decerebrate rigidity means the upper limb and the lower limb in the patient is all the time lying in an extended posture. Okay. So these are the causes of a bleed that you find hypertensive bleed. Okay. Second thing, don't forget, is a lobar hemorrhage. So the hemorrhage that you find, which you just now saw, was a subcortical hemorrhage. Look at this, putamen or maybe pons, thalamus, everything is below the cortex, subcortical. Now you've got a lobar hemorrhage in a patient. That means the cortex itself has got a collection of blood inside it. Okay, that is a lobar hemorrhage. Lobar hemorrhage occurs due to a disorder that occurs in elderly with dementia known as cerebral amyloid angiopathy, being abbreviated as a word CAA. That's not the article which the people were fighting for, CAA. Okay, right. The site of this is often seen in the parietal and the occipital lobe. So the lobar bleed that you find is more often seen in the occipital and the parietal lobe of the brain, and it occurs due to cerebral amyloid angiopathy. We'll discuss this some concept somewhere in Alzheimer also. It often occurs in elderly people. This bleed due to CA occurs in elderly people, and most important, they are non-hypertensive patients. They don't have a hypertension phenomena with them in the background. Okay. Third cause, apart from hypertension or CA causing a lobar hemorrhage, in a patient of a bleed or ICH, can be a vascular malformation. The vascular malformation that you find can be this: arteriovenous malformation, AVM. AVM can also cause a bleed. Okay. Now remember this: AVM causing hemorrhage can be lobar in the cortex or can be subcortical. So arteriovenous malformation causing a bleed can be cortical or subcortical, either of the two. Okay. There's no clear reason why parietal and occipital. There was just a chance that they found most often it was in that point. Okay. Another cause of intracellular bleed, don't forget, is the neoplasm. Neoplasm means the brain tumor. Okay. Remember this. This brain tumor could be primary or could be secondary. The primary brain tumor, which has been a cause very often for an intracerebral bleed, okay, is glioblastoma multiforme, being abbreviated as a word GBM. Glioblastoma multiforme, GBM, right? Secondary. Secondary can be a metastasis into the brain, and few metastases have been named to be a possible cause of a bleed inside them, that is melanoma. Second is the bronchogenic carcinoma. Third is a renal cell carcinoma. And the fourth is a choriocarcinoma. So these are the malignancies which can deposit in the brain, okay, and you can have this problem. Now, how to suspect? When to suspect a patient to be having an intracranial space occupying lesion, okay, who has presented with an intracerebral hemorrhage. Now, a patient with ICH, I'm trying to suspect a brain tumor inside the brain. When should I think about it? There are a few points here, write it down. Subacute worsening. Okay. Before the actual presentation, that means the patient of intracerebral bleed, before the hemiparesis happened, for few days and weeks was trying to have some weakness, and gradually one day he had complete plegia. So that makes me think that there is a tumor inside the brain possibly. Second concept that they write here is, if there is ring enhancement on MRI at 48 hours, that means 2 days time later after the bleed you find in the MRI there is a ring enhancing lesion being created, then you suspect this problem. Or if at all, unusual location. For example, the bleed is seen in this part, the corpus callosum. Corpus callosum is not a very known site for an intracerebral hemorrhage to happen, even the hypertensive one. So don't forget, unusual location like corpus callosum, if the bleed is seen, think of a tumor sitting there. Ring enhancement on the MRI has occurred at 2 days time on MRI, then you think about it. Subacute worsening before the actual presentation, then think about it. Oh my god, ICSOL. I stands for intracranial. Intracranial, it's what happens when you keep on typing in the chat box, no? And I keep on teaching a new topic. You are somewhere lost. Where has sir gone? Occupying lesion. Space occupying lesion SOL. Okay. After the neoplasm, don't forget, there's another cause for this problem. Can be use of sympathomimetic drugs. Sympathomimetic drugs. Okay, see, whatever I'm teaching today is exclusively for you guys, because even in the photocopy notes, this data is not there. If you are just typing in the chat box, you are missing a lot of things. Things will go over your head after a month. Use of sympathomimetic drugs. Okay. Some drugs, if you use in a patient, can cause a bleed. Don't forget the name. One is amphetamine, and the second one is cocaine. Right? Amphetamine and cocaine, actually, what happens in them? There is first of all, write it down. There is a reversible vasoconstriction. Remember them. Amphetamine, cocaine, both of them causes vasoconstriction, and in them there is reversible. That means it becomes normal. And when it becomes normal, the patient suffers with reperfusion. When the blood comes more in amount, it starts bleeding. Reperfusion, hemorrhage, with a severe hypertension. With a severe hypertension, they find. So when you use a sympathetic mimetic drug, reversible vasoconstriction occurs with a reperfusion hemorrhage in these patients with a very high blood pressure being recorded. Okay. Another one, anticoagulation, anticoagulant therapy. See, anticoagulant therapy causing a bleed could happen in two sets. Can happen in two sets. Either the patient is using a drug like warfarin, which I'm so scared of, or the patient has been thrombolized by drug recombinant TPA, right? Now, who are at risk? You can think about the risk factors of bleed secondary to an anticoagulant therapy. Firstly, first important thing is advanced age. More the age, more the chances of having uncontrolled hypertension. Uncontrolled hypertension. Okay. INR. INR is something that you keep on checking if a patient is on an anticoagulant therapy. If it is more than 2, then yes. So these are few things that you always think about anticoagulant therapy being a cause for a bleed inside the brain. But remember this bleed usually evolves over 24 to 48 hours. Like, hemiparesis and everything in a basal ganglia bleed, if it at all happened, it would happen in 5-10 minutes, half an hour, one day. Not beyond one day it would progress that much, but the deficit obviously will be there. But in this patient, after one day you find the deficit happening and worsening. That means it evolves over 24 to 48 hours time. Okay. Now, someone asked me, sir, in Harrison they write that head injury is a case of as a case of ICH. Is it possible? See, head injury we'll discuss today as well. It causes SCH, SDH, and EDH more frequently. But head injury, yes, can cause intraparenchymal bleed, especially in the temporal and the inferior frontal area. So inferior frontal brain and the temporal region, you find intraparenchymal bleed, especially in patients of head injury. Okay. So that's important thing to know about the risk factors. Risk factor for a patient of stroke. Okay. That a word about treatment also. How do I go and treat a patient of hypertensive intracerebral bleed? treatment for this patient. Now, first important thing, the blood pressure should be lowered and the systolic BP ideally should be kept below 140. Higher BP will cause more bleed and a more problem in the patient. Okay, so it's always better to keep the BP below 140. One thing. Secondly, uh, we should also think about, is the patient a surgical candidate? Surgical candidate for removing the blood from the brain, that is a craniotomy surgery. Okay, remember this, write it down. A cerebellar bleed, a cerebellar hemorrhage, which is more than 3 centimeter in diameter, is a good surgical candidate for operating upon. Most of the patients that you find are basal ganglion bleed. If you even send a neurosurgery reference, the neurosurgeon will write no active surgical intervention, manage medically. He's correct on this because cerebellar bleed is a bleed, okay, which can be evacuated easily, and it's always better to remove it. They also say if the ICH, okay, is associated with any kind of an aneurysm or a arteriovenous malformation, then in that case it's better to remove the blood. Okay, any young patient with moderate or a large lobar hemorrhage, which is clinically deteriorating. So a young patient with a large lobar moderate hemorrhage which is clinically deteriorated is a surgical candidate to remove the blood. Okay, so remember these 3 indications to come across and operate upon the patient. Most important is also to decrease the raised ICP. The intracranial pressure that you find inside the brain needs to be decreased. Okay. Okay, why not basal ganglia, thalamic, pontine, they are midline bleed. It's very difficult to remove it. Even in a lobar hemorrhage, they say if it is a young patient who is having a moderate or a large lobar hemorrhage, okay, in that case you operate upon, or an ICH which is associated with aneurysm or AVM, then it's better to operate upon. Okay, reperfusion or reperfusion, that means the blood was not there, the blood came in, and when it came it caused hemorrhage because a lot of blood is coming out now. That's the reperfusion hemorrhage. Okay, someone is asking me, I'm taking this Cineres drug and will I get a bleed or not? Long term these drugs should not be taken, on a serious note. Okay, long term they should not be taken. Right, now how do you decrease the raised ICP? That's important. How do you decrease the raised ICP? There are few concepts that you need to know. Treatment of raised intracranial pressure in any patient that you come across, there are some goals for it. Oh, someone is getting up from the sleep, writing on the chat box. So there is so much to add in the previous class notes. Good morning. This was a trailer. Wait for another 2 days, you'll start crying on Sunday. Sir, ये क्या किया आपने? I am Vinod ke papa. Don't worry. Goals. If you are thinking to bunk the classes and you already have the photocopy notes, 2 minutes of silence for your idea, because things are going to just add up to your previous notes. I will not have any idea what's been taught. Okay. Goals for ICP and cerebral perfusion pressure. ICP should be kept below 20 millimeters of mercury, and the cerebral perfusion pressure should be above 60 millimeters of mercury. Right? Now remember this. There's a very old concept. What is cerebral perfusion pressure? I'll come to that also. Cerebral perfusion pressure is equal to mean arterial pressure minus the intracerebral pressure. So that's a thing that you all should know about. Firstly, what happened? We'll make it in a circular way around it. There is vasodilatation in the brain vessels. The brain vessels suddenly dilate. Okay? The vasodilatation happens in the brain vessel due to certain factors like increase in the PaCO2, that is the arterial carbon dioxide level. Okay, it rises, it can happen. Second is pharmacological. We have got a vasodilator kind of drug with us, right, which can cause vasodilatation. Now this vasodilatation, as you understand, will increase what? Cerebral blood volume. So the cerebral blood volume will rise, and when the cerebral blood volume rises, there is going to be increase in the intracranial pressure. See, the ICP is nothing but the pressure of the CSF that we know. Now if there is more blood, there is more ultrafiltration in the choroid plexus, and there is going to be more CSF when ICP rises. If the ICP rises, what is going to come down? Cerebral perfusion pressure. So that's a vicious cycle. They say if the cerebral perfusion pressure decreases, vasodilatation again happens. So vasodilatation occurs due to increase in the arterial CO2, or maybe due to certain pharmacological method, increasing the cerebral blood volume, increasing the ICP. When the ICP increases, the cerebral perfusion pressure drastically decreases. Okay. Now how to manage a patient with a raised ICP? Journal techniques. Treatment of raised ICP. In journal, I am talking about not only a patient of bleed or something. First is osmotherapy. Osmotherapy means I can give a patient an osmotic diuretic like mannitol, one, or I can give the patient hypertonic saline. So these are two things. By osmotherapy we can decrease the cerebral edema of the patient also. Okay. Second, you can give a drug which can decrease the cerebral edema known as the glucocorticoids. Glucocorticoid, of course, the old drug which we have used in meningitis also, known as the dexamethasone. Don't forget, dexamethasone is contraindicated, standing CI abbreviation as contraindicated. Okay, in two sets of patients. One is patient of head injury, you should not give steroids, and second, patient of stroke. Steroid doesn't do any help at all. So steroids are useful to decrease cerebral edema, agreed, but they are not to be used in head injury patients and patients of stroke. Number 3, we can also try in the patient hyperventilation. Why? Can you guide me on this? Why is hyperventilation considered to be good for these patients? What will it be useful for to decrease? and finally decrease the ICP? Please tell me. By hyperventilation, intubating the patient, putting him on a ventilatory support. Okay. What can we decrease? Yes, someone answered it correctly. PCO2 we decrease. If the PCO2 or the CO2 is washed out, suddenly things are getting sorted out now. Okay. It will not cause too much of vasodilatation now. Good. Somewhere we find a pressor therapy is also very helpful in these patients. Pressor therapy means we try to increase the blood pressure. Why? Why? Look at this please. If the ICP is rising and I increase the blood pressure, what will decrease? Cerebral perfusion pressure. So that's the concept here now. Somewhere we put them on an infusion maybe of norepinephrine or maybe dopamine. Norepinephrine or dopamine. And we try to increase the BP in a sense that we are able to manage the cerebral perfusion pressure of the patient well. See, hyperventilation, remember them. You are right, in surgery you read it, is only a short-term method. Short-term method. It's not a long-term method. Only for 1 or 2 days you do it and leave it. Don't do it for a very long time. Okay? So this is how do you manage a patient of raised ICP. Okay. Yeah, isoventilation is done. I agree, but we have to decrease the PCO2 initially, but it is a short-term method. That's why they always say isoventilation is preferred. Yes, you are right. Isoventilation is preferred, but if the ICP is very, very high and you want to decrease it fast within a day or an hour's time, you can go for hyperventilation also, but it's not routinely prescribed. Okay. Now let's move into the extracerebral bleed, that is the subarachnoid hemorrhage. Subarachnoid hemorrhage. SAH. See, the pressor therapy is to increase the mean arterial pressure. Okay, if I increase the mean arterial pressure, in spite of raised ICP, I can decrease the cerebral perfusion pressure. Okay, because anytime the goal initially maybe is to decrease the ICP, okay, and increase the cerebral perfusion. If the cerebral perfusion is good, I am able to save the brain well. Okay. Pressor therapy means increasing the pressure. Okay. Subarachnoid hemorrhage, another small but important topic. Steroids are basically to decrease the vasogenic edema. Especially we give steroid like Dexa in patients of raised ICP who come to me with maybe brain abscess. Okay, don't worry, the abscess is not going to flare up by giving steroids. It's going to at least decrease in the size. Not in the size, that the decrease will happen with the help of your antibiotic, but at least the surrounding edema will decrease. See, if I increase the mean arterial pressure, it will try to improve the cerebral perfusion pressure in this way. Subarachnoid hemorrhage, straightforward, simple topic. Subarachnoid hemorrhage, before we go into that, let's look into a space known as the subarachnoid space between the arachnoid matter and the pia mater inside. Okay. The subarachnoid space tries to contain two things within it. One is a network of vessels at the base of brain that you already know is the circle of Willis. And we know this quick fact where the two vessels are uniting in the circle of Willis. At the point of union, there is a small defect which comes in to enlarge itself to become an outpouching. Remember this, This outpouching is round, circular, and looks like a fruit berry hanging from a tree. Berry aneurysm. Now what happens in such patients? There is a rupture of this aneurysm. Look at this please. If there is a berry aneurysm sitting in the circle of Willis, it is going to rupture and create a lot of blood in the subarachnoid space. Okay. Now, why does this aneurysm happen? Remember this. It all happens here. There is a defect which is seen in the muscular layer or the tunica media of the vessel wall. So where the two vessels are uniting with each other, there is a small defect seen in the tunica media layer, which is going to open up and become an outpouching like this, to become a round, circular, looking like a fruit berry hanging from a tree. And when this ruptures, the release of blood is obviously in the subarachnoid space, and that is nothing but your subarachnoid hemorrhage. When I look at this subarachnoid hemorrhage and I look at the cause of it, etiology, one of the etiology is rupture of berry or saccular aneurysm. Number two, while number one is nothing but your trauma. Most common cause of subarachnoid hemorrhage is always considered to be trauma. But another very commonly asked question, most common cause of spontaneous subarachnoid hemorrhage is berry aneurysm rupture. Remember this, the word spontaneous is not the grammar spontaneous suddenly, no. Spontaneous means non-traumatic. Okay. So the word spontaneous basically means a non-traumatic. So non-spontaneous spontaneous word means non-traumatic. Okay. So most common cause of non-traumatic SAH is berry aneurysm rupture, while the most common cause overall is considered to be a trauma or head injury. Now, another thing which somewhere sits inside the subarachnoid space is the CSF. Can you tell me where is the CSF formed in? A simple question. And where is it absorbed in? We have discussed this also in the previous classroom teachings. In meningitis chapter, I think so, I've tried to discuss this. And you already know it's very simple. Just put the first two words of each one. Formed. Where is it formed in? Choroid plexus. Good. And where is it absorbed in? Yes. It's been absorbed in the arachnoid villi. Right? So CSF is formed in the choroid plexus, absorbed in the arachnoid villi, and those arachnoid villi are present where? Please tell me. Are they present in the complete subarachnoid space or the site of those arachnoid villi where the absorption is going to happen? Please tell me. You can put the initials of that thing if you know it. It's good. We have discussed this in the previous season 1 also. Dural venous sinuses. Agreed. But which one? Which dural sinus? Which dural sinus is going to receive the CSF for absorption? Enough of priming on this. Yes, the superior sagittal sinus. Good. So some students are recalling, some people are studying, some people are looking at their watch. Look at the difference. Superior sagittal sinus, right? Now, before we go into the drama of SAH, let's try to see where do these aneurysm really form inside. Okay, let me keep the mobile like this. You can see the camera and you also. Oh my God, Your chat box is like, some reading, getting vertical nystagmus every time. Down beating, up beating. Okay. Circle of Willis. My request again, take a full page for this work. Take a full one page for this one. Yeah, there is some confusion in decorticate and decerebrate. I agree with your confusion. Actually, if you open up your Genong somewhere, they have beautifully tried to explain it in a diagrammatic fashion. That if it is a lesion in the midbrain, the upper part, and above it, obviously above it, then it is a decorticate. If the lesion is somewhere below that any time, or even the upper pons especially, it is a decerebrate rigidity. So it's very difficult. I'll go like this. If it is above midbrain, it is a decorticate. If it is at lower midbrain or below that, it is going to be a decerebrate. Okay. Full one page for this work. Very important diagram, I'm sure in. Okay. Yeah, supratentorial is always decorticate. There is nothing wrong in that. Infratentorial, no, not like this. Infratentorial is decerebrate. Anything below the midbrain will be decerebrate. Arey Baba, this class is till 9 p.m. Till 12. Someone wants to stay till 12. Good. We'll see. Circle of Willis. Okay. See, I'll tell you, studying on an app is like a gym membership plan. It's all up to you want to do or not to do. But this time it's a personal coaching. Your coach is there with you to make you study. And sometimes everyone goes to the gym, but not everyone has that six pack. Like me, I've got a family pack. So what is there to be done? A dieting work or maybe some homework from your end with some doubts, of course, and whatever essential part to be taught and understood, we are doing that work. Okay. So if you are appearing for this year or next year, maybe, so be attentive in the classroom teaching. Whatever we teach, at least try to gather this that much. The rest of the things you will keep on revising and recollect in the exam very well. Okay. People who have attended my live lectures, yeah, I've only taken 2-3 lectures this year before the lockdown, and last year, yeah, to complete it was offline. You can just write extra things in a piece of paper and stick it there, because most of the content is going to remain the same. Only I'm going to add some 25% maybe. It all depends on you. If you want to study, I'll teach you new topics which I've never taught for the last 10 years maybe. Okay, I'll come to those topics also. Now I'm making this anterior circulation again that we have tried to make. There's an anterior communicating artery joining the two anterior subartery. The ICA will go into ACN and the MCA. Bifurcation we divide into the superior and the inferior division. A lot of confusion. It's a very simple thing. I'll repeat again. I'm not going into SH. I'm just revising what we learned in the infarct. Pre-communal ACA, nothing will happen. Post-communal ACA, lower limb weakness will happen. Pre or post-communal without anterior communicating will have lower limb weak, urinary incontinence and a behavioral problem. MCA, the entire territory is lost, hemiparesis with global aphasia. MCA superior division is lost, hemiparesis with Broca's aphasia. MCA inferior division is lost. Yes, what do you get? No hemiparesis. maybe, oh sorry, in Wernicke's aphasia left side and construction apraxia right side. Okay, so don't worry, things are simple, keep them simple. Chal. So this is the anterior circulation. Then we have the posterior circulation. Yeah, these new topics are quite essential for NEET. Why I'm teaching you new topics, because trend has changed. They are now going back to the old topics which were earlier asked, and they keep on asking about it. Right? And to be secular, not communal. Right. So this is the posterior circulation. The two vertebral join to become the basilar, which bifurcate to become the PCA. The anterior and the posterior circulation happily connect with each other with the help of what? The posterior communicating artery. So the anterior communicating connects the anterior circulation. Posterior communicating connects the anterior with the posterior circulation. So this becomes a round circle of Willis. Now where do you see the circle? Circle is somewhere here, in between. So it's a round circular thing which comes like this. So we are trying to look at the brain from below. So from the inferior view I see this. Now why this diagram was important? Because at the junction of the two major vessels in the circle of Willis, there is a defect in tunica media which is going to enlarge and rupture. First aneurysm and then rupture to become what? SH. So these are few perfect sites of the aneurysm found in the circle of Willis. Remember this question. The most common site for the aneurysm that we find, is this one, the ACA and the anterior communicating artery junction. So junction of the AC with the anterior communicating artery, this wala, is the most common site for the aneurysm to be found. Okay. Then another quick point is this. Around the aneurysm is nothing but the brain and some meningeal lining. So just imagine this, there is an aneurysm which is going to expand and soon going to recoil also. So whenever the blood comes into it, it expands, and whenever the blood leaves it, it's going to recoil back. Okay. Now we find somewhere that expansion of the aneurysm is going to compress the neighboring structure, and that compression is going to produce a pain that's known as the headache. So depending on the site of the aneurysm, you're going to find a typical pain. So we can write this in the diagram itself. If the aneurysm is at the MCA bifurcation, remember this, we get a typical temporal pain in this part. While if the aneurysm is at this point, posterior communicating or with the ICA junction, this one, we get a pain behind the eye very typically, which is known as a retroorbital pain. Right? And if at all the aneurysm is in the back side, the vertebral and the basilar junction, we get it in the neck pain, that is occipital, or the cervical pain. Fine. I just forgot to ask you this very question. Can someone of you guide me on this? The posterior communicating artery is a branch of which artery? Someone of you knows it. Good. The posterior communicating artery is a branch of which artery? The posterior communicating artery is a branch of which artery? Is it a branch of PCA, MCA, ICA, or ACA? It's a very commonly asked question somewhere in anatomy section, ICA, good. ICA actually trifurcates. It doesn't go in, no, not PCA, ICA. ICA will trifurcate into posterior communicating AC and MCA. So don't mark this question wrong. Another very commonly asked radio or anatomy question is this. Which of the following artery is not the part of circle of Willis? ACA, posterior communicating, MCA. Which one? ACA, posterior communicating, or MCA? Which of the following is not the part of circle of Willis? MCA. It is outside the circle, correct? So we are trying to make the circle in between like this. Now don't forget the retroorbital pain in posterior communicating and ICA junction aneurysm is often associated with a third nerve palsy, third cranial nerve palsy. So third nerve palsy occurs in these patients. Okay. Ophthal, guys. I have asked a doubt also. I'll share with that which hemianopia occurs. Ophthal people, please tell me. Initially in this patient of aneurysm, will there be pupillary involvement or pupillary sparing? What will happen? In these patients, third nerve palsy due to aneurysm, will there be a pupillary dilatation or pupillary sparing? Okay. Some priming. Priming I'll do, don't worry. Priming is P for peripheral, P for pupillary. Sparing, Margaret. This is what happens when you don't revise and you just read. To improve your hippocampus, only one thing is required: revision. Even I revise, I study, I revise my son's syllabus also. He never studies. I know better than him. Okay, I'm Vinod ke papa, that's why. Arey Baba, I'm giving a hint na. Oculomotor fibers are pupillary, which are peripheral, and oculomotor, moving the eyeball, right? Aneurysm is outside na. It's an aneurysm sitting outside. If it comes and compresses the third nerve, which fiber will be lost first? Pupillary fibers. Because from outside some fugax is there, don't panic, it will get corrected. Pupillary fibers, okay, the pupillary fibers are going to get compressed first. So initially in these patients, before the ptosis and all that drama to happen, there is going to be pupillary dilatation. And now after that, I'm putting an arrow to explain that word oculomotor fibers. After that, you're going to have what? Ptosis. Simple. Yeah. Now, this is about the basic of circle of Willis and few facts related to it. Now the clinical features. Subarachnoid hemorrhage. Immediate. When an SH happens in anyone, there are some symptoms which happen at the onset of it. Okay. So I remember this patient. To explain the symptom of SH, the best example will be a clinical example, of course, a funny humorous one. I remember there was a patient who came to me in my OPD long back in my residency days and was brought by 3 of his friends. And they all came and told me one thing together. Sir, doctor, we were together in a room drinking alcohol, party time. And suddenly one of our friends started shouting that an electric current has come and fallen over his head. And the moment he told us this, he became unconscious. He remained unconscious for 2 hours and then he became fully conscious. And now all this happened 2 days back. First of all, I told them, very good people, you came 2 days after it, good. So now what is the problem? They all told me, you talk to the patient, you will find the deficit. You know what the patient told me? Okay, doctor, 2 days back, I was in a room and suddenly electric current fell on my head, passed through my body as a shock wave, and I became unconscious. I remained unconscious for 2 days. Now I am fully conscious. But the problem is that electric current from head to toe which went is moving still inside me. I immediately said, very good, power bank, come here, idara. Let me charge my mobiles from you. You are a good man. But the problem was he was a known alcoholic and he was not drinking for last 2 days. I thought all these are hallucinations he's getting. He's in an alcohol withdrawal stage. So I referred him to a psychiatrist. And to my surprise, maybe 2 or 3 days later, the same patient came back to my OPD with a CT scan being done by the psychiatrist, and the report read like this: acute subarachnoid hemorrhage, please correlate clinically. Now just imagine this. This is a subarachnoid space, okay? And there is an aneurysm right over there. And suddenly there is a rupture over here. Now what will happen? The blood will leak and will come down along with the CSF, which is not only running around the brain, it's also around the spinal cord. So my patient gave me this complaint. He told me, doctor, 2 days back, suddenly I felt a thunderbolt has come and hit my head. The headache which happened was maximum at this point and it gradually went down towards the earth. And for last 2 days, that current which has gone down from head to toe is still revolving in me. But the description of the patient wasn't this. What he wanted to convey me is this. When the headache happened at the onset, the headache was at the peak or the maximum. And in a very short time, it declined and disappeared from the scene. So headache, when it happened, it was maximum at the onset, okay, and in few fraction of seconds it declined and went away from the scene. The worst headache of life, the first severe headache, or the headache as if a thunderbolt has come and struck my head, is known as a thunderclap headache. Correct? And my dear friends, if you have drawn this wala diagram, please remove it. Hatao. Remove it. Erase it. Cut it. I'll tell you why. Because you guys read today and revise not tomorrow. You revise after 1 month when DAMS has given you time to study. When you think your sleep is full 100% complete and your stomach is full. Conditions apply, you study always with that. And now when you study and you might see this diagram, you might worry, what did I teach in this diagram? Because one student has clicked a photograph of this and put it very proudly on the Facebook. And he asked me, sir, what did you teach in this diagram? I said, Dekh nahi raha, I taught this na. Babaji ka thullu. So every one of you I know is finding for an kind of a timing which should be so comfortable with you to revise. We should give you full 1 month to revise. Stop the classes in between. You should also sleep for 8 hours in a day. Then only your brain will work. Wow, wow, wow. When you're doing a binge walk on Netflix, I know how many hours in a day do you really sleep. Okay. So don't ever study with conditions apply. Remember my words. Doctors are like soldiers. When they feel like sleeping, they should sleep. When they feel like hunger, they should eat. If you find for your ideal time, nothing will happen ever for you. Okay. Along with this, very important, neck rigidity. Thunderclap headache with neck rigidity. Why? Because this happens. Meningeal layer which is now having blood will have stiffness, neck rigidity. Loss of consciousness occurs in the patient, but the patient often recovers with it. There's a transient LOCC. And above all, in the patient, there is no focal neurological deficit. Why? Because the blood never collects at a point. Remember this. If it started sitting and accumulating around the frontal lobe, then in that case there can be a behavioral problem, temporal memory, parietal sensory, occipital vision. The blood never sits at a point, never collects, there is no deficit. So there is no focal neurological deficit in a patient of SCH at the onset of it, when it really happens. But remember this deficit will come later on, is known as a term delayed. Now delayed deficit occurs due to one reason, that is the vasospasm. Why? Look and follow this. There is a vessel running with blood. Around the vessel there is blood starting collecting, subarachnoid hemorrhage. And now what will happen is the blood starts collecting around the vessel. When the blood starts collecting, obviously being a blood, it will start clotting. And when it starts clotting, it will narrow the lumen and stop the flow of the blood inside the vessel. So look at this concept, please. There is a patient with me of subarachnoid hemorrhage, and now in the brain I find ischemia and infarction. Correct? Can you define this ischemia and infarction for me? Is this ischemic injury infarct embolic, or is it thrombotic? Please tell me. Type the initial part of it, don't type the full. E embolic or T thrombotic? Please tell me. Thrombotic. Good. Thrombotic. Excellent. Thrombotic, thrombotic. Okay, people who mark it as T thrombotic, tell me, where is your thrombus? Arey Baba, answer is none of the above. It is not embolic, it is not thrombotic. Read it carefully. It is due to what? Vasospasm. The vessel gets compressed by the blood collecting around it circumferentially. Yes, vasospasm. So it is not embolic, it is not thrombotic, it is due to vasospasm, right? Now vasospasm never happens so early, it happens delayed. Why? 4 to 14 days after SH it happens. So not immediately of SH it will occur. It will happen 4 to 14 days after the SH has occurred. Right? And don't forget this question, a very commonly asked one-liner. The most common cause of morbidity and mortality in a patient of subarachnoid hemorrhage is nothing but your vasospasm. Okay? So a patient of SH dies because of this villain, and the name of this villain is nothing but your vasospasm. Okay. Second thing, don't forget, is known as a term re-rupture. Re-rupture. Now, why do we call it as re-rupture? Because a vessel or aneurysm ruptures, and the tear happens not at the lower part with a touching vessel neck. It happens at this part that is known as a dome. So the rupture of aneurysm often occurs at the dome part. So wherever the rupture has occurred, at that point the coagulation cascade will come. So what happens like this? The dome ruptures, okay, releases some amount of blood in the subarachnoid space, causing SH. But God is great, it is going to come and seal the site. Once this particular site has been sealed, what will happen now? It is sealed, it's closed. But if you don't try to track or rather investigate the aneurysm, is it there or not, and most important, you don't treat it, what will happen? Will it be sealed all throughout the life? No, Baba, it will rupture again, re-rupture. Remember this. There are chances of nearly 30% of re-rupture in the very first 1 month of the disorder. So in the very first 1 month of the disorder, the chances of re-rupture nearly is around 30%. Okay. Third, hydrocephalus. Hydrocephalus. Why hydrocephalus? Somewhere if you know this fact, when the blood is moving down in the subarachnoid space, okay, it can obstruct two things. What? One is aqueduct of Sylvius. If you remember a short diagram, I'll just make it the Mickey Mouse. The lateral ventricle, the third ventricle, and the fourth ventricle. Between the two is a small tube-like thing like this, known as the aqueduct of Sylvius. If the blood starts collecting around it at the base of the brain, yes, CSF flow is going to hamper, and now obstruction of the CSF flow will lead on to dilatation of ventricles. Hydrocephalus, nothing new, you know this. Second, this blood of the subarachnoid space can also obstruct another area where the final movement of the CSF going to happen. Superior sagittal sinus. So just imagine the blood goes up and sits in the superior sagittal sinus where the CSF is going to get absorbed. So now one thing, there is difficulty in moving the CSF down. That can be a cause for your raised ICT and hydrocephalus in these patients. And the second wala, as you can understand, the absorption of CSF is delayed. Again, in that case, the CSF is going to sit in the ventricular cells or the ventricular in the ventricles, causing hydrocephalus. Number 4, something which can happen later on is hyponatremia, low sodium. Why? Because whenever I have a raised ICT phenomena, there are one thing which comes out from the brain, the BNP, and the name abbreviated enough, but it's good, brain natriuretic peptide. As the name suggests, it's natriuretic. Natri stands for the sodium, the uretic stands for the urine. Now what happens is this. The sodium will now be dragged out into the urine, natriuresis. Because of this, the blood sodium level will fall down, right? Along with the sodium, one thing will again come through the osmotic gradient. What? The water. So I got less of sodium and less of water in the patient. We use a term to explain this drama is hypovolemic hyponatremia. Hypovolemic hyponatremia, right? Now, to put it all together is under one roof as a name thing. We have discussed this previously also. Cerebral salt wasting disease. As the name suggests, disease is a problem. Waste is a loss of this salt, that's the sodium, because of the problem in the brain. Cerebral salt wasting disease. Okay. Hypovolemic hyponatremia. We will touch upon this topic again somewhere when we discuss about SIEDH also. See, the blood here, I agree, will disintegrate, but it will not be absorbed. Somewhere it will go into the rotation and sit over there. See, it's not 10 or 15 ml of blood loss. It may be more than 100 ml of blood loss. So traumatic LP, which you do somewhere, you end up having a blood loss of 10 or 15 ml, not more than that, but this is in more than 100 ml sometimes. So not every one of them will be absorbed. Somewhere will be stuck over here, somewhere will be stuck over here, and that can cause all this problem. See, hydrocephalus means a dilated ventricle. Dilated ventricle will occur because of two things, either obstruction in the flow of CSF or the problem in absorption of CSF. The absorption of CSF happens in the superior sagittal sinus and the blood sits there and tries to difficulty in reabsorbing. Okay. Aqueduct of Sylvius, yes, that's getting obstructed by the collected blood outside. Because of this, the blood, now the CSF will stay in the ventricles for a longer time. Okay. Now the investigation. Please answer my question, please. Oh, Tokde gang is back. Radio class, is it done or no? Because last time when we met, jab we met in April, at that time I think so radio was not being touched upon. Is it done or no? Yes, good, very good, very good, बहुत अच्छा, Mogambo खुश हुआ. Now what we'll do, we'll understand a basic concept of neuroimaging again. Okay. Now neuroimaging requires two things. Either you can do a computerized tomography or the CT scan, or the magnetic resonance imaging or the MRI scan. They have got their own merits, like a CT scan is always good enough to find what? An acute hemorrhage, and also good enough to find a lesion that has died somewhere or the calcified lesion. While on the other spectrum, the MRI is always good enough to see ischemia, infarction, and above all, inflammation. Correct? So I for ischemia, I for infarction, I for inflammation, I can see through an eye of an MRI. C for calcium, C for a clot, acute hemorrhage, I can always see through a CT scan. So, my dear friends, tell me please, if a patient of stroke comes to you, CVA, focal deficit, vascular cause, what is the first investigation you like to order? MRI or the CT? CT. CT scan. And don't forget, it is always and most of the time mentioned as a non-contrast CT. NCCT brain. The CT scan of the brain is always being done to rule out what? R/O stands for ruling out what? Acute hemorrhage. If the CT scan is normal, correct, what should you do next? You can do the MRI scan. MRI scan to confirm what? Acute infarct. So it's very simple rule that we follow, first CT and then the MRI. An MRI only required if the CT is normal or it doesn't catch any infarct or there is no bleed. Then only you go in for an MRI. Okay, that's the simple rule. Now we'll apply this rule to investigate a patient of acute SH. Investigation of choice. In a patient with acute subarachnoid hemorrhage. It's an acute event, it has freshly happened, that's why the word acute has been given to it, is what? NCCT brain. Correct? But if the CT is normal, can you guide me on this? What is the next investigation I can order for to maybe confirm a case is SAH or not? Any guesses, any ideas on this? The CT brain is normal. What else can I do to find an acute SH? Should I do a diffusion weighted MRI? No, no, no. That will only catch an infarct. It's a bleed. Yes, people are telling me correct answers. You do a lumbar puncture, LP. And now what do you find in the LP? No, don't do an MRI. MRI is not going to find an acute bleed. CT angio will be done to find aneurysm. I am talking about acute SA. Don't commit this blunder. And what in LP do you find? You find something that we have discussed in season 1, collection of blood inside the CSF. Xanthochromia, priming. CSF is coming out. I am doing LP and I find in the first test tube there is more blood, second less, and third minimum. In all of the 3 test tubes, I have tried to take out the CSF in a serial order 1, 2, and 3. Right? Priming intern story. Good. What is this? And what is this? I've already explained to you in the previous class. Season 1. Yeah, people are remembering. Gajnis are back. Oh, sir, yaad aaya. This one is a traumatic LP. Traumatic LP. In traumatic LP, with time, the blood will be less and less. While subarachnoid hemorrhage, the blood will be constant. Right? Simple. Now, problem is, acute SH is a stage of raised ICT. So please remember, although been written in the book, but clinically it is often being avoided at any point. Because we found somewhere the risk of conal herniation is very high in these patients. What is herniation? Conal, we'll discuss it tomorrow. Like if you imagine like this, if this was the brain and you put a needle below here, and it's a case of raised ICT. Suddenly what will happen, the brainstem will herniate downwards like this, making a cone. So raised ICT, conal herniation is very common if you do. So although being discussed theoretically, but practically we try to avoid it as far as possible. Nowadays 64, 128 slice CT scan machines are there. You can easily find a minimal SH also there. Now when you want to investigate an aneurysm, yes, for that the investigation of choice is your angiography. Okay, that all you will discuss somewhere in your radio classes. Now a word on treatment. Surgical treatment. Surgical treatment could be achieved by 2 methods. Yeah, sir will excellently teach you this CT angio, MR angio, 4 vessel angio. We'll discuss all this there. Surgical. There are 2 methods of treating these aneurysm. 1 and 2. I can put a clip over here. So this surgical technique is at the neck of the aneurysm, putting a clipping. As you can see this one, you put a coil inside the aneurysm and obliterate it forever. That is known as the word coiling. Okay, so this is clipping and that's the coiling method. Now what to follow is again surgical choice, but what to follow could be easily deciphered out by this thing. There are 2 aneurysms in front of us. One aneurysm has got a narrow neck and the second aneurysm has got a wide neck with it. Okay, please tell me, for a wide neck aneurysm, what should I do? CO coiling or CL clipping? Just type it. Let me check your expertise. For wide neck aneurysm, what should I do? Coiling, CO or CL clipping? Okay, coiling. Wide neck coiling. Very good. So, Dr. Arjun Reddy of Kabir Singh, a great surgeon, went and did coiling in an aneurysm which had a wide neck. Next day, the coil went outside the aneurysm. Now, just like Preeti, he's doing an angiography to find where has the coil gone. Okay, it will not come back. So, my dear surgeons, for a wide neck aneurysm, you do a clipping because a coil will come out, and for a narrow neck, you do a coiling procedure, right? There's another therapy that you follow, that is the medical therapy. Here, emojis come very fast, but answer comes very late. Okay, typical TikTokers, Medical therapy. Medical therapy includes one thing. Nimodipine. Nimodipine is a drug which is a calcium channel blocker, and it inhibits the villain of the story, that's the vasospasm. If you know the drug nimodipine, it's an intracerebrally acting calcium channel blocker. Okay, so it causes a sort of a vasodilatation. In a term, it tries to inhibit the villain vasospasm in the patient. So to treat vasospasm, it's not amlodipine, it's not nicardipine, nifedipine, it's an old drug nimodipine. Apart from this, we can follow this triple H therapy. Triple H therapy. There are 3 H that we find with the patient. First wala is the hypertension. Second one is the hypervolemia. And the third wala is hemodilution. So there are 3 H that we find here. Now, how really does it help is this. If the aneurysm or has ruptured and the blood has come from outside and it is trying to compress the vessel from outside through vasospasm, I can oppose it all by applying more pressure from inside, like this. If I apply more pressure from inside outwards, I can dilate the vessel and inhibit what? Vasospasm. But how do I apply more pressure on the vessel wall laterally? By increasing the pressure. That's a term known as hypertension. How do I do hypertension? By giving more fluid to the patient. But how do I give these more fluid? I give it through the IV route. So if I give more IV fluid to any person, the blood is going to dilute. Hemodilution. So that's the concept of the triple H therapy. But remember this. Again, conditions apply. It is again nowadays said to be avoided. Why? Because there is an aneurysm and it ruptured, the blood came out and it got sealed. If you don't try to maybe treat it and you start the patient on hypertension with hypervolemia and hemodilution, what will happen again? Re-rupture. So in a term they say it increases the risk of re-rupture very often. So again, it is something which is nowadays being avoided in most of the centers. Although it's given in the book, that's why I'm teaching you this topic. So next time if they ask you triple H therapy is used in patients of SAH, SDH, EDH, none of the above. Don't go and mark none of the above. You can easily mark the answer as SAH. Okay. Now two brothers of SAH, the last nail in the coffin of stroke, SDH and the EDH. Okay, this is something I think so in surgery you might have discussed. SDH and the EDH. Subdural hematoma happens due to rupture of cortical bridging veins. The EDH happens due to rupture of middle meningeal artery, being abbreviated to me as a term MMA. So look at the first major difference between the two. This is a venous bleed and this wala is an arterial bleed. Okay, so we can just understand this in a very simple classical clinical way. A patient suffers with a head injury, which can be a minor trivial trauma or a major trauma, and post head injury patient complains of headache. Now headache with a sort of a neurological deficit also, like hemiparesis or something. And don't forget, the headache and neurological deficit increases over days, over weeks, and over months, or it increases over few minutes and hours. Just imagine this. If it is a venous bleed, the blood will leak out slowly and it will start compressing the neighboring structure maybe after a longer time. So the deficit will take a lot of time to really show its effect, or rather be apparent to me. That means the progression here is slow, while on the other spectrum, it's an arterial bleed EDH. The blood will collect as per the pressure of inside the vessel. That will be a very fast progression. So here the progression is slow in a venous bleed. Here the progression is fast. Okay. Now what we'll see on a CT, something in radio you guys discuss it very often. SDH is concavo-convex. EDH is biconvex. It looks like a half moon semilunar. This looks like a lens, lenticular. I'm very sure in radio if Sir has touched about this topic, he might have discussed this line. SDH doesn't cross what? And EDH doesn't cross what? This is discussed in even in surgery also. Subdural bleed doesn't cross what? See in the diagram. The subdural bleed doesn't cross what? Midline. And the EDH bleed doesn't cross what? The suture line. So remember this. The EDH bleed is more often located where? Temporoparietal. Okay. So EDH bleed is often located in a zone temporoparietal. Okay. Something about radio, very useful concept. SDH has been classified into three heads: acute, subacute, and chronic. You know, something you should always know, whenever the blood leaks on an imaging, like a CT for example, it will look white. So that whiteness on a CT scan is not written as a whiteness. It is written as the word hyperdense. Okay. So it's white is hyperdense. That means it's glowing, it's shining. But all that glitter is not gold. So it becomes isodense. And then it will become a black money trail. Hypodense. It becomes black hypodense. Okay. Now something you read in radio again, please enlighten me on this. If I want to see this hyperdensity, I might confuse this hyperdensity whiteness as a bone tissue or the blood. I don't know this. Please tell me who is always better for me to differentiate between bone versus blood. It's a very small old concept of radio, don't forget it. Bone versus blood, who is better to tell me? CT or MRI? Yeah, CT scan. Not the MRI. Hounsfield unit. Where are you guys? MRI कहाँ? देखो. I'll tell you. Not MRI. Hounsfield unit are always different for blood and always different for bone. Any bony tissue is always read through a CT scan better. I'm applying this concept here. Acute hemorrhage is always seen through what? CT scan better. Okay. Then an MRI. MRI will always find an acute infarct, inflammation. CT scan will always pick out an acute hemorrhage. So my dear friend, don't do this blunder. Some fugax happen. Don't worry. You'll get all right. CT is better than MRI. Now please, my dear radiologist, tell me which is better in isodense and hypodense. Please tell me which is now better in subacute and chronic. MRI better than CT. Recall these words of Sir in radio class. In a patient with an acute SDH, CT is preferred. Subacute and chronic hypodense is something which can be seen as infarct or a chronic blood, which is always deferred through an MRI better. Correct? Ha. Cerebral edema in intraparenchymal bleed peaks at what time? This is something memory based, cannot help you much in this. 48 hours. Cerebral edema in an intraparenchymal bleed peaks at 48 hours. Like, you know what happens when the blood loss occurs, right? Around 48 hours time after the bleed has actually occurred, the cerebral edema starts happening over there. Okay? And 3 to 5 days time, it will disappear. Remember this point. Cerebral edema in an intracerebral bleed will disappear in 3 to 5 days time, and it will peak in 2 days time or 48 hours time. Right? Which of the following primary brain tumor can be present with an intracerebral bleed? Please tell me. I've already written this down. Is it pilocytic astrocytoma, craniopharyngioma, medulloblastoma, or glioblastoma multiforme? Glioblastoma multiforme, that was a primary brain tumor. Okay. Which of the following is not a common site for a hypertensive intracerebral hemorrhage? Not a common site. Medulla, pons, cerebellum, basal ganglia. Medulla. Medulla is not a common site. You find infarct, you find medial lateral medullary syndrome, you find ischemic injury more often there than a hypertensive bleed. Which of the following statements about intracerebral hemorrhage is false? False. Tell me. Focal deficit worsens over 30 to 90 minutes. That's true. Okay. It occurs in an awake state. That's again true. there is a focal deficit happens all of a sudden, yes. Are seizure common with it? Are seizure common with it? See, I'll take you like this. The intracerebral hemorrhage, ICH, the most common cause is hypertension. Hypertension, the most common site is what? Basal ganglia. And this site, basal ganglia, is it cortical or subcortical? Subcortical. First class, season 1. Seizure originates from where? Cortex. It doesn't originate from a subcortical structure. So seizure are not a common phenomena, my dear friend. Abrupt onset focal deficit can happen. It's a very simple trick. I'll write it down here. Either it can be an embolic stroke, or it could be a thrombotic stroke, or it could be a hemorrhagic stroke. 3 strokes which we know. Okay. Onset. All of them, remember, is abrupt onset. All of 3. Okay. Maximum weakness. When does it happen? Maximum weakness I'm talking about. That means the neurological deficit happens at the maximum time. Embolic at the onset. We have discussed this. Embolic improve with time. So the maximum weakness in embolic stroke is at the onset. Thrombotic stroke, the maximum weakness is later. Even hemorrhagic stroke, it is later. Now, just continuing it. Consciousness. Who is going to be drowsy among the 3? Please tell me. E embolic, T thrombotic, or H hemorrhagic? Common sense. Who is going to be more drowsy? One who has got cerebral edema. Who has got cerebral edema? Hemorrhagic stroke. So the patient with a hemorrhagic stroke is found to be drowsy. Right? While in embolic and thrombotic, it could be normal also, consciousness. Okay. So this is how we try to ascertain. Seizure. Now coming to this. Which stroke is most epileptogenic? I have discussed this topic also in the previous class. We can write like this. Embolic stroke is most epileptogenic stroke. So if a patient comes to me with a seizure followed by a focal deficit, I can think about an embolic stroke to be more frequent. Hemorrhagic plus minus, thrombotic is plus minus, but the most epileptogenic stroke is always an embolic stroke, not the hemorrhagic stroke. Okay. Which of the following is true about intracerebral hemorrhage? It constitutes 10% of all strokes, yes. Usually has a normal level of consciousness, no. Cerebral perfusion pressure is maintained between 30 to 40, no. It is between 50 to 70, usually we take the average as 60. Head injury is not a cause for SAH. That's again no. So best answer is A. They constitute to 10%. This I just forgot to tell you. Like so many scores we have got. ABCD2 score is for TIA. CHAD 2 score is for oral anticoagulation in a patient with AF. Okay. Same scoring system is an ICS scoring system. Okay. In ICS scoring system, we take hematoma volume, we take the GCS, Okay, we take the age of the patient but not the blood pressure reading. So just remember this: age, GCS and hematoma volume are taken as factors for the ICS scoring system. I'll write it here, don't worry. ICS scoring system, okay, takes into consideration age, GCS and the hematoma volume. Three things. The ICS scoring system, just like another scoring scale in subarachnoid hemorrhage patient. Yes, a very popular name. Need not know the detail, just know the name is sufficient. Hunt and Hess scale. Hunt and Hess scale. So there's a Hunt and Hess scale that is applied in patients of subarachnoid hemorrhage. There is an ICH scoring system that is applied in patients of hemorrhagic stroke. CHAT2 score is applied in patients of AF, which is non-rheumatic, and ABCD2 is for TIA. These scoring scales have become suddenly very important. The last 1 year at least they are asking you about the name. If you are able to tell the examiner like which scoring system for which disease, more than sufficient. Okay. Decerebrate rigidity is most likely to be seen in which of the following hypertensive intracerebral bleed? Decerebrate. Pontine. We have done this on time. In a patient with a spontaneous ICH, that is non-traumatic again, initial BP is 150 by 220, very high. Systolic BP can be safely lowered and rapidly to how much? Less than 140. This is a cutoff that we try to lower it first. All of the following are good candidates for surgical management of intracerebral bleed except. Tell me. A, B, C or D. Cerebral hemorrhage more than 3 cm in size. We have written this down. It's a good candidate. Young patient with a moderate or a large lobar hemorrhage who's deteriorating is again a good candidate. Surgically accessible intracerebral bleed due to aneurysm and AVM again is a surgical candidate. But a basal ganglia bleed, I repeat, thalamic, basal ganglia and pontine are left there only. There is no active surgical intervention. Okay, so this is not a good candidate for a surgical management. Which of the following is not recommended in treatment of patients with raised ICP? Tell me. Steroids. See, it's a journal question. They don't ask you about hemorrhage, head injury, just raised ICP. Steroids are used, glucocorticoids, I already told you. Hyperventilation, short-term management, good. Not a long-term, that's why surgery cert keeps on telling it's isoventilation better. Dopamine pressor agent, yes. Furosemide, no. Mannitol, osmotic diuretic, not loop diuretic. Okay. Which of the following is about SH is true? SH is always due to trauma or aneurysm rupture. No, this is false. I'll tell you why. Sometimes they found that SH could occur due to something like dural fistula also. SH happened in patients with arteriovenous malformation also. So they are not always the cause. They can happen rarely due to these things also. Giant aneurysm is more than 4 cm. No, it is considered to be more than 2.5 cm. Aneurysm at the posterior communicating artery junction with the IC has got a cervical plane. Let me rewind this fact. Posterior communicating artery with ICA will not give me a cervical pain. What pain does it give me? Retroorbital pain. Retroorbital pain. Seizure are uncommon at the onset of rupture. Yes, my dear friend, yes. Most of the bleed, even extracerebral, they do not cause seizure at the onset. It's not that common. It's uncommon with them. Okay. 46-year-old patient complains of severe bursting headache. On examination is found to be conscious but restless with neck stiffness preceded by a throbbing retroorbital headache. Dropping of the right eyelid. Aneurysm is most likely located in which of the following site? Can you tell? A, B, C or D? Simple. Circular Willis again in front of you, and a clear-cut case with neck stiffness, severe bursting SAH, preceded by a throbbing headache which is retroorbital. Yes, we have discussed this. The aneurysm is most likely to be present at this point. Posterior communicating ICA junction. B. Okay. So the same concept which is theoretical is applied in an image based question like this. So don't get scared on seeing them. They're very simple ones. This is another easy one. 63-year-old female presents in emergency room with an acute aneurysmal SAH and she underwent a clipping procedure on admission. She has been recovering in the ICU. On the 10th post-op day, she noted to have a slurred speech with the right facial drop and the right arm weak. She's had got difficulty in arousability also. Now what CT scan and a 4-vessel angiogram showed me ischemia in the MCA territory. So look at the timeline. SH, we did a clipping. In spite of that, the patient develops a neurological deficit. What is the reason for this deficit? Nothing but the villain, vasospasm. So you might do a clipping, in spite of that a deficit occurs, vasospasm. So this happens, and then that happens. Chronology समझिए. So how do you treat vasospasm? Calcium channel blockers, yes. Intra-arterially acting, simple. 40-year-old female is brought to the emergency after being unresponsive following a sudden bout of severe headache at work. Keywords. On examination, her blood pressure is 180 by 110, very high. Her respiration is irregular and is Kienstoke type. She is agitated and doesn't follow commands. Moves her extremities spontaneously. Answer me. A 40-year-old female is brought to the emergency room after being unresponsive after a bout of severe headache. Blood pressure is high. Her respiration is irregular, raised ICD, Kienstoke type. She is agitated, doesn't follow command, but moves her extremity very well. Most of you guessed it right, SAH. I'm happy with it. But can you guide me, why is it not ICH? This question has appeared in AIMS, PGI, JIPMER, everywhere this question has come. Same question. Can you guide me, why is it not ICH? I say the BP is high and hypertension is the most common cause of ICH. Why is it not ICH? Please tell me. Look at the last line. Moves her extremity spontaneously on her own. Yes, very good. See what happens in a hypertensive ICA, the most common site was basal ganglia and the patient had contralateral weakness or hemiparesis. But here the movement of the extremity is perfectly normal. I repeat my words, in SH patient there is no focal neurological deficit seen. Okay? So it's SH. People know it. I'm very happy. Okay, I'm खुश हुआ. I'll teach more, don't worry. 62-year-old diabetic patient presents with history of progressive right side weakness of 1 month duration. Patient is having speech difficulty. Fundus examination shows papilledema. 2 months ago, she had a fall in her bathroom and struck her head against the wall. So there is a preceding history of trauma 2 months back. For the last 1 month, she is having slowly progressively increasing deficit with raised ICT or papilledema. Where does my patient sit into now? Nothing but my chronic SDH. Such a long history, slowly progressive course, post traumatic, raised ICT, papilledema goes with D. Correct answer, correct answer. No doubt. Now let me ask you, why is it not Alzheimer? Alzheimer, no, it's not Alzheimer. Why is it not left parietal glioma? See, my patient has got weakness. Weakness can happen in a parietal lobe lesion also because majority of the corticospinal fibers are originating from there as well. Correct, one thing. Secondly, in a brain tumor, there is raised ICT, and the raised ICT is better checked in a fundus examination in form of papilledema. Correct? So why not a left parietal glioma? Answer me please. Okay, why not this parietal glioma? History of fall. Oh my god. Brain tumor are going to cause seizure. Brain tumor causes seizure. After seizure, anyone can fall. See, parietal glioma doesn't mean raised ICT and weakness. In this very case, there is no parietal symptom. If you remember these symptoms, astereognosis, graphesthesia, and all that. So in these patients, there is no parietal lobe symptom seen. So it cannot be qualified for a left parietal glioma. Left MCA territory stroke? Yes. Can't it be a left MCA territory stroke? Look at this. Weakness, left MCA will be on the right side. That is there in the patient. The infarct which is there can increase in size over the time and can cause raised ICT. That explains the papilledema. Why not this left MCA territory stroke? See, I've explained this. Weakness improves, weakness goes down. Weakness improves, embolic. Goes down, tragedy, thrombotic. Please remember this fact. All this drama will happen just in a week or 7 days time. It won't take a month time to happen. Okay. So it is unlikely to be an MCA territory stroke. The best answer, you already answered it, is D. Remember the trick in a clinical question. I keep on telling every year that you should know what is the answer, why it is an answer, and above all, why not the other people. Right. So we'll take a tea break of 15 minutes time. Again I write, don't ask me again and again. Class is till 9 p.m. Let me draw an emoji for this. Okay. Asu. And an emoji for this. Any doubts? I'm there sitting and at my house. Why pupillary dilatation happens first? Because the pupillary fibers in a third nerve, if you see a oculomotor nerve, it is peripheral. So I'm drawing a section which is a transverse one. So the pupillary fibers are peripheral. So anytime, anywhere, if I see an aneurysm sitting here, it is going to compress the pupillary fibers from outside. Okay. Now just imagine this diabetic neuropathy. In diabetic neuropathy, third nerve involvement is there, but there is pupillary sparing. Okay. Now what happens is this. If there is a vessel, okay, running with blood inside the third nerve, and this vessel is supplying the central part, and the central part was an oculomotor part, and the outer is a peripheral pupillary part. But the pupillary part doesn't get the blood only from inside, it also gets it from outside. So if at all in diabetes, I'm talking about diabetes, in diabetes, what happens? The vessel which is supplying blood to the nerve has got disease. There is anoxic injury which involves the oculomotor fibers as central. Okay, so in diabetic, you can write it here. In a diabetes neuropathy or third nerve palsy, there is what? A pupillary sparing, because the pupillary fibers, if they don't get the blood from inside, they will find it from outside. Okay. Management of SDH and EDH is already done in surgery. I'm not going into details of that. Okay. Already in Harrison, they have not given anything related to it. It is out of syllabus for me. So in surgery, they teach you better there how to manage it. Lucid interval. Okay, I forgot this concept. Lucid interval is something which is seen perfectly in patients of EDH. Okay. See, EDH, SDH is done in surgery very well. I have noticed. Confirmed it from everyone there. BNP is a brain natriuretic peptide. You know what happens? Whenever there is a raised ICT phenomena, from the brain, BNP comes out. As the word natriuretic comes in, it will take the sodium out into the urine, decreasing the sodium. Okay. Alzheimer disease. Remember in a very simple manner that Alzheimer is a disease in which you find in the brain cells atrophy, followed all because I can write like this. I will not write atrophy first. We'll write the pathological process causing it, known as the amyloidosis, causing atrophy in the brain cells, finally leading into a process of memory known as the amnesia. So this is how it really follows up like this. There is a change in structure of protein, that is amyloidosis, followed by atrophy, followed by the amnesia. Okay. Now, how does amyloidosis happen in patients of Alzheimer disease, and what happens in amyloidosis? In the cell membrane of any neuronal cell, so in the cell membrane of a neuronal cell tissue, we happen to see a molecule whose name is APP. Now, it is amyloid precursor, protein. Now, this amyloid precursor protein will be acted upon by various enzymes in a stepwise fashion. There are two enzymes which are going to work here. One is a beta secretase and the second wala is an alpha secretase. So there are two secretase enzymes which are going to work on the cell membrane, and the amyloid precursor protein is going to break into two products. One is a beta secretase product, okay, and second wala is a alpha secretase product. Now what we will see, another enzyme will come and work on this beta secretase product, which is nothing. I'm trying to break it somewhere in between like this, and that is my gamma secretase. So first amyloid precursor protein in a cell membrane, the alpha and the beta secretase work. They break it into two products, beta and alpha secretase product. The beta secretase product will be further being cleaved by another enzyme known as the gamma secretase. And once this has been cleaved, it will form two products. One is A beta 42, other one is A beta 40. Both of them are peptide structures. But remember this, the A beta 42 is a toxic product or amyloidogenic product. Well, A beta 40 product is non-toxic, right? What about the alpha secretase product? It forms a substance known as the P3 product, which is again found to be non-toxic. So A for Acha, alpha secretase product will be non-toxic. B for Bura, yes. The beta secretase product will form something bad for me, that is a A beta 42 peptide, which is a toxic amyloidogenic protein. Let me repeat. This is the first slide. Cell membrane has got an amyloid precursor protein within it, which is acted upon by an enzyme alpha and the beta secretase to reveal two products, beta secretase and alpha secretase product. The beta secretase product will be acted upon by another enzyme gamma secretase, which will break it into A beta 42 peptide and A beta 40 peptide. The A beta 42 is a toxic amyloidogenic protein, while beta 40 is non-toxic, while the alpha secretase product P3 is again non-toxic. The whole concept of your amyloidosis revolves around this. A normal protein is converted into a defective protein, and that defective protein is going to invite other people around it and cause neurodegeneration. Okay. Now, another important concept. There are certain genetic mutations which are lined up for these disorders. Especially the Alzheimer disorder, there are certain genetic mutations which are lined up for it. What are they? Okay, from where does this secretase enzyme come from? You and me can have it, but there are certain genetic mutations which are going to increase the activity of it. One genetic mutation is related to chromosome number 21. Now, chromosome 21 mutation, is a trisomy 21. It gives me an extra dose of APP gene. So we get an extra APPD gene in us because there is already one chromosome extra, and that will give me an extra APP gene. And they say Down syndrome, especially Down syndrome, if they survive beyond the age of 40 years, very common. If they survive beyond the age of 40, very common. Alzheimer's disease. Alzheimer's disease is already inherited trisomy of this chromosome 21. Okay, and if they survive beyond the age of 40, they're going to get it. Chromosome 14. Chromosome 14 is basically coding for a particular gene which is known as the pre-selenin 1. Now, pre-selenin 1, also being abbreviated as a word PS1, okay, write it down, very important concept, is the most common cause of early onset early onset familial Alzheimer disease. AD stands for Alzheimer disease. Okay. Remember this. For pre-selenin 1 and chromosome 14 mutation, the mean age of the Alzheimer disease to start is 45 years, and duration disorder that you find in them is found to be around 6 to 7 years. This disease is found to have more severe form, and most important, it stimulates secretase activity, because final product will come from a gamma secretase activity. Okay, that could happen through this chromosome number 14. That is the most common cause of early onset familial Alzheimer disease. Don't worry, it will get all right. Don't panic, all is well, all is well. Okay, duration is 6 to 7 years. Okay, more severe, and it activates the gamma secretase enzyme. I just took a power nap. It's my home, I can do anything. Okay, now another chromosomal mutation that you all should be aware with is chromosome number 1, that forms another protein particle which can cause it, that is known as pre-selenin 2. Okay, remember this, the onset of this disease in these patients is relatively late, at the age of approximately 53 years, and the duration of the disorder in these patients is somewhere found to be around 11 years. Okay, so they are late onset and slowly progressive. Don't forget another chromosome, very important, commonly asked mutation is chromosome number 19. This is something very frequently asked. It codes for a protein that is known as ApoE4. ApoE4, right? ApoE4 protein, if at all is there with us in a gene over there on chromosome number 4, it is going to decrease the clearance of amyloidogenic or any kind of an amyloid protein. So amyloid protein, if at all being formed in our body, will remain with us if ApoE4 gene is there in our family tree. So this is very important thing to understand, that ApoE4 gene basically in a long run is going to increase the risk of Alzheimer disease. So at least remember the numbers. I'll repeat again. Genetic mutation that are responsible for this disorder is chromosome 21, 14, 1 and 19. Chromosome 21 gives me an extra dose of APP gene seen in Down syndrome. If they survive beyond the age of 40, Alzheimer disease develop in them. Chromosome 14, pre-selenin 1, is the most common cause of early onset familial Alzheimer disease. It comes early and the patient goes off early because the duration is very short. Severity obviously more, and it activates the gamma secretase enzyme. Pre-selenin 2 comes late and the patient survives for a better time. And ApoE4 is late, maybe a late onset, but most important thing is ApoE4 gene, which decreases the clearance of the amyloid protein, right? People who have joined late, I don't know why. Amyloid precursor protein in a cell membrane will be acted upon by the beta and alpha secretase to form two products, and now final cleavage will be by the gamma secretase, which will form A beta 42 peptide and A beta 40 peptide. A beta 42 is toxic, A beta 40 is found to be non-toxic. ADA, oh my god, AD is Alzheimer, not autosomal dominant. Okay, right. Now, what are the factors which can increase the risk of Alzheimer and certain factors which can decrease the risk for the Alzheimer disease? The factor which can increase the risk of Alzheimer is family history. Family history, if at all positive, of Alzheimer disease. AD stands again for not autosomal dominant Alzheimer disease. Second important thing, age. Age is above 70 years. Elderly people are more prone to have it. Third factor is female. Someone asked me why females are more prone to have it. Can you tell me why females are more prone to have Alzheimer disease? Any guesses, any ideas on this? Don't put anything hormonal into this, nothing to do with it. They have got a long life. So they live for a longer time, and if they live for a longer time, they are more likely to have Alzheimer disease, right? Now, apart from this, ApoE4 gene I have already explained to you via chromosome number 19. Okay. Then few toxins to add here is aluminum, mercury, whose exposure can again increase the Alzheimer disease risk. Then we have the head injury or head trauma. Okay. Diabetes also, hypertension as well, and elevated homocysteine levels. Right? High cholesterol level also. High cholesterol level also increases the risk of the disease. Low levels of exercise. Low levels of exercise increase the risk for the disease. And poor dietary intake. Poor dietary intake of fruits, vegetables, and something outside my budget, red wine. So these are a few factors which can rather in a sense increase the risk of Alzheimer disease. Okay. Apart from it, we can also write low folic acid. There has been a study on this also, low folic acid. Okay. In previous studies, although being omitted now, is poor education. Poor education again increases the risk for the disease Alzheimer. So that's finally a good news for you today, that you have done a lot of primary prevention for Alzheimer by studying so much. Okay. My dear friend, it's not the poor education. It's not the poor education. It's poor maths. Now look at yourself. You were so bad in maths that your everyone in the house made you do MBBS. Okay. Now only few factors which have been found to rather decrease the risk for Alzheimer disease. Only few of them. One is ability to express complex written language, language in early adulthood. So complex written language, if you try to learn in early adulthood in a study, they were found to decrease the risk. Another independent study being done was NSAID use and ApoE2 gene. ApoE2 gene. So ApoE4 gene will increase the risk, ApoE2 gene will decrease the risk. Remember this fact. And of course, I know you all know one factor which will kill but will protect you from a lot of disorder is smoking. Smoking is protective for what kind of disorders? If you remember, smoking not only decreases the risk for Alzheimer, what other disorders I've discussed in the previous class will decrease the risk? Yeah, your old friend who was fascinating Parkinson, and the other wala was inflammatory bowel disease, ulcerative colitis. You know a lot of things. Good. Now, basically, when I look in a patient's brain of Alzheimer disease, there is going to be atrophy in the brain. Now, atrophy is likely to be seen in the temporal lobe, as well as it is seen very well in the parietal lobe. And I'm putting it separately is hippocampus. In the temporal lobe, there are few areas being marked where I see atrophy very well with them. One is the entorhinal cortex. Other one is a perirhinal cortex. Don't worry, all is well. Entorhinal and perirhinal cortex. These are the two sites where in the temporal lobe we find atrophy in these patients. Okay. Now, somewhere as an old MCQ given in patho book, not in the medicine book, is this: the changes of atrophy are found to be seen earliest not in the temporal lobe, it is commonly seen in the hippocampal region. Okay. Okay. Now, what was temporal lobe going to do for me? Working and a short-term memory. And what is the hippocampus going to do for me? Convert it into a long-term memory. This is how it does. Now, I can give you an example. You know, my own grandmother, I remember when she was alive, in her end of days, she was having Alzheimer. So what I used to happen that every morning she used to get up, make our breakfast, and we used to have it at 8 a.m. or 9 a.m. Suddenly 11 a.m. again we could smell the breakfast being made in the kitchen. And I used to go in the kitchen and ask her, Dadi, we had our breakfast, why are you making it again? She said, we did not have any breakfast since morning. You're going so weak, eat more food. That was loss of working memory. She did not remember we had a breakfast hour or two back. So it happened in our family that we used to have breakfast twice, lunch thrice, dinner 4 times. And what happened was after months or few weeks, from a 6 pack, we all in the family had a family pack. Because we are Punjabis, you know, by basically genotype. Khate pite log. Yeah, not pite green tea only in between the meals. So now everything happened so fine. After a year, there was an episode in my family, my own marriage anniversary. The whole family tree was there to celebrate it. Everyone in the family tree used to come out and touch my grandmother's feet. And suddenly, when my wife came and touched my grandma's feet, my grandmother asked my wife only one question. You know what? Beta, are you married? Then everyone in the family tree looked at me. You got married or you staying in living relationship? I said, nahi yaar, I am married. Grandmother has lost her hippocampus. Possibly the episode of marriage has not been converted into long term in her memory tree. Okay. That's a different sad story. My wife has got a very strong hippocampus. She remembers everything. Okay. Now, something I'll like to tell you. What are the features in the brain cells on biopsy in these patients? In the brain cell on the biopsy, what do you find? Okay, before that, biopsy and pathogenesis will go later on. Let me discuss some of the important clinical features of Alzheimer's disease. Clinical features. Now, the clinical features of Alzheimer's disease is grouped into two types: cognitive and non-cognitive kind of symptoms. Cognitive and non-cognitive kind of symptoms. Now the cognitive symptoms are basically like this. There is impairment of a lot of things in these patients. For example, Alzheimer's disease in a cognitive symptom obviously will have impaired memory, one thing, impaired judgment, second thing, impaired abstract thinking, impaired language, impaired orientation, impaired praxis, that is a movement, and impaired attention. So few things which are impaired in a patient of Alzheimer are cognitive symptom like this. Non-cognitive, if I look at, it can be two formats. It can be a negative symptom. Now in Alzheimer's disease, the negative symptom that we have, okay, apathy and depression. Some positive symptoms could also happen in them, like irritability and delusion. Psychotic symptoms, of course, can happen. Sorry, it's irritability and agitation over here. Just wrote it wrong. You can write irritability and agitation. Psychotic symptoms like that is delusion. So these are few symptoms which are taken as Arey Baba, negative means that means the patient is not talking to anyone, negative thoughts. Positive means that he is talking to everyone and rather abusing them. Okay. I'll come to praxis. I'll explain it in a different way so that you understand it better. What is apraxia and what is praxis? Okay. There is a CDR scale to grade Alzheimer disease. Now important is this, the name CDR scale. So there are many scaling systems we have been crossing through. ABCD2 for TIA, CHAT2 for a non-rheumatic AF with embolic stroke. Then we have the ICS scoring system for our intracerebral bleed. Then we have the Hunt and Hess for SAH. Now we have the CDR. CDR stands for Clinical Dementia Rating. Again, you can go back and read it in the books, but doesn't make any too much of sense for us. But let's just remember this Clinical Dementia Rating Scale is a scale that we apply for the MMSE, this mini mental scale examination. Yes, is also being applied for this, but I'm just telling you one thing extra, that is a CDR rating scale. Okay. The negative word comes in the sense that the person is not talking to anyone. That's the word negativity in the patient. Okay. Impaired judgment to decide what is good and bad, okay, is the word judgment in these patients. Now let's look into this. A term which I've been skipping and since morning is apraxia. What do you mean by apraxia and how do you classify apraxia? Okay, apraxia means a complex motor deficit, motor deficit, not attributable, not attributable to any kind of a pyramidal, extra pyramidal, cerebellar, or sensory dysfunction. So there is no pyramidal, extra pyramidal kind of a thing, okay, to cause apraxia. It's something exclusive now. Apraxia can be classified into various types, One apraxia is apraxia of speech. Apraxia of speech. Now the speech apraxia has got a problem. In the patient there is articulation abnormality present. The patient cannot articulate the speech well. Because of this, the duration or maybe the fluidity or the fluency of the speech has drastically decreased in such patients. So there is an apraxia for speech also. That means doesn't have any pyramidal, extra pyramidal kind of a thing. Still the patient cannot speak well. Another apraxia that we know is known as the buccofacial apraxia. Buccofacial apraxia. As the name suggests, buccofacial. Something to do with the muscles of the oral cavity and the face. Yes. So there is a problem in movement of mouth and the face in the patient especially while whistling and coughing. So while whistling and coughing, the patient has got a severe problem in doing these kind of acts. Another term known as the limb kinetic apraxia. Limb kinetic apraxia. In the limb kinetic apraxia, as the name suggests, you cannot move the limb so well. So there is something known as clumsiness in use of tools and objects. So just remember these three types, which are the broader type: apraxia of speech, buccofacial, and limb kinetic. But there are two more important types to read. One is ideomotor apraxia. Other wala is a ideational apraxia. Two more types to read: ideomotor and ideational. Okay. I can just briefly define it in a simple manner. In an ideomotor apraxia, patient cannot follow command in absence of a particular tool. What do I mean by this? I'll give you an example. I'll tell the patient to brush his teeth, but this patient will not be able to do it without the toothbrush. Okay, so how do you brush the teeth? He doesn't know that. He cannot do that particular act. Okay, but can imitate when the actual object is handed over. Are you getting my point? I ask my patient, tell me, how do you brush the teeth? He says, I don't know. But the moment I give him a toothbrush, he might imitate me. Now the word is imitation. He just looks at me and thinks that he's going to brush the teeth like this. No. He goes to the chest and start brushing like this. Okay, so this is something, an imitation of the act, but he doesn't know really where he has to apply the brush, over here or over here. Okay, so that's a term applied for a ideomotor apraxia. Okay, ideational. Ideational is also known as the conceptual. Conceptual. Okay. Conceptual means a deficit. Deficit in goal-directed activity or a goal-directed movement, but individual steps are normal. Okay, I'll give you another example for this. I tell my patient to prepare me a cup of tea. This time he cannot follow and he cannot prepare me a cup of tea. But if I tell him individual steps, like, okay, go to the kitchen, boil water. Good, he will do that. Now add milk to it. Yes, he will do that. Add tea to it. Patient will do that. Add sugar to it. He will do that. Filter it. He is going to do that. It's typically me only in house in the lockdown days. My wife tells me to prepare a food something. I'm totally deficit in a goal directed activity. No clue how to prepare. Only one thing in MBBS I came to know is how to prepare omelette and Maggie. But tea and coffee is not my cup of tea. But she always takes me to the kitchen and let me do everything like this. Okay. Yeah, like a robot. Yeah, nice name for me. So please rub it out because if you see this after a month or a year, you might wonder what was sir teaching us in the classroom that day. How to prepare a cup of tea. Okay. So this is something known as the ideational apraxia. So ideomotor means a total absence of the thing being committed. Even the small individual steps are not followed by the patient. But in ideational, small steps which are taking us to a goal directed activity is well done. Okay. So these are two things that you all should know about ideomotor and ideational apraxia. Okay. Now, people were asking me about this also. Hemispatial neglect. There's a term known as the hemispatial neglect. Okay, what is this word as hemispatial neglect? I'll explain this in a very simple way. Like for an example, like a normal person has been asked to make a clock. A normal person will make a clock like this. Okay, you keep on looking at your clock, watch, everywhere. You keep on looking at the clock. You never look at the textbook. You always keep on looking at the clock. Kitna time, kitna time. Okay. Now, hemispatial neglect patient will make a wall clock or a circular clock for me like this. So, what is the major difference in them? Maybe this field of vision is not seeing anything. Only this field of vision is seeing it. Maybe a normal person will bisect the line like this. Bisect the line, cutting it in between. But a patient of hemispatial neglect is going to cut it like this. Maybe this part he is unable to see at all. In a sense, he only feels the line extends from this point to this point and is going to cut it midline like this. Okay. So all these kind of problems, hemispatial neglect and all, okay, comes due to lesion in the parietal lobe. Lesion in the parietal lobe. So in the parietal cortex, very often we find lesion in these group of patients. Right. Now let's look into the brain, and in the biopsy that you do in the brain cells, what do you find in them? First foremost thing that we made was an amyloid precursor protein, which by the alpha, beta and the final gamma secretase activity converted itself into what? amyloidogenic or toxic amyloid protein, that is A beta 42. Now, A beta 42 peptide will reach the brain cell and will not be beta plated anymore. It will become a tangle loop and coil. And this tangle loop and coil is nothing but your neurofibrillary tangles. So there is something found in these patients, that is neurofibrillary tangles. So in patients with Alzheimer, you find NFT in the brain cell. One important point here to write is that these NFT particles are always seen inside the brain cell. They're found to be intracellular. Okay. Constructional apraxia, I think so you have covered, might have covered this thing in your gastro classes, because they teach there only. Constructional apraxia. That was a right-sided angular-gyrus lesion, if you remember. Again, the parietal cortex. In these patients, if I tell them to join the dots together in a number fashion, 1, 2, 3, 4, 5 and 6, a normal person will try to make it like this: 1, 2, 3, 4, 5, 6, back to 1. But this patient, when I tell him to just join the dots in a serial order, this patient is unable to do that. He will just go this and this way. So he cannot do, or rather copy, I can use the word copy. He has to see and do this exactly the same. He cannot copy simple geometric images or figures like this. That's constructional apraxia. Okay. Hemispatial neglect means neglecting the half space. Again, a parietal lobe lesion is going to cause this problem. Neurofibrillary tangles are intracellular. Intracellular, inside the brain cell. Biopsy cannot be done ante-mortem, it's a post-mortem finding, but you should know about it. The neurofibrillary tangles often correlate with the severity of the disease. That means more the disorder, more the neurofibrillary tangles that you find. Apart from this, these neurofibrillary tangles contain a different kind of a protein within them known as the tau proteins. And don't forget, these tau proteins are something which are suggestive of S/O, suggestive of neurodegeneration. Neurodegeneration. Now, where else do we found the tau protein? Remember this. Tau protein are classically seen in patients with Alzheimer's disease, one disorder that you come across with. Okay. Another similar disorder that I'll deal separately today is frontotemporal dementia, a disease dementia with a frontal and temporal lobe involvement, FTD. Something from the previous season 1 classes that we had is a disease which comes under the heading of Parkinsonism plus syndrome. Yes, progressive supranuclear palsy. If you remember this, it was a disorder in which the person had an extended posture, defected downward gaze, history of recurrent fall. And one more thing, corticobasilar degeneration. If you remember this topic also, we have read this in Parkinsonism plus syndrome. It is a patient of Parkinsonism who comes to me with an alien limb. He cannot control his limb, it goes away, along with dystonia and myoclonus. That was CBD. So we have got tau proteins inside these neurodegenerative disorder. So all these disorders are coming under one roof as what? Taupathies. So let me write like this. There are disorders which are known as taupathies. Just parallel to it, you can write like this. Another disorder is known as the synucleopathies. If you remember, in Parkinson, we have written this and read it as well. There are Lewy bodies. Inside the Lewy body, there were alpha-synuclein. So, neurodegenerative disorder which happen to have alpha-synuclein particle are grouped into one term as these synucleopathies. Let me write this again. Taupathy, what disorder am I thinking about? Alzheimer. Frontotemporal dementia, corticobasilar degeneration, and PSP. Synucleinopathy, yes, has to be Parkinson disease, one disorder you know. Another disorder in the plus family, if you remember, was a Lewy body dementia, LBD. Parkinsonism with a dementia early onset with visual hallucinations and multiple system atrophy. Yes. Parkinsonism with autonomic instability, if you remember, with or without cerebellar symptoms, MSA. This has come this time in AIMS. This has come this time in NEET. This is a very, very commonly asked question in any standard examination. Don't miss it. Okay. The second thing that you find in the brain of Alzheimer is a term known as the senile neuritic plaques. Senile neuritic plaques being abbreviated as a term SNP. Senile plaques, remember them? They're found outside the cell. They are extracellular. Like the neurofibritangle happen to be intracellular, they're seen outside the cell. They're typically extracellular. And they often correlate with severity, with the age of the disorder. Like the NFT connected with the severity, the senile plaque, as the word senile, it correlates with age. Now, another term we can write here is cerebral amyloid angiopathy. Cerebral amyloid angiopathy is seen in these patients. Okay. As the word suggests, it's a disease in the vessel, angiopathy, due to amyloid protein in the brain vessel, cerebral amyloid angiopathy, CAA. Remember this, cerebral amyloid angiopathy can happen on two kinds of vessels. One is a large vessel and the second one is a small vessel. Large vessel, if at all is involved, the problem is going to be in the cortex, cortical. If the small vessel is involved, the problem is going to be below the cortex, subcortical. So we happen to classify our syndrome of dementia anatomically also as cortical or subcortical. I'll give you examples for them. Cortical dementia, the perfect example we just saw was Alzheimer. It was a disease of the cortex, the temporal parietal lobe, while the subcortical good example will be PSP, progressive supranuclear palsy. And another disease which can be subcortical is HIV dementia. Okay. Now someone asked me genuine doubts on what are tau proteins. Okay. I'll tell you this. What are tau proteins? You know, tau proteins are proteins present in any of the cell. Any cell can have a tau protein. The main function is to stabilize the microtubules inside the cell, which are important for the chromosomal transfer when the cell division occurs. Okay. Now in Alzheimer, remember this, the tau proteins are hyperphosphorylated. So the tau protein in Alzheimer patient is often hyperphosphorylated. So can they stabilize the microtubules? No. So there is no stability to the microtubules happening. So what happens? There is a cell death and the new cell is not forming now, because microtubules are important for chromosomal transfer while dividing the cell. But now the microtubules are not stable. They keep on jumping here and there. Okay. So hyperphosphorylated tau proteins are seen in these patients, and whenever you find them, you think about a neurodegenerative process. See how the vessel gets involved in them is like this, whatever the A beta cannot enter the cell, it will come and sit on a large vessel. and the large vessel will have amyloid protein causing a cerebral amyloid angiopathy. Fourth is a degeneration pattern which is seen typically in them, known as the granulovascular degeneration. So don't forget, granulovascular degeneration is seen in these patients very well. So the pattern of degeneration in the end seen in them is the granulovascular degeneration. Okay, age can correlate with the severity of the disease. Okay. Okay, neurons don't divide, but at least the new cell has to form if the old has gone away. The word division doesn't mean that the new cell will form another cell. When the cell death occurs, the new cell has to come up. Now, that won't come up so easily. PSP stands for progressive supranuclear palsy. Okay. HIV dementia is a term applied for dementia in HIV patient. Nothing new in that. Now, another thing, how do you go in for treatment of Alzheimer's disease? Everyone keeps on asking me, sir, when will you teach treatment? I said, this is something very small and already covered in Pharmac. But no one is accepting my explanation for this. So there's a term, or rather, a treatment which is not very effective, but still we found that could be given in them is a choline esterase inhibitor. Why? You know, in Alzheimer, there is a sequential degeneration in a structure known as nucleus bacillus of myelin. Now, the nucleus bacillus of myelin degenerates in them. Because of this, there is deficiency of acetylcholine. So, to preserve whatever acetylcholine is there, we can give an inhibitor of the enzyme which tries to degrade it, acetylcholine esterase inhibitor. Few drugs, if you remember, the names more than enough. Donepezil, okay, galantamine, and rivastigmine. So these are three drugs which can be used as a treatment for Alzheimer's disease. Okay, rivastigmine has been a drug which is available in form of a patch, while galantamine and donepezil are oral treatment. Another thing is NMDA antagonist. So any neurotransmitter which is excitatory has to act through this receptor NMDA. So you can inhibit this. There is another name drug here that's known as the memantin. So just remember the names more than sufficient for you. Okay. Another small topic to discuss here is frontotemporal dementia, FTD. The brother of Alzheimer may be a younger brother. Now, someone asked me this, what is the cause of death? Cause of death in Alzheimer very often seen is aspiration pneumonia. So remember this, the cause of death in Alzheimer patient is very often seen as aspiration pneumonia. So my patients of Alzheimer usually succumb to this problem. Okay. What is FTD, frontotemporal dementia, FTD? Another very commonly asked topic. Remember this, the onset of FTD usually happens at the 5th and the sixth decade of life. Like Alzheimer will come beyond 60 or 65 years, they come slightly early. Alzheimer, as I stated, was more frequent in females than males, while this wala is more frequent in males than females. Uh, in these patients, there is an autosomal dominant inheritance pattern seen in around 10% of cases. Now, this has been a recent MCQ in pathology. What are the mutations that they come with FTD patients? There's one mutation which comes on chromosome number 9, and another mutation comes on chromosome number 17. Remember, chromosome number 9 is the most common chromosomal mutation seen in them. Okay, and this mutation basically is for C9ORF72 gene mutation. This was a recent MCQ, that's why I'm taking this out separately. ORF, actually I could check in path books, was open reading frame. Okay, ORF. Basically, a gene mutation in C9ORF72 is going to cause GGGGCC expansion. Now look at this. What is this? 6 codons and anticodons together. 6 together is known as a hexanucleotide. So it is a disorder which comes due to not trinucleotide repeat sequence but a hexanucleotide repeat sequence defect. Chromosome 17 is having an MAPT gene mutation. Okay. Now, what are the clinical types of FTD? Clinical types of FTD. Types, clinical feature you can write, and the area involved in the brain. First type that you find is a behavioral type, behavioral variant. In the behavioral variant, remember this is the most common type of FTD that you find. Okay. In these patients you find apathy, disinhibition, so all kind of, in a nutshell, psychological symptoms are seen in them. See, the word is F, frontal. So there's a frontal lobe which is involved in these patients, that is the behavioral variant. That's the most common type. Okay. In these patients, don't forget, the area involved is the medial and the orbital frontal lobe. So frontal lobe is involved in these patients in the medial and the orbital zone. Second one is a semantic variant. Semantic variant. Okay. In semantic variant, the problem with the patient is cannot decode meaning of a word which has been told to him, or maybe an object name. Can you tell me, if I'm thinking about an aphasia at this point, which aphasia will have this kind of a problem? Cannot decode a meaning of a word or an object name. Can you tell me which aphasia will we have it here? I'm talking to a patient and the patient word or object name, whatever I'm telling him, he is unable to understand that word. If I'm thinking of aphasia in this way, what can be the meaning or kind of aphasia seen in them? Exactly an anomic aphasia. It's more nearby a Wernicke's aphasia. It's more nearby a Wernicke's because this patient cannot understand a command also. Anomic was able to understand what's going around him. Just the name of the object he cannot put me. Okay. So if it is somewhere near that, what area of the brain is involved? It's a temporal lobe. Temporal lobe. That's why it's FTD. Frontal, behavioral, temporal will have the semantic variant. And the third is a non-fluent or agrammatic variant. Cannot talk fluently. That means the patient will have what? Inability to produce word. Now, can you tell me if there's a problem here? What kind of aphasia am I talking about? What kind of aphasia am I talking about? Inability to produce word is Broca's aphasia. Yeah, so it is somewhere nearby that. Okay, so the lesion here is again the frontal. So frontal lobe lesion in these patients can result in an agrammatic variant in which the person cannot talk, semantic variant temporal lobe injury, patient cannot understand, or a behavioral variant in which the patient is totally disinhibited. Why am I taking out this topic? Because this year we found a question on this. There is a term known as primary progressive aphasia. When the students saw this term, they could not understand what have they actually asked. So someone tried to be smart there. He said it's a aphasic patient in whom the problem increases without any reason, primary. No, it's a very simple thing. Remember, in the patient there is aphasia, right? Without any kind of a weakness. That means if it is a left-sided cortical lesion causing aphasia in you and me, I'm going to bound to have a right hemiparesis. But this patient doesn't have any weakness, only aphasia is seen in him. Okay. Now this PPA or PAPA, okay, is of three types: semantic, agrammatic, and logopenic. Simple way to remember it: semantic type is almost similar to Wernicke's aphasia. Agrammatic type is almost similar to a patient of Broca's aphasia, and logopenic is between the two, conduction aphasia. So you come across a patient of conduction aphasia without any motor deficit, logopenic. Patient now is having a Wernicke's aphasia without any motor deficit, semantic. Patient is having Broca's aphasia without any weakness, is agrammatic. Okay. See, yeah, it is always kept as a separate entity. It's not mixed up with aphasia at all, right? Okay, I'll just take out the questions related to this topic, get wiser on them by reading MCQs. 80-year-old person has started forgetting names of familiar person and places. Okay, there has been no confabulation at all. Oh, confabulation, I'll come to that separately. It's a term which is applied for fill in the blanks. Whenever I'm having a memory loss, I'm trying to hide it from the people by telling a false story. Confabulation. He tends to forget whether he had his meals or not. Meals or not. Did the patient have it or not? Okay. He doesn't remember that. Clinical and neurological examination reveals no abnormality. That means doesn't have any hemiparesis, anything. CT scan of the brain showed the symmetrical enlargement of lateral ventricles with wider sulci. Okay. Can you guide me what is the best answer? Can you guide me what is the best answer? It's nothing but your Alzheimer disease. Okay, because this is something very typical for a patient with Alzheimer disease seen in them. They've got memory loss, right? They don't try to hide it from the people around them. Okay, 55-year-old male was admitted, found confused at home, lasting for 2 hours with no recollection of events on recovery. Read this question very carefully. See, wider sulci means that there is atrophy of the cortex and the sulcus and the gyrus becomes deeper and deeper. So this is a typical CT finding as well as the clinical presentation of Alzheimer. There should not be any confusion in this. Patient was found confused at home lasting for 2 hours with no recollection of events on recovery. He had similar episodes in past during the wakeful hours. When he was awake, he had the same problem. MRI, EEG and metabolic evaluation done recently was perfectly normal in these patients. The likely diagnosis, tell me. Now I'll repeat it. I had a patient at home. For next 2 hours, what happened with him, he doesn't remember. For 2 hours, who was he? He doesn't remember. If a patient comes to me with amnesia and doesn't remember what has happened with him, okay, and similar previous episode have occurred with him, what do I think about? This can be a post-ictal stage. If you remember, we have discussed seizure. Seizure patient doesn't remember what happens after starting of it, post-ictal, correct? So something which I understand, it can be a post-ictal amnesia in a patient of seizure disorder. Second, maybe at home he is alone. He had a transient ischemic attack which recovers in most of the cases in 1 hour time. TIA. TIA patient can also present with hypoxic injury like this. And then we have the metabolic. Yes. Why metabolic? For example, if anyone consumes alcohol, it's a very common scenario in hostels. People drink alcohol and they fight with each other. And next day morning when they meet the person whom they have fought last night, they always hug each other and say, "Tu mera bhai hai," because they don't remember what have they done last night. So after drinking, you don't really remember what blunders you have done. Again, a term applied for the anterograde amnesia. Okay. Now look at this. If I want to diagnose it as a post-ictal seizure, what are you going to do? EEG, electroencephalogram, is going to find it. If you want to get a TIA diagnosis handy, you have to do the MRI. Metabolic screening, a lot of things you can do in the labs to know is the patient consuming certain drugs or alcohol, something like this. So easily can be picked up from that. So what is the best answer? Let me go back to the question. A 55-year-old male admitted, count confused at home, lasting for 2 hours with no recollection of events on recovery. He doesn't remember what has happened with him at home. He had the similar episodes in past during the wakeful hours. His MRI is normal. If he was having a recurrent kind of a trauma, at least acute stroke on MRI you can find. MRI is normal. Focal dyscognitive is an old term for focal seizure with impaired awareness. EEG is another thing which is going to find this out. PAPA, primary progressive aphasia, is a aphasic patient, just an aphasic patient without any other disturbance. So it's not a PAPA. It's not Binod ke Papa. What are we having? Transient global amnesia, TGA. Let me take this like this now. For 2 hours, patient did not remember what happened with him. For 2 hours, he does not recall who was he. So he's having what? Anterograde amnesia as well as retrograde amnesia. Together we'll put it as global. In 2 hours time he recovered, okay, transient global amnesia, TGA. Okay, it's a very common scenario, like for example, you go for an exam and now suddenly when the exam starts, you're going to forget whatever you have read. So you suffer with retrograde amnesia first, and later on, whatever you keep on attempting in the paper, neither do you remember that. You suffer with what? Anterograde amnesia. And then you curse your memory power, that your memory power is so bad. You should have studied in done this and that. But the problem is your memory is good, but your acclimatization to that stress of examination is so poor that you fall short of your memory at that point. That is the transient global amnesia or the TGA. Okay. Okay. Neurophobic tangles are seen in cases of Alzheimer's disease. Which of the following area of the brain is resistant to the neurophobic tangle formation? Okay. Remember this, Alzheimer was a disorder which was seen as a cortical disorder. If you go back and see in anatomy books, the visual association area, the cingulate gyrus and the entorhinal cortex, all three of them are the part of the cortex. Can you guys tell me lateral geniculate body is located where? Just lateral to the medial geniculate body. But which structure is it located? Can you guys tell me? Yes, thalamus. And we have been following this fact that thalamus is a subcortical structure. Why will it get involved in Alzheimer? Simple. So we get a very simple answer or no hi-fi data attached with it. Which of the following chromosomal mutation is most common cause of early onset familial Alzheimer disease? Tell me chromosome number 14. Okay. A patient demonstrating the use of toothbrush at the level of chest. Please tell me what is this known as? Confabulation, hiding the fact, hysterexis, apraxia or hemispatial neglect. It is known as apraxia. Demonstrating the use of toothbrush at the level of chest. Can you tell me now? Is it ideomotor or ideational? It is ideomotor. Okay. It's known as the ideomotor type. A 45-year-old patient presents with behavioral abnormality with mild sensory loss. His acetylcholine level is normal. An MRI shows significant atrophy in the frontal and the temporal region. On biopsy, he is found to have tau proteins. Which of the following speech deficit is likely to be seen in the patient? First of all, can you guide me which disorder are we seeing? If it was acetylcholine low and acetylcholine normal. Acetylcholine low was a case of Alzheimer, yes. Acetylcholine normal is a case of what? Frontotemporal dementia, FTD. FTD has got a different problem with it, which is known as a primary progressive aphasia or PAPA. Now, agrammatic is Broca's almost equivalent, semantic is almost equivalent to one case, and logopenic is almost equivalent to conduction. Answer is all of the above. It can have any one of them. Even logopenic can happen in them. Okay. Just two short topics to be done. One is this Huntington chorea. Huntington chorea. Huntington chorea is happening due to a disorder known as the Huntington gene. And now what happens, there is a chromosome number 4, okay, which is on the short arm of it, having this particular gene with it. So on the short arm of chromosome number 4, this gene is being present. Now, what is this gene going to cause for me? It is going to cause trinucleotide repeat sequence defect. Now the nucleotide sequence which repeats very often in these patients is the CAG repeat. CAG repeat. We all have got CAG repeat with us, but in these patients we often find more than 40 repeats. So more than 40 repeats are seen in this patient, a trinucleotide repeat sequence defect. Now if the disease is there, it has to come down in a genetic format through a pattern of inheritance, that is autosomal dominant inheritance. Remember this fact. So CAG repeats are normal with all of us, but if they repeat more than 40 times, it will result in a disease, Huntington chorea, coming down through a chromosome 4 on the short arm. Okay, don't worry, we are just with the IT team noting down the spammers. They will not be allowed for the class tomorrow. All the best. Keep on spamming. 2 successive generations are affected in these patients. Okay, 2 successive generations are affected in these patients. Okay, first of all, to call a disease as autosomal dominant, 2 successive generations have to be affected in the patient. If at all, in autosomal dominant disorder, don't forget, if one parent is affected, then the chance of the disease in the further generation becomes 50%. That is in a ratio of 1:2. Okay, let me put this in a family tree: husband, wife and 4 children. Okay, if at all one parent is affected, in the subsequent generation out of 4, 2 are affected. That becomes a chance of 50% and a ratio of 1:2. If at all both parents are affected, then in that case, in autosomal dominant disorder, the chance of the disease is 75% in the ratio that we see as 3:4. Okay, let me put this in a family tree. Okay, oh sorry, that's maybe legal but not biological. Okay, if both the parents are affected, okay, then in the subsequent generation out of 4, 3 are affected. That becomes a chance of the percentage of the disease in the subsequent generation as 3:4. Okay, the chance becomes in a percentage format as 75%. Now apart from this, remember this fact: in Huntington chorea patient, lengthening happens. Some people must be looking at the emoji and must be worrying, yaar, I'm busy spamming, why did he, where is the joke? Keep on doing it, it's your loss. इसमें तेरा घाटा मेरा कुछ नहीं जाता. Lengthening. Now the lengthening is this, if you inherit the disease from father, as they mentioned, if you inherit the disease from father, okay, The subsequent generation, okay, I can write like this. I'll explain this in a different way. In lengthening, what do they explain is this: larger the defect, larger the defect, okay, more severe is the disease, one, and possibly early is the onset of the disorder. So if you get a defect of CAG repeat which is longer and larger, then obviously the defect will be more severe and it will come early in life. Now let me put this in a perfect example. Either I get the disease from father or I get the disease from the mother. For example, I'm just taking a general example. There are CAG repeats. The CAG repeats from father, for example, are just 400 and for mother is also 400. But in the subsequent generation, you know what happens? If you get the disease from the paternal side, the CAG repeat becomes 40,000. If you get the disease from mother, it stays at 400. So what do I find now here? In the subsequent generation, the CAG repeat is going to increase. Okay, in the next generation if I inherit the disease from the father. Now what is the meaning of this? If I get more larger defect or a larger number of repeats, the disease is going to be more severe and is going to come early in life. Okay, so you find like this: if you inherit the disease from father, the onset of the disorder is found to be early in life, early onset. Okay, this phenomena is put into a different term referred as a term anticipation. That means if the father is affected, in the subsequent generation we are going to have the disease in early phase of life or early onset. Okay, so lengthening is a cause, as you can see, and the anticipation is a final effect of it. Okay, clinically, when I see these patients, remember this clinical features. First of all, remember the bracket. The onset of the disease commonly occurs in a bracket of 25 to 45 years of age. That is a common bracket of these patients. Okay. There's no clear reason I could find in any book why it happens from the father. Okay, but it's just a thing that we could see. Okay. If you guys can tell me from genetics, which you are very good in, maybe you will get an answer from there, but I'm not that good in genetics, but at least this much I knew. Okay. Now clinical features, if I look at, is in a perfect triad like this. In this patient there is going to be chorea. Okay, it has to be an autosomal dominant inheritance, yes, with a memory loss which is known as a dementia. Chorea with ethitosis together. Okay, if you remember, chorea was a dance-like movement and ethitosis was a wave-like movement of the distal limb. Dementia is a term applied for memory loss that you find. Okay, so these are three things defining very well. Apart from this, don't forget seizure can also happen in them. Seizure is often seen in these patients, specifically if you inherit the disease from the father. Apart from this, in these patients, personality changes are also being documented. So personality changes are being seen in them, with seizure of course if you inherit the disease from the father. Okay. Okay, amplification occurs during spermatogenesis. Maybe it multiplies in spermatogenesis. Maybe that can be a correct reason. Okay, if there is chorea, please guide me on this topic from your long-term memory. I'll do the priming also. If there is chorea, tell me where is the atrophy in the brain seen at. Which part of the basal ganglia do you find the lesion to cause chorea? The priming for this is C for chorea and C for caudate nucleus. So the atrophy in these patients is typically found where? In the caudate nucleus. Very good. Guide me again, guide me again. If it is a movement disorder which is hyperkinetic, if it is a movement disorder which is hyperkinetic, which neurotransmitter is more abundant? Is it acetylcholine or is it dopamine? Yes, if the patient is found to be hypokinetic, there is a dopamine less. If it is hyperkinetic, dopamine is high. Okay. If dopa is high, what is low? Acetylcholine. Parkinson is just the ulta of it. No? Dopa low, acetylcholine high cause tremors. Dopa low causes bradykinesia. Along with this, there is also decrease in the GABAergic activity. Okay. But where? Where the caudate nucleus is staying. If you remember, caudate nucleus was basal ganglia. Along with putamen, it was staying where? Corpus striatum. Intrastriatal. Loss of cholinergic and GABAergic activity is found in these patients. A topic not to be mucked up. This is again a very frequently asked concept. I agree it's memory based, but by certain clues and connection with the priming, of course, you can recall it easily. Okay, there is deficiency of cholinergic and GABAergic activity intrastriatal in these patients. Treatment part. Either I can give a drug which can block the dopamine effect, dopamine antagonist, or decrease the dopamine formation in the brain, dopamine depleter. Dopaminergic antagonist that I know is haloperidol. Dopamine depleter that I know is tetrabenzene. Now please remember this fact, this has been approved treatment. The drug of choice in managing a patient of Huntington chorea has been always not haloperidol but tetrabenzene. Okay. Okay. Now we'll see another topic in a continuation. Okay. That is Wernicke's aphasia. Oh, not Wernicke's aphasia. Wernicke's encephalopathy. Acha, I'm not that bad a man. Do you want a break for 5 minutes? Do you want a break for 5 minutes? Endocrine started. Do you want a break for 5 minutes? Yes. Yes. No. Yes. No. I'll faint. We'll take a break for 5 minutes. I'm not asking for your kidney. I'm asking for a break which my paracentral lobule is telling me to take at the moment. Okay. So we'll take this as a small 5 minutes break, Swachh Bharat break through the guidance of the paracentral lobule. Okay. I'll see you back after 5 minutes. Wernicke's encephalopathy, a very important small topic commonly asked in exam. Wernicke's encephalopathy. In Wernicke's encephalopathy, remember this, there is always a predisposing factor for it. There is always a predisposing factor for Wernicke's encephalopathy to happen. Now the predisposing factors for Wernicke's encephalopathy disorder, okay, is number one, alcohol intake. Okay, and Among all the causes as predisposing factor, the most common happens to be the alcohol intake. Second, maybe collectively in one roof as some causes of malnutrition has been thought as a predisposing factor for this problem. Malnutrition in cases when the patient is vomiting a lot, hyperemesis, one. Maybe the patient is not eating too much of food, starvation. Uh, the patient is on hemodialysis or renal dialysis plan. Patient is a patient of cancer or malignancy. Patient is HIV positive, or maybe the patient has undergone a gastric bypass surgery. Okay, but gastric bypass surgery causing this problem and precipitating it is found to be very rare. The gastric bypass surgery, just to rewind back this topic, is a part of the bariatric surgery for weight loss being done. So most of the surgery books do write this topic as a bariatric wernicase associated with this surgery. Now, what happens in all these patients? Number one is the deficiency of the thiamine. Now, thiamine happens to be a vitamin B whose number is B1. Is found to be deficient in all these group of patients. And remember this vitamin B1 or thiamine happens to be a good friend to make few enzyme work. That means it's a cofactor for few enzymes like transketolase, pyruvate, dehydrogenase, and alpha ketoglutarate dehydrogenase. So these three enzymes, if you remember, are part of your glucose cycles in which they generate the ATP. Now what happens, because these enzymes are not working because the cofactor is missing for them, it will result in finally glucose accumulation. Now once the glucose accumulation happens, in these patients there is going to be a mitochondrial damage. Okay, mitochondrial damage. And finally this mitochondrial damage is going to cause neurotoxicity. Okay, so this is something that we understand. Why is this disease labeled under the heading of neurotoxicity or encephalopathy? Because of all this drama happening. But the interesting part about the disease is the clinical features. Yes, the clinical features of wernicase, every MBBS student remembers this topic because of the triad or the love triangle which defines wernicase encephalopathy. That's a very famous topic in all medical college hostels, the place in our country will like to go when the lockdown ends. Yes, people are giving me the answers. Very nice. The capital of Punjab known as Goa. The capital of Punjab. Because in Goa, English is spoken before 8 p.m. and in Punjab after 8 p.m. You know the reason why. Global confusion. Ophthalmoplegia. And ataxia. So these are the three symptoms that define this disorder very often. Now what do you mean by the word global confusion? In the word global confusion, the thing is like this: the patient is totally disoriented most of the time. Okay, and often the patient is inattentive also. That's the term global confusion, two symptoms. The word ophthalmoplegia in these patients will involve lateral rectus palsy. One, even conjugate gaze palsy is seen in them. Conjugate gaze palsy. As far as ptosis as a symptom in them is found to be rare. Not so very common, is found to be rare. Ataxia. Ataxia. Ataxia in these patients happens secondary to polyneuropathy and the cerebellar involvement. So cerebellar involvement, polyneuropathy are the two things which can cause ataxia in these patients. But if you plan for a Goa, I am very sure your Goa plan will fail. So for the Wernicke's also, only 1/3 of the patients with Wernicke's fulfill their Goa plan. That means this Goa triad as such, if you read, is only present in 1/3 of the patient. So even the Wernicke's Goa plan got failed. Apart from this, what are the sites which are typically involved in these patients? It's another very small but important topic. In these patients, we find periventricular lesions. Specifically, we find periventricular regions in these patients in form of some petechial hemorrhages. We find a periventricular lesion in these patients. That means I'm trying to consider this not as a periventricular like in patients of multiple sclerosis around the spinal cord and around the cortex. No, the periventricular here is somewhere around the third ventricle and the fourth ventricle. So around the third and the fourth ventricle, that areas of the brain will show petechial hemorrhages. And these petechial hemorrhages are seen specifically in the acute stages of the disease, not in the chronic form. Later on, that's why I'm putting an arrow now. Later on, these patients you find atrophy. Now, atrophy in these patients, in of course the chronic cases, is seen in the mammillary bodies. Okay, it's typically seen in the mammillary bodies in the chronic cases. So we find periventricular hemorrhages, petechial in third and the fourth ventricle in them, and atrophy occurs in mammillary bodies in these patients in the chronic cases. Okay, right. Thank you. Treatment of this disease is to replace thiamine replacement. There are various kinds of doses being associated with them. Yeah, bus sir. Even my family members are telling me bus kar. My dad just came and gave me a tea. Papa. Ek hai Papa. 100 mg thiamine is given to the patient intravenous most of the time initially. Okay. Remember this old concept. 100 mg thiamine given through the route IV. In these patients, when I give the first one to recover as a symptom in these patients is ophthalmoplegia. So do remember this ophthalmoplegia as a symptom, which is first one to recover in these patients. Okay. After ophthalmoplegia in these patients, in a succession we find ataxia to recover. After that, the global confusion or the psychosis will recover. Okay. Now, psychosis has been found as a symptom which can be persistent also in these patients. In spite of the thiamine replacement, most of them we find psychosis being present in spite of good treatment. Okay. So first symptom to recover in these patient is the ophthalmoplegia, followed by ataxia, and then final last psychosis, which could be persistent in them. Now I remember this case because I've seen this very often in my emergency duty, especially on a Saturday night. And a young alcoholic after a binge drinking and a party came to our emergency vomiting. And when he came to my emergency, he was having a typical the corona, or not the corona, but the economic warrior or the broad-based gait. And he was having some eye movement here and there, ophthalmoplegia, and he was totally disoriented. But as a protocol that we follow in our emergency room is to check the random sugar of any patient who has come to us with the vitals. So we checked the RBS with the blood glucometer, and we found that the RBS of the patient was low. And I thought every drama of confusion and all this is hypoglycemia related. So I gave him a dextrose. And to my surprise, his confusion did not improve. It started worsening with time. The only drama or the only mistake or the biggest mistake which I did was this: glucose infusion. So remember this, write this down. Glucose infusion can precipitate wernicase. Why? Because if there is a thiamine deficiency and you give a glucose or a dextrose solution, suddenly the glucose in the brain will rise and more neurotoxicity will happen. So it's always a mandatory thing whenever an alcoholic comes with any kind of a disorder, always give a thiamine followed by a dextrose infusion. Okay. Now the elder brother in the family that we are trying to understand is the Korsakoff psychosis. Korsakoff psychosis. Korsakoff psychosis, the patient suffers with memory loss, that is dementia, with a simple concept of confabulation. Like this patient suffers with a memory loss. And now in this patient, he has got a habit to hide the memory loss by a false story. For time like 2 or 3 hours, he'll forget what he has done. Now suddenly, to hide it from the people around him, he will tell a false story. So people believe him that he was totally normal in this time. So confabulation is a term applied for false story to hide the memory loss. Okay. Now, what are the sites involved in them, and what is this circuit known as the Pape's circuit? Pape's circuit. There is a mammillary body in the circuit to begin with. Write it down. Then the anterior nucleus of thalamus comes in. Then we have the cingulate gyrus. And then we have the entorhinal cortex. Then we have the hippocampus. And there's a connection of mammillary body with hippocampus through the fornix. Oh my god. So if you can remember it, it's okay, fine, no problem, but at least know this fact. In patients of Korsakoff psychosis, okay, the lesion is found in which part? Thalamus. So thalamus is involved in these patients, which is a leading cause of memory loss in these patients or dementia. And this circuit, which is supporting my memory, has been lost, known as the Pape's circuit. Okay. Normal pressure hydrocephalus. Normal pressure hydrocephalus. Someone is writing, sir, nothing is going into the brain. Two dry topics. Arey, I served you alcohol just now. I took you to Goa. Your plan got cancelled. Why it is a dry topic? It's such a nice topic. See, Wernicke's and Korsakoff is a progressive disease. First Wernicke's happen. If left untreated, undiagnosed, it will go to the stage of Korsakoff. Okay. Normal pressure hydrocephalus is treatment is same. NPH. Okay. Normal pressure hydrocephalus is a very simple thing. We try to see the CSF pressure this time. The normal CSF pressure that you find is in the range of 50 to 180 centimeter of water. Now I am taking this as centimeter of water. Okay. In patients of NPH, it rises and becomes 150 to 200. Just a second. Just a second. Just a second. Excuse me for a second, please. Pen has got finished. Sir is not going to leave us till he completes. जो कमिटमेंट कर दिया फिर तो मैं किसी भी स्टूडेंट की नहीं सुनता. Normal pressure hydrocephalus NPH is something in which the CSF pressure rises with hydrocephalus in the range of 150 to 200, not very high. Okay, so it's a high normal figure. Now don't forget this concept. Whenever you have CSF pressure rising anytime, the major deficit is decrease in CSF absorption. Okay, and why does it happen really? It happens due to two major reasons. One is subarachnoid hemorrhage, in which the blood collects at the arachnoid villi and now CSF is not getting absorbed. Second is infection, meningitis, with inflammation in the brain, okay, which happens in them. Now, clinical features of this patient is very simple to remember. Try it again. Yeah, that's very good, sir. And the mnemonic to remember this is a good triad. G stands for the gait ataxia. U stands for the urinary incontinence. Okay. And D stands for the dementia or the memory loss. So these are three symptoms that define this disease very well. Good triad. Okay. There's another extra thing to note here which has been asked 2 years back is a gait which is found in these patients known as the magnetic gait. Why is it known as magnetic? I'll explain to you. In these patients there is an external hip rotation which is seen. External hip rotation that is seen. With low ground clearance and shorter strides. So low ground clearance, external hip rotation and shorter strides are things which are seen specifically in these patients with the magnetic gait. Let me show the video related to this so you'll understand it better then. So the chai wala is back. Oh, chai se yaad raha, Papa. Yeah. This is something that I'm trying to stick my foot on the floor all the time when I'm walking, as if someone has stuck a magnet below my feet and it is coming down, because Earth has also got a magnetic field. That with physics I know. So this time you can see me, I'm walking with a shorter stride, with a low ground clearance and maybe an external hip rotation, like someone has put a magnet below my feet. Okay, the magnetic gait. Okay, now what is this gait? What is this gait? This is I'm trying to cause the right leg in front of the left in front of the right. Yeah, like a scissoring gait that was seen specifically in patients of spastic CP, spastic cerebral palsy. Okay, right. So we have got a patient with NPH with a good triad with all these symptoms together. Just a second. Now, how do you go in for treatment of these patients? Treatment of patients with NPH. In patients of NPH, how do we go and treat them? First of all, we go and do a Miller-Fisher test. Suddenly, I show a live video, you all get excited. Ah, kitna acha. And when I start writing something and make you write notes, you feel very boring. See, in exam, only boring questions will come. One, and there is no one to entertain you there. So at least for a span of 3 hours, make it as a habit to sit down in the classroom that we are trying to prepare you for the exam. Okay. Miller-Fisher test. Miller-Fisher test is being done in patients of NPH. How do we do this test? We do an LP in these patients and we drain around 30 ml of CSF. When I do the LP and I drain out 30 ml of CSF in these patients, I look for two things. One is ataxia, and the second one is the dementia part or the understanding part, cognition. If in these patients ataxia and the cognition starts improving, we will drain the CSF from the brain into a place, peritoneal cavity, where it is 100% absorbed, known as a ventriculoperitoneal shunting, being abbreviated as a term VP shunt. Okay, so this is how we go and do this. Now, VP shunt should be done or not is basically decided through the Miller-Fisher test. Remember this, when you do a VP shunt in patients of NPH, the first thing to show an improvement is always a gait ataxia. Is always a gait ataxia which starts improving first in a patient of NPH when you do a VP shunt surgery. But to do or not is decided by the test named as the Miller-Fisher test. Okay. Picture अभी बाकी है. A family consists of husband, wife and children. Wife's father has got Huntington's chorea. I'll explain this in a very simple family tree by making it. You'll answer it easily then. It's a very easy and old question. Keeps on getting repeated. Not husband consists of. The family consists of husband, wife, and 4 children. Okay. Wife's. Oh, what am I making? I'll make it separately. Husband, wife, and 4 children. Okay. The wife's father is suffering with Huntington's chorea. Right? Which of the following statement is true? Chance of getting this disease is 1 is to 4. True or false? If one parent gets affected, the chance of the disease in the subsequent generation, yes, is 1 is to 2. Okay, if one parent gets affected, autosomal dominant is 1 is to 2. Right. If father is affected or mother is affected, okay, then in the subsequent generation is again 1 is to 2. So if you are trying to apply the law of probability, so all the Shakuntala Devis in the batch, let me tell you, please don't apply the law of probability from this generation to this generation is 1 is to 2. In the subsequent I'll make 1 is to 2, 1 is to 2, that is 1 is to 4. No, so Shakuntala Devi is wrong at this point. This is genetic, not maths. Okay, can occur up till age of 50. Yes, it can happen, but if the father is affected, then the mother will be affected at an early age. That is anticipation, right? So it's not a very correct statement, but if at all the mother is affected, if at all the mother is affected, then the subsequent generation can catch the disease later on. It's agreed. Okay. Huntington chorea is due to point mutation in the gene. No, that's not a very correct statement. If wife does not get the disease till age of 50, children are not affected. Now look at this option C. What is option C talking to me like this? If mother doesn't get the disease till age of 50, her brother and her sister has got it. Okay, equally divide in the family. Should be no nepotism in this. Okay, so if at all she doesn't get the disease till age of 50, her brother and her sister would get it. Okay, so this is something that you find in this patient. If the wife does not get the disease till age of 50, her children are not affected. The upper limit can be 45 or 50, but if she doesn't get it, her children are safe. Her brother and sister got it. The correct answer is C. A wife of a 48-year-old male patient brings him to the emergency room. Now be careful, the male patient has been brought by his wife, something serious to deal with. She says that his memory has progressively gotten worse over the last several years. My wife also has the same complaint. Yeah, there's nothing new. She also says his personality has been changing. It's a very obvious thing. Physician notes abnormal writhing movements in the man's limb. Now, this is a writhing movement, if you remember, athetosis. MRI reveals a loss of volume in the neostriatum. The disease is inherited via. Okay, look at the triad now. There is a athetotic kind of a movement in the patient with memory loss, dementia. Which disease are we thinking about? Huntington chorea. Via which inheritance pattern? Autosomal dominant. Look at this question, my dear friends. It's an easy question at this point only because anterior and posterior are only questions of Huntington. But my dear friend, if this question comes after a biochemistry question before a community medicine question, will you answer it like this? No. So try to catch the key words and find the correct answer. This easy way. If Huntington disease is inherited from the mother, which of the following is true? Early onset disease? No, that comes from the father. Seizures are more frequent? No, that again comes from the father. Mitochondrial inheritance. Someone told me, sir, M for Ma, M for mitochondria. Ma mati manush mitochondria. No, it's not mitochondrial inheritance anytime, it's autosomal dominant inheritance. So the answer is none of the above. The most tricky option. Okay, not mitochondrial, my dear friend. It's not mitochondrial mother. No, nothing related to it. It's not Ma mati manush mitochondria. Bengali students in the batch know the joke. 60-year-old alcoholic male presents with urinary incontinence, abnormal gait, and loss of memory. Join the triad. It becomes nothing but a good triad of NPH. Why I've discussed this question? Because alcoholic male, the moment you see alcoholic male, you send him to Goa, but this is not the Goa triad. Not every alcoholic is bad. There are some good alcoholics also, like in cases of NPH. Okay. In a patient with Wernicke's, oh, people are marking Wernicke's encephalopathy. Shabash. In a patient with Wernicke's encephalopathy, which of the following symptom is likely to persist in spite of thiamine therapy? Confusion. Confusion. Tomorrow morning 9 a.m. when we start the class, we are going to start with a fresh topic. Another very important topic, the topic of the century of the decade, which students take more than 1 year to understand, spinal cord. Let us see the trailer of the spinal cord chapter. If you see the trailer, you will understand the movie better. Otherwise, you will not understand it at all. Okay? Why are you telling me thank you? I am not leaving you. I am there with you. Okay? Class is not over. Class is going on at the moment. Okay? So please don't, right? Oh, why are you saying thank you? I am still there in the class. I am not leaving. Spinal cord. It's going on. Don't leave. Don't log out. Idhar. No thank you. Spinal cord. Introduction part we'll see. I am not leaving you. Stop. Stop. Hey, बदमाश बच्चे. Spinal cord. मेरी क्लास जल्दी छोड़ के जाओगे, बड़ा पछताओगे, बड़ा पछताओगे. Spinal cord. No thank you for me. Please, please, please. Spinal cord, remember, class is going on, please. Arre. Spinal cord. Oh, where are you going? Stop. Not by. Spinal cord is a structure which is taking up a signal sensory and taking down a signal that is motor. So basically, sensory tract which is ascending and the motor tract that is descending is going through the spinal cord. Now, what are the tracts which are ascending? Number one is the spinothalamic tract. Spinothalamic tract. Oh, no, thank you, no, bye, come back. Hey, bye. I'm there. Spinothalamic tract. Remember the tract spinothalamic is conveying 3 impulses to the brain. One of the impulse it tries to take up to the brain is a signal of pain. A signal of pain. Second one it tries to take to the brain is a signal of temperature. And the third is crude touch. So the signal it tries to take to the brain is temperature, pain, and the crude touch. Remember this. Okay. Now, how does it go to the brain? This is something very, very, very important to read and understand. If I want to see a transverse section of spinal cord, the sensory input comes into it through a sensory nerve, pain, touch, and temperature. Okay. Sensory nerve through the dorsal root. And now when it comes in, it crosses the midline. Now this is important. I'll just draw it in a different way so that it's easy to understand. Just a second. Why this is hanging every time? I'll just restart it. No thank you, no thank you. I'm there. Where are you going? It's on right now. See, God is with me. He wants me to teach you guys spinothalamic tract, that is going to the brain taking a signal of pain, temperature, and crude touch. Okay. Now for this, we need to go into the basic. How does this track go up to the brain? So if I want to see this track, when it is moving up in the spinal cord is like this. The spinothalamic tract, every time when it moves up to the brain, it comes through the dorsal root or the sensory root, right? It comes to the dorsal or the sensory root. It goes up a segment. It crosses the midline, and then it goes up like this. So we find that the crossover of the spinothalamic is not happening at the same level it enters. It happens one segment above the point of entry. So if I want to see the signal of pain, tension, temperature, spinothalamic, it is going to cross the midline in the interior half of the spinal cord and go up like this. But it will not reach thalamus so directly. It will go through this part, the brainstem. Brainstem has got 3 floors. The ground floor goes with the medulla. Then we have the pons, and the topmost floor belongs to the midbrain. And then finally we have the sensory gateway with us known as the thalamus. Now remember this old fact that whenever the signal is going up in the brainstem and it has crossed the midline, we know these as a bundle of fibers, white matter bundle fibers. Yes, this is known as the lemnisci. So there's a lemniscus which is passing up like this, known as the spinal lemniscus in the patient, which is taking up the signal of pain, touch and temperature in the brainstem from the opposite half of the body. And when it reaches the final destination, thalamus, it has to stop in the nucleus there. And the nucleus in thalamus is ventro-posterolateral nucleus. So VPL, or the ventro-posterolateral nucleus in thalamus, is there, which is going to receive all the signal. Okay. Lateral lemniscus reh gaya. Somewhere I forgot lateral lemniscus. You keep on writing so much, I forget things. Where is lateral lemniscus seen? Any guesses? Someone indently write it. Lateral lemniscus is a part of the lemniscus system of auditory pathway. When it was crossing the midline and trapezoid body, pons, it was going up in the lateral part. So this one was a lateral lemniscus. So lateral lemniscus, we'll write it somewhere again, is a lemniscus for the auditory pathway. Yes, this is the spinal lemniscus. Now pain, temperature, remember, is going to the brain through the lateral spinothalamic. And the crude touch is going up to the brain through the anterior spinothalamic. And there is another funda in this, somewhere they write in the book also that whenever the spinothalamic is going to the brain and it is going with a signal of pain and temperature, the pain signal is found lateral and the temperature signal is seen medial to go up. So whenever we find the signal of pain and temperature together in the lateral spinothalamic tract, the signal of pain is going lateral to the signal of temperature. Now what is the clinical relevance? If I want to decrease the pain signal from any body part, I can cut the spinothalamic tract in the spinal cord in the lateral part. And we'll discuss this topic tomorrow, that there is a disease known as syringomyelia which originates inside the spinal cord. If it expands, which fiber will it catch first? Pain or temperature? Temperature fibers. So there is a disorder which comes in the spinal cord from outside and a disorder which tries to grow from inside. One which comes from outside will affect the pain fibers first. One which grows from inside will affect the temperature fiber first. Okay. Now what we will do to understand a easy topic, I don't know why is it so difficult for everyone, we'll make 3 transverse sections together. three transverse sections together, one above, one below, and then like this. I'm going to arbitrarily name them as T3, T4 and the T5. Okay, so what do you find is the spinothalamic. The spinothalamic tract, which has come with a signal from the T5, is going to move up, cross the midline in T4, and then it will finally reach the thalamus. Spinothalamic tract of T5 segment, right? The spinothalamic of T5 from the other end is going to come in, is going to go up, cross the midline in T4 and go up like this. Okay, so please draw the diagram. In case you are lost somewhere, you can follow the arrows. Spinothalamic enters, goes up till T4, crosses the midline and then goes up from this side and this side, both the sides. So nothing new, same thing again in a different way. I'm trying to arrange the three segments and how is the relation of spinothalamic tract in them. Now there is a spinothalamic tract of the T3 segment also. As you easily understand, the spinothalamic of the T3 segment is not going to cross in T3, it is going to cross in T2. Same goes here now. The spinothalamic of T3 is not going to cross in T3, it's going to cross one segment above in T2. Why am I drawing this one? Because if you get a hemisection in the T3 segment, tell me please, if I get a hemisection in the T3 segment, in this part, the spinothalamic of the T5 segment will be lost on which side? Same side or the opposite side? Please tell me. IL ipsilateral or CL contralateral? My question is, if there is a lesion in spinal cord in the thoracic 3 segment, okay, then the T5 segment spinothalamic will be lost on which side? Ipsilateral or contralateral? Contralateral, simple. Because if these fibers are getting crossed here and they're going up, these are lost. Well, as you can easily see, this one is escaping out the whole drama, contralateral. Okay. But please tell me if there is a lesion in T3 segment, the spinothalamic tract of T3 of which side is affected? Ipsilateral or contralateral? T3 wala. Now please tell me about T3. The spinothalamic tract will be affected on which side? T5 spinothalamic. The T5 spinothalamic is affected on the opposite side, contralateral, CL. T3 spinothalamic tract, yes, is affected on the same side, ipsilateral. Okay, good, you know it. Happy. Mugambo khush hua. So I'll teach more. Now, another ascending tract that you all should know about is the posterior column, also known to me as a dorsal column. Posterior dorsal column, if you remember, is taking up the signal of vibration. Okay. Proprioception, that's another term applied for your joint position sense, and of course the fine touch. So the crude touch is a thing that goes up to the brain through the spinothalamic. Fine touch goes to the brain through the posterior column. Now let's find it out. Okay. Now the posterior column will come with a signal. It will come with a signal from the lower limb and the signal from the upper limb. If you remember from basic anatomy again, the signal for the lower limb is coming as what? Fasciculus gracilis. Signal for the upper limb is coming through which fascicle? Fasciculus cuneatus. The gracilis muscle is for the lower limb The cuneatus, there's no muscle in the upper limb, but the C word goes with the cervical. So look at this arrangement. The lower limb fibers are medial, the upper limb fibers are lateral. Fasciculus, gracilis and cuneatus. It will go up. So write it again. Fasciculus gracilis, fasciculus cuneatus. Everything is going to end at a point. Nucleus gracilis and nucleus cuneatus, right? And happily it will all cross the midline and go up. Go up through what? The brainstem, the lowermost part medulla, the middle wala is the pons, and the topmost floor is the midbrain. And remember this, when it goes up, the fiber or the bundle of fibers which are white matter axons, yes, which will travel up with the signal. Can you tell me the name? Yeah, medial lemniscus. Medial lemniscus. It will finally reach a point again in the thalamus. The nucleus sitting over there is the ventro-posterolateral, and then finally it will go to the brain cortex. See, the main intention of drawing this diagram is very simple. You know this from anatomy. If there is a lesion in the midbrain, pons or medulla involving the medial lemniscus, the vibration, fine touch and joint position is lost on which side? Contralateral. But if at all there is a lesion in the spinal cord, the vibration, joint position, sense will be lost on which side? Same side, ipsilateral. Let me put this into a diagram like this. If I want to make this as a posterior column of T3, this wala is a posterior column of T4, and this wala is a posterior column of T5. So if I have a lesion in the spinal cord in the T3 segment hemisection, the posterior column at the level of the lesion as well as below the level of the lesion, you can easily see is lost on which side? Same side. So you can write there, posterior column at the level of the lesion is lost on the same side, ipsilateral. Even in the T5 segment, it is lost on the same side. That is known as the word ipsilateral. Yes. A good teacher is a one who teaches. Intelligent teacher is a one who cracks joke also. And the best teacher is a one who leaves you before time. I promised 9 p.m. I'm leaving you at 8:30 p.m. Okay? So namaskar. We'll start from here tomorrow and we'll see this Bahubali Part 2 movie Spinal Cord. Okay, I'll continue tomorrow. Continue, sir. Some people ask me to continue. Okay. What will happen in T4? I'll ask you guys tomorrow. Okay, good night and sleep tight. Okay, and I have to go and watch the entertainment channel tonight. That is Republic TV. It is an entertainment channel for us. I have asked Tata Sky to shift Republic TV into entertainment segment. Okay, chalo. So good night to all the students. Okay, see you tomorrow at 9 a.m. Right. I'll post the questions on Facebook tonight. I'll just make a thing on it and I'll post it on Facebook. You'll get it. So, night.